Morning, everyone. We're about to get started. Can I ask the two presenters who are in the room to please join me? So that includes Dr. Julia Ro. He's online, so I'm just waiting for him to pray. Morning, Mr. Gooden, please go ahead.
Okay, morning. All right, let us just unite our hearts in prayer. Heavenly Father, blessed Savior, as we come before you, dear Lord, because of your mercy, because of who you are. Heavenly Father, as we are in this National Health Research Conference, Jehovah God, we pray for your coverage, we pray for your peace, we pray for your intervention, and we pray for your capacity to lead the different aspects of this conference. Heavenly Father, the different groups that come together to make this conference possible today, Jehovah God, from the ministerial head, from the permanent secretary to the CMO, to the different administrative staff, to the different doctors in their different capacities. Heavenly Father, I pray for a special touch upon this conference, Jehovah God. Let it be a conference like none other. Let it be a conference where newness is birthed, where new understanding is birthed. Heavenly Father, let it be a conference that whatever is discussed, Jehovah God, shall come forth and bear life. Heavenly Father, as the team is combating non-communicable diseases, dear Lord, for a desire for a healthier future, a healthier Jamaica. Heavenly Father, I pray that this reality will come to pass. Heavenly Father, I pray, dear Lord, that the proceedings of today will be done to your honor and to your glory. Mighty God, comfort the hearts at the table of discussion today, Jehovah God. Let there be no anxiousness, Jehovah, but let there be a responsiveness to get things done that should be done. Heavenly Father, we just want to thank you. We just want to praise you. We just want to lift you up. We thank you for giving us this opportunity to intervene in the affairs of our people, of our nation. Jehovah God, let your will be done. Let your will be done. Mighty God, we thank you for giving us the wisdom to even incorporate prayer into such a conference, Jehovah God. Heavenly Father, let not self go before, but let your will. In Jesus' name we pray. Amen and amen.
Amen. Thank you so much, Mr. Gooden. So welcome again to everyone, both present in the room and those persons online, to our second day of the 13th National Health Research Conference under the theme, Combating Non-Communicable Diseases, Looking to a Healthier Future. I have a few house announcements before we proceed to the presentations. We want to encourage all our attendees to use the conference webpage tabs. Ensure you enter the poster hall and ask poster presenters on the poster hall any questions you may have so that they can provide feedback. Make use of the network tab chat room to ask questions and interact with other attendees as well as presenters. Post your questions for the presenters in the networking tab chat room as well. We encourage all oral and poster presenters to log on when they are not presenting and use the networking tab as well. Attendees can interact and ask questions directly to our oral and poster presenters. So now let's begin scientific session number 3, non-communicable diseases and maternal and child health. We have 4 presenters in this section. We'll go with the first 2, after which we'll take questions and answers, and then we'll end the session with the last 2 presentations. The first presentation will be a recording done by Mrs. Patricia Whitehorn-Smith, who is currently completing her doctoral degree at Curtin University in Western Australia, where she's a recipient of the prestigious Australian Government Research Training Program Stipend Award. Mrs. Patrice Whitehorn-Smith has over a decade of experience working on the development and implementation of regional and national level research projects in the areas of maternal health and substance misuse. So let's pay attention to the screen while Mrs. Smith gives her presentation.
Good day, colleagues. I'm Patrice Whitehorn-Smith, and today I will be sharing results from our study entitled Exploring Comorbid, Severe and Enduring Mental Illnesses and Chronic Physical Illnesses among patients attending community mental health clinics in Jamaica. Now, there has been a significant body of research globally that has shown that persons with severe and enduring mental illnesses tend to be at increased risk of developing chronic physical illnesses or diseases. And as such, they have poorer outcomes as it relates to shorter life expectancy and higher mortality rates than people in the general population or people with just a chronic physical illness. And there have been a number of factors that have been identified that contribute to persons with severe mental illnesses developing chronic disease, as well as having these increased risk of poor outcomes. And one of the key things that has been linked to it is poor health system practices as it relates to screening and management of these comorbid illnesses in this patient population. So for our current study, we really wanted to understand if in the Jamaican context, there was a high prevalence of chronic physical illness among persons who have severe and enduring mental illnesses, and also to describe their experience. So the focus of the study was really on the patient reports and experience of their illnesses and their experience with screening and management within the health system. Now, this was a cross-sectional study done via survey. The surveys were researcher administered, but based on self-report from patients who attended mental health clinics. The relevant permissions and ethical approvals were granted, and patients provided written informed consent for participation. Now, to attract a representative sample, we needed a target sample size of 380 persons. And what we did was use a cluster sampling method, which involved getting a listing of all the operational mental health clinics within the island, and using a systematic cluster sampling approach to identify clinics throughout the island that would attract our sample size. Prior to being able to attend these clinics, we would arrange dialogue and contact with the clinic coordinators to sensitize them to the study, as well as attend the pre-clinic sessions where the patients were attending, sensitize them to the study and seek their willingness to participate. Now, for persons to be included in this research, they needed to have a previous diagnosis of a severe and enduring mental illness, meaning that this was not their first time at the clinic. They actually had received a diagnosis before. They needed to be 18 years or older and hadn't had a psychiatric crisis in the last 7 days. And we pre-screened. We had pre-screening questions to rule out that. Now, there are a number of factors that resulted in us not being able to achieve our full sample size. One of the factors being that we collected data around the time of the COVID-19 heavy restrictions in 2020. And so clinic attendance was lower than was projected. But we ended up with a sample size of 306 participants, of which 57, almost 59%, 58%, were males, and 42% were females. And the age ranged from 19 to 80 years, with the mean age being about 46 years. Most persons we spoke to had a psychotic disorder, and we're going to talk a little bit more about that in a bit. And the length of diagnosis had varied from 4 months to 50 years with their severe and enduring mental illness. Interestingly, almost 29% of participants reported that they also had a chronic physical illness. And among this group, more females than males reported having this illness. Now, when we talked about the severe and enduring mental illnesses, we notice here that a little over half of persons reported having schizophrenia. So these patients were able to identify that they had schizophrenia. And this was based on looking at their medication or being able to say that that's what they had. But you'll see a very large amount, 34%, did not know what their diagnosis was. In these cases, they would say, I have a nerves problem, or them say me mad. These are the type of things that the patients would say. So when we talked earlier about 91% having a psychotic disorder, we had to, as a research team, improvise to try to assess what the diagnosis could be. And so we had a consultant, a psychiatrist on the team who would, we would get the description of the medications or the names of the medications, and we're able to go through the persons who were not clear on their diagnosis to get some background on symptoms and on symptoms and on their prescribed medication to be able to find out if it was a psychotic disorder or not. We didn't want to over specify in that realm, as it wasn't clear beyond that. So this was an interesting finding for us. So throughout the clinic, schizophrenia was most prevalent. Among persons who reported having a chronic physical illness, you'll see that diabetes and hypertension were the most common, with hypertension being present in more than 53% of our participants. Other illnesses were prevalent in less frequency than hypertension and diabetes. Okay. Now, most of our patients were able to say that they had a chronic physical illness, only one, while a few had 2 and 3 and 4, but 86% of persons only had one other illness. Now, by age group, the age group that showed the most frequency of comorbid chronic physical illness and severe and enduring mental illness were those between the ages of 51 to 60 years old. So we want to pay attention to persons in this age group. In terms of length of time for the diagnosis of a chronic physical illness, some persons had just recently been diagnosed, less than a month, and others for up to 57 years. So the mean age here was 12 years was the mean length of that diagnosis. Now this table shows a comparison between those with a chronic illness, physical illness, and those without, and if they had received these type of screening practices. And we see here that there was significant difference shown between those with a chronic physical illness and those without, and some key areas of screening. So those with a chronic physical illness, they were more likely, it seems here, to have a physical exam in the last 6 months, have their weight checked regular and blood pressure, as well as being encouraged to exercise and have a balanced meal. So once these participants were known to have a chronic physical illness, it seems that they received continued monitoring and screening more than those who were not known to have this illness. Interestingly, there was no difference between the measurements for cigarette use. So that one was not significant. Now, as it relates to management factors, when participants were asked if their illness had been explained to them in a way that they understood, 54% of them said no. And their psychiatrist or mental health nurse would ask about chronic physical illness, even though sometimes this wasn't done regularly. It's noteworthy that they felt that their complaints were taken seriously by doctors and nurses, and that they also had a good experience with doctors and nurses. So when we think about the implications of this research, it's important that we recognize that we had a high prevalence of comorbid, severe and enduring mental illness and chronic physical illness, with almost 3 in 10 participants reporting having both 2 or more conditions. It's also important to note that there are measures in place for screening and monitoring of chronic physical illnesses within our community mental health setting. And although this is done specifically for persons who have a recognized diagnosis already of chronic physical illness, there needs to be more consistency in monitoring those who do not yet have a diagnosis of a chronic physical illness, so that these can be caught early. So it's not enough to just look at those who we already know are at risk, but also to make sure there is proper early detection strategies for those who have not yet presented, especially with the risk that psychotropic drugs pose to the development of these metabolic syndromes. There also needs to be improved screening for cigarette use, which we know is a major risk factor for the development of CPIs in this population. And the issue of education of patients as it relates to their severe and enduring mental illness is really important, and how the two disorders can interplay to produce, more serious outcomes. It's really important that patients understand what is happening to them and can articulate in a way that they understand what their diagnosis is and what the treatment options are for them. Still, it is very much of great note that within our health sector, patients and our participants believed that once they do come forward with a complaint, the doctors and the nurses are willing to listen and are willing to investigate what's happening with them, which is a significant finding, as in many contexts, this is an issue. So in conclusion, I'd like to acknowledge those who contributed to the preparation of this research and presentation, which consists of my supervisory team, as this is a part of a bigger doctoral project. I'd like to recognize them for their contribution, for those who participated in the actual data collection, for the Australian Government Research Training Program, stipend scholarship, and the Department of Community Health and Psychiatry that helped to fund the research. So I'd like to express sincere thanks to everyone who made this study possible. And thank you very much. And I hope.
So thank you, Mrs. Patrice Whitehorn-Smith, who sent her pre-recorded presentation on exploring comorbid, severe, and enduring mental illnesses and chronic physical illnesses among patients attending community mental health clinics in Jamaica. Let me now introduce Dr. Carol Lord, who is in her final year of the Doctorate of Public Health program at the University of the West Indies. Dr. Lord has authored and co-authored research papers in infectious disease, pediatrics, and maternal health. She currently works at the Family Health Unit as the National Coordinator for Maternal and Neonatal Health and is the chair of the Sickle Cell Technical Working Group. Dr. Lord will be presenting her research on a 5-year review of maternal and fetal outcomes for women with hypertensive disorders in pregnancy at public hospitals in the Southeast Regional Health Authority in Jamaica. Please welcome Dr. Lord.
Okay, good morning. I would just like to thank the organizers for allowing me to present on this. This is actually a part of a 5-year review of maternal and fetal outcomes with several authors from the ministry, UE, and Southeast region. So I'm going to do the overview of the presentation. Is the aims. We're going to look at the aims, which involve an objective. Sorry, that's an error. We're going to look at the results and the conclusion. So this presentation actually, hypertensive disorders of pregnancy is classified into 5 categories, with the presence and absence of proteinuria being the separation between each level. Hypertension, part of the chronic disease. So preeclampsia is actually a multisystemic, multifactorial disease in a previously normotensive person, woman, and is characterized by blood pressure of 140, greater than 140, with over 90, taken on 2 occasions, at least 4 hours apart. And whereby they will have proteinuria. We find that persons with hypertensive disorders in pregnancy, can't see there, can actually have prolonged hypertension, leading to chronic hypertension, where after 12 weeks of hypertension post-delivery, they can go on to form hypertension, chronic hypertension. Why do we want to look at hypertensive disorder of pregnancy? The global incidence is about 4 to 20%, complicating 3 to 10% of pregnancies and accounting for 18% of maternal deaths and 500,000 perinatal deaths annually. And that is very important, because pregnancy is not a disease. Research has shown that nulliparous women and those of advanced maternal age and hypertension in the previous pregnancy along with pre-existing chronic health conditions, such as diabetes and hypertension, obesity, were at increased risk. Complications of hypertensive disorder can be maternal and fetal. For example, we have the antepartum hemorrhage, postpartum hemorrhage, coagulation failure, and fetal complication can include miscarriages, growth restriction, and neonatal death. This study actually aimed to describe the maternal and fetal outcomes in women with hypertensive disorders attending public hospital, and this is between January 2015 and December 2019. Therefore, we want to also identify factors associated with adverse outcomes and determine actually the incidence of eclampsia. This was actually a mixed method study, and it divided into 3 components, and so this is just part of one of the components. It's a retrospective cohort study where we look at women with hypertensive disorders and women who were normotensive. Who did we include in this study? Persons who attended these facilities during the 5-year period, and persons who actually were admitted to hospitals such as the Victoria Jubilee. These are the hospitals within Sarah, the Victoria Jubilee Hospital, Spanish Town University Hospital, Linstead Hospital, and the neonates of these mothers, of these women. We excluded those persons who had a pre-diagnosed eclamptic disorder and those whose seizure were not actually attributable to hypertensive disorders of pregnancy. So in terms of the sample size we collected, we constructed for each hospital a list of patients with eclampsia, preeclampsia, and gestational hypertension. We selected all the records of eclampsia, 1 in 4 of preeclampsia, 1 in 10 of gestational hypertension, and a sample of normotensive women who delivered the same day with these persons, bringing a sample size of 917 persons. The data collection was from various sources, and so retrieval from earlier years actually was difficult. That was very difficult, especially for those who had died. We had 2 trained healthcare workers who assisted with the data extraction process, and a data extraction sheet containing the maternal and obstetric delivery information, along with neonatal birth information, was actually used. SPSS and Stata were used for data processing and analysis. Descriptive and inferential stats were used to describe maternal and fetal factors, chi-square tests for the associations for categorical variables, and we used the univariate analysis for individual hypertensive disorders and multivariate logistic regression for predictors of outcome. P-value less than 0.05 was considered to be statistically significant. Rates were calculated as recommended by WHO and presented in tables, graphs, and charts. The maternal and fetal outcomes were also examined, and ethical approval was from the University of the West Indies, Ministry of Health, and the Southeast Regional Health Authority. So let us see. In terms of the results, we're going to look at the maternal factors and the maternal outcomes, and then we're going to look into the neonatal outcomes. What did we find? When we look at the population of these 917 persons, we had a mean age of 27 years with a minimum of 13 years and a maximum of 48 years. These were the women that we reviewed their medical information. Most of the women that had eclampsia, you notice, were less than 20 years, as represented in the blue. Among the older age group, gestational hypertension and preeclampsia predominated, as represented in the red color. And this association was noted actually to be significant in terms of the age group with hypertensive disorder. We are here providing information of the mean diastolic of the weights of these persons from the booking when they started their antenatal care to the last antenatal visit. We see the range as being between 5 kilograms from the start to the end of their antenatal visit, from the eclampsia patients, to 9 kilograms for the preeclampsia patients. The women diagnosed with eclampsia weighed less throughout their pregnancy, in that they had a mean weight of 868 with an interquartile range of 57 and 85 kilograms. The mean diastolic blood pressure between the penultimate visit and the last visit was documented to be lower in women with eclampsia than those with gestational and preeclampsia. There was a linear relationship between the number of days, the number of antenatal visits done by these women, in that the longer the women that had the most antenatal visits had a higher antenatal visit, had a shorter duration of stay in the hospital. This is a univariate analysis represented as a forest plot with eclampsia, where we looked at the maternal factors for these persons. Here we recognize that age less than 20 and parity were most significant risk factors for eclampsia. When we look at the comparison of the univariate analysis, we notice that when persons who were less than 20 years were were 2 times at risk of eclampsia compared to those who 20 to 34 years. The primigravida were 3 times more likely to have eclampsia. The nulliparous were twice likely, and those with eclampsia were 19 times more likely to have a cesarean section. When we look at the case fatality rate, we found that those with preeclampsia, we had more persons die. Okay, thank you. We had more persons with preeclampsia dying with hypertensive disorder. Okay. We found that persons with preeclampsia were 12 times more likely to have postpartum hemorrhage. And what we found is that persons with preeclampsia and eclampsia had more adverse neonatal outcome of preterm live births and stillbirths, as represented here. And this association was also significant with the outcome. As diastolic blood pressure increased, above greater than equal to 110, actually we found that adverse outcomes were noticed among these women. It's of note here is that we did not have any neonatal asphyxia among the study population, but what happened is that they had low birth weight, and the neonatal, those women, the neonates that were admitted, I'm seeing a time slip here in front of me, I'm sorry. I didn't notice that before. So the neonatal admissions were those who were with preeclampsia had longer duration of admission to the nursery, of a median of 7 days, with the maximum being 13 days. And we realized that the incidence of eclampsia in KSA was higher than St. Catherine and St. Thomas as relates to parish of incidence. So in summary, we looked at, we know that the weight gain and the booking weight was less predictive of eclampsia, that eclampsia had an average normal blood pressure reading, that the number of antenatal visits was inversely proportional to the duration of stay in hospital. Women less than 20 years had a more significant risk factors for eclampsia. There were 19-fold cesarean section rate in eclampsia and the preterm births. In conclusion, we recognize that we would need to incorporate more clinical and biochemical markers for the prediction of preeclampsia and eclampsia, and we would have to introduce a universal electronic medical record system. So I want to say thanks to my supervisor and those who would have been a part of this process, including Prof. Affet McCobbins and Professor Peter Figueroa. So these are my references. Thank you.
Thank you so much, Dr. Lord. At this point in time, we're going to field questions from whether it's in the room or online. And so I'm going to be looking to my colleagues in the room to indicate if there's a question online and when there is. Just to indicate that, unfortunately, Mrs. Whitehorn-Smith is otherwise occupied, wishing her a safe delivery. So we won't be able to field questions to her, unfortunately. However, Dr. Lord's presentation, we can field questions from that. Both very interesting presentations, one looking at mental health, the other looking at maternal health. So the floor is now open to participants.
This question is for Dr. Lord. How do you account for women with a diastolic blood pressure of less than 90 having eclampsia?
All right. For women, if we notice as part actually in terms of the study population and the data that we collected, we had more women that were less than 20 actually having eclampsia, and these were actually the younger population, which is very important, because even though we have continuous blood pressure monitoring throughout their antenatal period, but still these persons develop eclampsia, which we actually aim to reduce, because this is just an obstetric emergency. So these persons that would have had diastolic blood pressure less than 90 having eclampsia, it just means that we have to look at other risk factors that for eclampsia. And so this is one area that we would want to ventilate more, looking at the other risk factors that for eclampsia. So it means that blood pressure alone is not a single monitoring item in the follow-up of these patients that we should be looking at. So we need to look at other risk factors, and we need to also screen the whole idea of first trimester ultrasound screening in these patients that we can red flag that have risk factors. The high risk factors, we would have to have ultrasound screening, because what research has shown is that once they do first trimester ultrasound, we can pick up by 90% those persons who are at increased risk of developing preeclampsia and eclampsia. And I do believe that is where we need to go, because international guidelines suggest to us that 140/90 should be one of the guidelines we should use, but it's definitely not working for our Jamaican population here. And so studies done actually by Prof. McCobbins et al. Right here for Jamaica indicated that some of our women fit at 80. So now the bar has gone lower to 70, and it means that ultrasound, first trimester ultrasound, will have to play an important role in us curbing preeclampsia and eclampsia within the nation, because this causes the lives of many persons. And eclampsia remains one of the top 3 cause of death, maternal death in Jamaica. Oh.
Thank you, Dr. Lord. Next question.
Was diastolic normal at time of seizures or earlier in pregnancy?
Actually, the diastolic was normal. The diastolic blood pressure was these diastolic blood pressures. If you notice that sometime throughout the pregnancy, 2 things we have to note here. One, when we look at these patients, they can have the first antenatal visit, or the booking visit can be actually have a normal blood pressure. But once they have a rise in the diastolic blood pressure, for example, of 50 milligrams, So if you start pregnancy with a diastolic blood pressure of about 60 or 50, and you go up to 65, 70, you can have a seizure. Because another method of screening is a systolic blood pressure increase of 30 millimeters mercury and a diastolic of 15. So once you have a blood pressure increase of 30 over 15, you can also have a seizure. So it depends on your first reading. What was your pre-pregnancy blood pressure? What was your first visit blood pressure? And then we check from there. Once there's a gradual increase, you can have a seizure before. You can have preeclampsia and eclampsia before you reach 80. So that's very important. So it depends on the incremental increase in your blood pressure. Over.
Thanks. Dr. Lord, I suppose you didn't get a chance to expound on it, but I noticed that for the case fatality ratio for the preeclamptic patients was 3.2%. For the eclamptic patients, that was lower, 1 point something. And we would expect that more of the eclamptic patients would die. So any explanation for that?
All right. Thank you for that question. Thank you very much. Dr. Harris, that deal with a lot of maternal mortality? Yes. All right. The thing is that with the persons, within the study population, we had actually more persons dying with preeclampsia. And if we notice with the age group, those with preeclampsia and gestational hypertension was actually seen among the older women. This was actually seen among the older women. It means that most of them would have had pre-existing comorbidities, hypertension, diabetes, obesity, other coexisting conditions. And so that is why we find that instead of them going on to, some of them going on to form eclampsia, they actually die from the complications of those comorbidities. Some of them would go from the health syndrome and from even the complications of their comorbid conditions that can cause them to succumb to death. Because pregnancy would exacerbate any other pre-existing condition that you will have. So that is one area too. So it means then that we will encourage persons to control their chronic illnesses before going into pregnancy, before becoming pregnant. That is also one of the recommendations that we would want to encourage. Over.
Are there any other questions online or any comments? All right, thank you so very much, Dr. Lord. Excellent presentation. Very interesting research, and I know there are probably 2 or more presentations out of that one doctoral thesis, which we look forward to hearing about in subsequent health research conferences. So the next set of presentations, the first presentation is going to come to us from Ms. Latoya Smith, who is currently enrolled in the Doctor of Philosophy in Public Health program at the University of the West Indies, Mona campus. She was the recipient of the University of the West Indies Postgraduate Scholarship and is currently a part-time lecturer at the University of Technology, Jamaica. And she'll be presenting on the association between antihypertensive medication class and orthostatic blood pressure dysregulation in older Caribbean adult patients. So, Ms. Smith, over to you.
Okay, pleasant morning all. My name is Latoya Smith and my presentation is entitled The Association Between Antihypertensive Medication Class and Orthostatic Blood Pressure Dysregulation in Older Caribbean Adult Patients. This is an outline of my presentation. Now, in relation to hypertension globally, it is ranked as a leading risk factor for mortality, and it is a risk factor for cardiovascular disease. It has been reported that persons of African descent are disproportionately affected in comparison to other ethnic groups. Its incidence increases significantly with increasing age, and in the Caribbean, its prevalence is approximately 60%. The 2016 to 2017 Jamaica Health and Lifestyle Survey has also reported that greater than 2/3 of the elder population of Jamaica were hypertensive, with female being more predominantly affected. Now, in regards to recommendation for hypertension therapy, both JNC8 and the European Society of Hypertension and the European Society of Cardiology has recommended comparable guidelines for the management of hypertension to include the use of combination antihypertensive therapy to achieve a blood pressure target of less than 150 over 90 millimeters per mercury and less than 140 over 80 millimeters per mercury, respectively, in adults aged 60 years and older. Other studies have reported that hypertensive patients requires an average of 3 drugs for adequate blood pressure control, and monotherapy has been prescribed, but with limited success. In regards to hypertension therapy, continuing, by analogy with monotherapy, combination therapy improves blood pressure control, and calcium channel blockers and renin-angiotensin-aldosterone system blockers were the most frequently prescribed class of antihypertensive therapy. And when they're given in combination, it is associated with improved blood pressure control. JNC8 recommends a combination of CCBs, RAS blockers, and diuretics to provide additive blood pressure control. As for blood pressure dysregulation, this includes orthostatic hypotension and orthostatic hypertension, both of which are cardiovascular complication of hypertension. As it relates to the orthostatic blood pressure dysregulation epidemiology, OHD prevalence ranges between 5 to 30%. It is associated with cardiovascular risk, and it increases the likelihood of silent cerebrovascular lesions, as well as it's a marker of neuropathy among type 2 diabetics. Interestingly, other study has reported that it is masked hypertension, which is also a risk factor for all-cause mortality and cardiovascular related mortality. OHD is inconsistently associated with geriatric symptoms. In contrast, now OH, its prevalence is similar to OHD, where it ranges from 5 to 30% in community and also older adults, and it's an established marker of cardiovascular risk in elderly and hypertensive patients. It is also associated with increased risk of cardiovascular comorbidities, and it's associated with all-cause and cardiovascular mortality. It is also associated with risk for geriatric symptoms in contrast to OHD. Now, what was the justification for this study? To the best of our knowledge, there's lack of data available on the association between antihypertensive medication class and orthostatic blood pressure dysregulation. And as such, the prevalence of orthostatic blood pressure dysregulation and its association with antihypertensive classes of drugs among older Caribbean adults with hypertension and hyperlipidemia attending public health center is unknown. Therefore, the ascertainment of same would constitute an important clinical finding that could reduce an unrecognized health problem among the aging population of Jamaica. Now, what was our primary aim? This was to examine the association of antihypertensive classes of drugs with orthostatic blood pressure dysregulation in patients 60 years and older with hypertension and hyperlipidemia attending public primary care facilities. Now, onto our methods. The study was cross-sectional, and it included older patients with hypertension and hyperlipidemia to determine orthostatic changes in blood pressure measured from seated to standing 3 times. Now, as it relates to OHD, it is defined as an increase in systolic blood pressure of equals to or greater than 20 millimeters per mercury, and or increase in diastolic blood pressure of greater than or equal to 10 millimeters per mercury upon orthostasis. OH, on the other hand, was defined as a decrease in systolic blood pressure of equals to 20 millimeters per mercury, or diastolic blood pressure of greater than or equals to 10 millimeters per mercury upon orthostasis. Patients were later classified according to their orthostatic blood pressure response to include orthostatic normotensive and orthostatic blood pressure dysregulated patients. Multivariable logistic regression models were used to examine the association of antihypertensive classes and orthostatic blood pressure dysregulation. Now, for our results, majority of the sample were females, And as it relates to orthostatic blood pressure changes, OHT prevalence was 47.3%, and that of OH was 2.6%. 16.3% of the sample had coronary heart disease, and only 10% had stroke. In regard to antihypertensive medication prescribed, RAS blockers was the most frequently prescribed, followed by diuretics and dihydropyridine calcium channel blockers. Now, blood pressure dysregulation was highest among females, and obesity was also highest among blood pressure dysregulated patients. The mean sitting systolic blood pressure as well as the mean sitting diastolic blood pressure was significantly lower among blood pressure dysregulated patients, and the mean standing diastolic blood pressure, however, was highest among blood pressure dysregulated patients. A lower proportion of blood pressure dysregulated patients had stroke, and among the prescribed antihypertensive classes, a lower proportion of blood pressure dysregulated patients were prescribed dihydropyridine calcium channel blockers. As it relates to type of antihypertensive therapy, fewer patients in our sample were prescribed monotherapy, and monotherapy was not associated with blood pressure dysregulation. More of the population were prescribed dual or more antihypertensive combination therapy, and among the dual therapy, RAS blockers was the most frequently prescribed. However, there was no association with orthostatic blood pressure dysregulation. Meanwhile, the triple antihypertensive therapy of RAS blockers with DCCBs as well as diuretics was the most frequently prescribed therapy, and a lower proportion of blood pressure dysregulated patients were prescribed this triple antihypertensive therapy. Multivariable logistic regression revealed that, well, actually after adjusting for confounders, revealed that the triple antihypertensive therapy of RAS blockers, DCCBs, and beta blockers, as well as RAS blockers in combination with DCCBs and diuretics, was associated with lower risk of orthostatic blood pressure dysregulation. Now, on to our discussion. The prevalence of OH in our sample was actually low, which was 2.6%, and this was inconsistent with the findings of the other Caribbean study that had reported a prevalence of 20%. The prevalence of OHT is high at 47.3%, and this is outside the range that was reported by other cross-sectional studies, which showed a prevalence ranging from 5 to 30% among older adults. Prevalence of OHT also varies based on disease process, where it is reported that in extreme dippers, OHT prevalence was 72% in elderly hypertensive patients, and among those with dysautonomia, such as postural tachycardia, the prevalence was 38%. Now, majority of the normotensive and orthostatic blood pressure dysregulated patients were prescribed 2 or more antihypertensive medication therapy, and this was consistent with JNC 8 guidelines. Monotherapy, of course, is not recommended by JNC 8, and in our study, of course, fewer patients were prescribed monotherapy. The combination therapy of RAS blockers with DCCBs and diuretics was the most frequently prescribed triple antihypertensive therapy, and this was also consistent with JNC guidelines. In addition, the World Health Organization recommends this combination for patients with essential hypertension with blood pressure equals to or greater than 20/10 millimeters per mercury. The triple combination therapy compared to dual combination therapy produces greater blood pressure reduction in patients with moderate to severe hypertension. The study showed that the triple antihypertensive combination therapy of RAS blockers, DCCBs, and diuretics was inversely related to orthostatic blood pressure dysregulation, and this is suggestive of a protective effect. Moreover, JNC 8 also reported that this triple antihypertensive therapy is more effective at reducing the risk of cardiovascular events and mortality, and clinical trials have reported that this triple antihypertensive therapy is superior at reducing mean sitting systolic and diastolic blood pressure, as well as achieving blood pressure target of less than 140/90 millimeters per mercury when compared to dual antihypertensive combination therapy. The study also showed that the triple antihypertensive therapy of RAS blockers with DCCBs and beta blockers were inversely related to orthostatic blood pressure dysregulation, and this is also suggestive of a protective effect. JNC 8 recommends this triple antihypertensive therapy for high-risk patients with compelling indications, and it was also noted that it was shown to improve survival, decrease risk of recurrent myocardial infarction, and decrease incidence of sudden cardiac death among patients with coronary heart disease. Lastly, the study showed that RAS blockers in combination with diuretics was the most commonly prescribed dual antihypertensive therapy. However, this was not related to or associated to orthostatic blood pressure dysregulation. In conclusion, orthostatic blood pressure dysregulation, in particularly OHD, was common in older Jamaican patients with hypertension and dyslipidemia. And patients prescribed the antihypertensive therapies of RAS blockers with DCCBs and diuretics, as well as RAS blockers with DCCBs and beta blockers, were protective against orthostatic blood pressure dysregulation. The triple antihypertensive therapy combination was, of course, consistent with prescription guidelines. And the fact that the study findings showed that these triple antihypertensive therapy was able to reduce the risk of orthostatic blood pressure dysregulation, it is appealing, of course, and has implication as it relates to clinical management. Thus, it is important for larger studies to be conducted to determine the effect of these antihypertensive therapies on orthostatic blood pressure dysregulation. And of course, the results from these may go on to, of course, inform health policy as well as resource allocation. Now, onto our limitations. The study sample size was modest, and of course, there's lack of repeated data on orthostatic testing. Arterial stiffness is a known contributing factor for OHD development, and this was not measured in our study. And there's no consensus on the guidelines for systolic or diastolic blood pressure targets in the elderly. Thus, orthostatic blood pressure dysregulation, in particular the OHD, is in this investigation may be overestimated. Measuring orthostasis from seated to standing could actually impact our investigation, since the recommended assessment for orthostatic testing is measurement from supine to standing. However, this could not be accommodated in our clinical setting. There's also a lack of information available on drug dosage, grade, or severity of hypertension prior to initial therapy. And it is reported that higher baseline blood pressure is associated with orthostatic hypertension. These are my references. I thank you.
Thank you very much, Ms. Smith, for that presentation. We're now going to move to our final presentation for this session, which will be delivered by Dr. Julia Rowe-Porter, who is currently the medical epidemiologist in the Non-Communicable Disease and Injury Prevention Unit in the Ministry of Health and Wellness. She has a Master of Public Health with distinction and has served the health sector for over 15 years with positions in the Northeast Regional Health Authority, as well as Program Development Officer with responsibility primarily for immunization and child health within the Family Health Unit in the Ministry of Health and Wellness. Dr. Rowe-Porter is also a wife and a mother, and she'll be presenting on private physicians' adherence to administrative and clinical guidelines, which are the results from a pilot phase of the Public-Private Partnership for Non-Communicable Diseases project. Please welcome Dr. Rowe-Porter.
Good morning, everyone. The Public-Private Partnership for Non-Communicable Diseases project, or the PPP for NCDs initiative, as we call it, was launched in November 2020, 2 years ago, during Diabetes Awareness Month. And it is with great pleasure that I present selected findings from the pilot assessment of this recently implemented initiative led by the NCD and Injury Prevention Unit. Special thanks to our permanent secretary, Mr. Dunstan Bryan, Dr. Nicholas Skyers, our director of the NCD unit, Dr. Camelia Thompson, our PPP coordinator, and members of the PPP steering committee. So, globally, NCDs kills 41 million persons each year, equivalent to 74% of all deaths. And 17 million people die from NCDs before the age of 70. 86% of these premature deaths occur in low and middle income countries like Jamaica. Cardiovascular disease, including hypertension, account for most NCD-related deaths, followed by cancers, chronic respiratory diseases, and diabetes. The World Bank estimates that NCDs account for 79% of all deaths in Jamaica. NCDs pose a major public health threat to Jamaica and constitute a significant burden on our health sector. Globally, the power of public-private partnerships has been proven to support burdened health systems, is cost-effective, and provides value for money, as well as maximizing the benefits of public goods and services. The PPP for NCDs initiative in Jamaica was designed to decrease the patient burden in primary care and meet the need for quality care for patients with NCDs. It was also implemented as an initiative, as an alternative arrangement in response to the impact of the COVID-19 pandemic for expansion of primary care services. Stable patients with diabetes and hypertension were referred to selected GPs in the community for continuity of care. These GPs were trained in the MOH guidelines from November 2020 to June 2021, and the program was piloted from July 2021 to March 2022. Inclusion criteria for patient enrollment included known diagnosis of type 2 diabetes and/or essential hypertension, diabetes and hypertension control for the last 2 visits with a standard definition of control as per the clinical management guidelines, and being registered for the individual benefits program of the NHF. Comorbidities were the main exclusion criteria, and these include heart disease, renal impairments, cardiovascular disease, peripheral vascular disease, peripheral neuropathy and amputations, as well as type 1 diabetes and secondary hypertension, because these patients are required to have specialist intervention and close follow-up. Clinical management guidelines are instituted to assist physicians with decision support for care of patients with specific medical conditions. Non-adherence to clinical guidelines contributes significantly to poor delivery of clinical care and hence poor clinical outcomes for patients. Adherence to these guidelines has been found to be suboptimal in some settings, and several factors have been found to influence adherence to guidelines, such as physician's age, clinical experience, clinical governance, outdated guidelines, time constraints, trustworthiness of the guidelines, lack of resources, and auditing and feedback. The objective of this assessment that was conducted as part of the pilot evaluation of the PPP for NCDs initiative was to determine the adherence of private physicians engaged for the program to clinical guidelines for diabetes and hypertension and administrative guidelines in the provision of care to enrolled patients. All 4 GPs that were contracted to the ministry to provide services to enrolled patients were involved in the assessment. At the time of the assessment, a total of 126 clients were enrolled in the program, and a sample of 41% or 51 medical records were randomly selected for review. The sample distribution is shown in the diagram and was based on the proportion of patients enrolled for each GP. Records of the latest visits for patients enrolled since the commencement of the program were reviewed. Data extraction tools were developed based on MOH clinical management guidelines as well as administrative guidelines that were developed for the program. Prescribing practices were also reviewed to determine adherence to the 2020 Vital, Essential, and Necessary, or VEN list of drugs. Key findings are summarized as follows. Of the 51 records reviewed, there were 90.2% females and 9.8% males, with a mean age of 59 years, ranging from 31 to 80 years of age. 94% were known to have hypertension and 41.2% had diabetes. Note that some would have had a dual diagnosis. The majority of patients in the sample, which was 70.6%, had only 1 visit during the 9-month pilot period. Of the 51 records reviewed, the most well-documented variable was the patient's medication, which was 96.1%. Adherence to documentation of body mass index and medication compliance was 45.1%, followed by documentation of dietary recommendations at 39.2%. There was no documentation of waist circumference or foot inspection and periodontal exams. When the documented medications were matched with the VENLIS drugs, we found that 86.7% of the drugs to treat hypertension and 71.4% of drugs to treat diabetes were on the VENLIS. All GPs receive a package from the referring health centers for each enrolled client, and these include the patient's clinical summary on a standardized applicant screening form. GPs are also required to submit a report to the health center for each patient visit. On review of the records, no applicant screen forms were found in sample records of 2 of 4 GPs. The overall adherence rate for the 4 GPs was 72.6%, and copies of the patient report for the health centers were seen in none of the records reviewed. Based on the findings, there was limited adherence to the clinical management guidelines in keeping with findings of similar local studies and reports. In the Auditor General Report of 2016, it was reported that similar findings were reported and other findings that showed weaknesses in diabetes clinical management in public health centers. Also, the NCD and Injury Prevention Unit conducted audits in public health centers in 2021 that showed low scores for assessment and referral, especially for foot and fundoscopic exams and dental checks, which were generally either not done or referred. This end of pilot study showed limited adherence to guidelines among our PPP GPs, which may impact quality of care and ultimately patient outcomes. Recommendations include ongoing training of the private physicians in the clinical management of these conditions, as well as optimizing administrative processes through ongoing dialogue and support. Of note, a standardized clinical consultation form for patient records was recently developed and implemented for health centers to improve documentation of clinical care parameters for patients with diabetes and hypertension in those NCD clinics, and serve as a constant reminder of the clinical guidelines to care providers. This tool has been shown to improve audit scores in the recent past for the public sector and has been introduced to the PPP private providers as a recommendation emanating from the pilot assessment. Additionally, re-auditing every 6 months has also been instituted to monitor quality improvement initiatives such as these and has proven to be effective. These are my references. Thank you.
Two excellent presentations, again, both from Ms. Smith and Dr. Porter. So the floor is now open for questions from participants, both in the room as well as those online. No questions or comments from the team?
Okay. What were the reasons given by the PPs for non-adherence to the MOHW guidelines?
Well, so it's similar to what we found for the health centers. Usually there is just free text writing in the records. They'll say that they don't have the time in the public sector, but in the private sector they do have the time. And it's really a matter of perhaps feeling that they don't need to do some of the guidelines on a routine basis. They also reported that they did do some of the activities, but they were not documented. So we found that documentation was lacking, and if it's not documented, it's not done, in that sense. So it was a matter of reviewing records and seeing if it was documented. We note that they needed some reminders of the guidelines, so we have since introduced, and that has been useful for them.
And another question, how were the PPs selected?
The GPs were selected for the pilot phase through an expression of interest. We sent out that through our procurement team, and those that were interested and selected based on certain criteria were contracted. They had to also go through extensive assessment where their offices were observed, they were assessed, so that they had minimum standards and a comfortable and appropriate space to see clinicians. And those that were selected were trained, and if the training was incomplete, they would not be contracted. So all that were selected and engaged were trained.
Okay. Regarding the screening tools, the forms are extremely long and time-consuming, not practical for the public sector setting. Can a highly skilled CHA or records clerk be trained to apply the screening tools instead of the primary care physician?
Okay, so the applicant screening form, I'm assuming it's the applicant screening form that they're speaking to and not the consultation form. This is a one-pager, and that goes with a referral form. And we have instituted a teamwork and task shifting and sharing approach where we know that documentation is key, and what we've done is we have actually trained community health aides to take on some of the documentation. There are some health centers that have really incorporated their entire team where the medical record clerk, the health aide, and the doctor work together to have the referrals done, and they have not reported the burden of that documentation because of the approach of teamwork. So if one team member is expected to do all the documentation, it will be a burden. So we recommend that that particular facility institute the teamwork approach because documentation is key.
Will this program be continued, and did patients indicate their satisfaction or not?
In the pilot assessment, those findings were not shared, but we did a rapid assessment in December, which showed 90 to 100% satisfaction rates for all the patients that were interviewed via the phone. The waiting times were dramatically reduced to half of them reported less than half an hour wait for those doctors. The majority of them said they want to return and would recommend the patients, recommend the GPs to their other patients. What we're doing is documenting the implementation, and we are guided by evidence. So this assessments like this are key because we want to be guided by the evidence. It's also been proven to be cost-effective in other settings, so we would also need to do an assessment of the investments that are made in the program and the outcomes, especially the patient outcomes, where we look at our control levels, compare it to what is happening in our public setting, and see if there are ways that we can address barriers and maximize on the benefits of the program going forward based on the evidence.
Any other comments or questions from? Yes, please go ahead.
Okay, thanks, Dr. Roporter, for that excellent presentation. As it relates to policy, is there any policy shift or policy crafting that is necessary to increase compliance or adherence to the policies, to the guidelines?
Well, I had mentioned, ensuring that auditing is done on a routine basis, and I believe our SLAs, hold our regions to it and hold us to it as well, and that has been proven to be a factor that will improve adherence to guidelines when consistent monitoring and ongoing monitoring is done. In addition to that, in terms of policy, although it didn't feature as a significant finding in terms of adherence to VEN list prescriptions, for example, there is, say, one combination drug on the VEN list for hypertension, so we suspect that there may not be that trustworthiness of the guidelines as a factor that was shown in other studies, where physicians may want to prescribe other drugs outside of the VEN list because they know those drugs to be effective. So in terms of policy, we would want to see in the next iteration of the VEN list an inclusion of cost-effective drugs and options, and I believe that would help with the adherence to some of the VEN list options so that the clinicians' prescribing practices will be improved.
Yes, please go ahead.
One more question. Is the screening tool made available to all health centers or just a selective few?
The applicant screen form is specifically for the program because it summarizes the information. Persons with diabetes and hypertension are chronic illness patients, so they have a long history of notes, so it would have to be summarized as part of the referral. It is attached to the referral form A, and it is specifically for the GPs. It is not specified essentially for the GP, meaning it doesn't have diabetes, hypertension on it. At this particular time, we are using it for the program, but we can explore its usefulness in the referral processes for other external services if that is a recommendation.
How often is the VEN list reviewed?
I know it is currently being reviewed, so I can say that. So there is an opportunity now for a review of the medications that are available for public sector.
And the last one is, was the audit score based on standardized consultation form, or were they validated?
So at the time of the assessment, the consultation forms were not implemented. The consultation forms it's an intake tool, similar to what the HIV service uses. We use their experience to guide us. So while the pilot was going on, it was not instituted. And we had found that in the health centers, when it was implemented, it was very, very useful. So audit scores that we are looking at for the early part of 2022 have actually improved significantly, hence the reason why we've introduced it to the doctors. And anecdotally, well, we're currently doing a review, re-auditing of the GPs now, and we haven't done the analysis, but the scores have increased significantly, and it is attributable to that consultation form. So we expect that the scores will improve when we do the reports, the follow-up report.
That's it. I have one question in terms of the patient reports that the GPs are to provide to the health facilities that would have referred the patients in the first instance. You had 0 in the pilot. Has that improved?
Okay, that's a good question. So there's a question about the burden of documentation, and the GPs, some of them just found it burdensome to write another report, and this is for every patient visit. So what we've done is the consultation form that we've introduced to them, we've carbonized it. So once they see the patients, they will just send a copy to the health center, and that would be the report that the health center would get, and they have welcomed that change immensely.
Okay, awesome. So thank you, everyone. Let us give a big round of applause to all the presenters in this session. This session was on non-communicable diseases, maternal and child health. We really do appreciate your time and attention. And we are now going to go into a 5-minute commercial break while we switch moderators. So it really has been my distinct pleasure and privilege to chair this session. And so wishing you all the best for the rest of the conference as well as the rest of today. So thank you, everyone, and have a good morning, afternoon, night.
So, morning again, everyone. Before you go, Dr. Spence, we could not let you go without acknowledging our appreciation for your willingness to moderate this session. We know that whenever we call on you to assist us with respect to the conference, you are always willing, and we do appreciate that. So this is a token of our appreciation.
Thank you so very much. Lots of goodies in the basket, and I'm willing to share.
We were given a mandate to provide oversight of the redevelopment of the Conrad Regional Hospital. The oversight committee visited the site and inspected the building, and we all concluded that it was a worthwhile building to renovate. To construct a new building would cost 10 times as much of what we are spending to do the renovation.
The hospital is a 450-bed facility. It was pretty much full and has been consistently so. And the options to close would mean having nowhere to put persons. People would literally die if we close the hospital.
This project is approximately $3.5 billion. The first phase was to fix the roof, fix the structural problems. The second phase was to the demolition of the building. That is to remove all the internals, because a lot of them are identified to be mold infested. And then the third phase would have been the rehabilitation of the building.
We have not compromised on one service, one area of service that we are doing before the hospital was closed. We would have removed and built a standalone building to accommodate our CT machines, our X-ray machines, and so on. We would have expanded our accident and emergency unit, constructed intensive care units to be used for COVID, converted living spaces into wards, constructed 3 additional operating theaters, expanded even our dialysis area. When it is completed, we'll have a brand new hospital, a brand new building, brand new facilities, modern facilities, because it is totally being redesigned.
Okay, good morning, ladies and gentlemen, both online and present here. My name is Howard Lynch from the Ministry of Health and Wellness, and it's my task to moderate this session. And this is the Health Economics session, and it will have the feature presentation. So our first presenter and he's our guest presenter, and he's online. Is he? Yes? Okay. His name is Professor Abdullahi Abdul Kadri. I hope I got that right. He's the coordinator of the Statistics and Social Development Unit of the United Nations Economic Commission for Latin America and the Caribbean, ECLAC. So he's based at the sub-regional headquarters for the Caribbean in Port of Spain, Trinidad and Tobago. He also serves as ECLAC's focal point for the 2030 Agenda for Sustainable Development in the Caribbean. Professor Abdul Kadri, hope I get it right again, plays an instrumental role in addressing the economics of non-communicable diseases in the Caribbean. Professor Abdul Kadri, he has a PhD degree in economics, and this is from Kansas State University. And he completed his postdoctoral fellowship in health economics at the Centers for Disease Control and Prevention in Atlanta, and this was done in 2002. So, Professor, I hope you're ready. So, ladies and gentlemen, can you join me in welcoming Professor Abdul Kadri to be the guest presenter and to do the feature presentation. Over to you, Professor.
Yes, thank you very much, Mr. Lynch. Can you hear me?
Loud and clear, Professor, loud and clear.
It's raining heavily here in Port of Spain, so I wanted to know if I should use a headset. Just 2 seconds while I upload my presentation. Can you confirm if you're seeing? Okay, there you go.
His audio is not so good. Where's the feed? Go ahead, Professor. Go ahead.
Okay. My presentation, is it coming okay?
Well, we're seeing the title slide.
They did progress to the. I just wanted to make sure that the slides are coming up. Okay, it looks like they are. Thank you again for the introduction. It's indeed a pleasure for me, and I think I'll actually call it an honor for me to make this presentation at the National Health Research Conference. I remember the first time I participated in this conference, which was in person, was about 10 years ago at the Jamaica Conference Center, which was quite a memorable experience for me because I'm not a health expert, but I do work with a number of professionals, and that has really broadened my hope in understanding the issues that are of importance when we're talking about. So I would like to thank Dr. Webster Carr, Dr. Grant, and his colleagues for really making this happen. Now, my presentation is going to be a little different from most of the presentations that may have happened already in this conference. I'm not going to take so much of a scientific approach. I'm going to do more of advocacy. So I'm here to sell something to you. Hopefully, I'll do a very good job. At the end of the day, I would have accomplished that goal. And my goal is to convince the decision makers and the professionals, the health professionals, of the need to start looking at NCD as not only a public health or a health issue, but also as an economic issue, something of importance when it comes to development. Now, to do that, let me move these. Okay. Remind us, and there's most of what I will be talking initially will be things that you already know and you know more than I do, or that you may have heard yesterday or even today. They just earlier on, Dr. Reporter mentioned some of the data that I will share. But just for the sake of completeness, in case somebody might be looking at this PowerPoint after this presentation, I will still make an attempt to just document them. The Caribbean decision makers are really taking a very proactive role in recognizing this, what I'm trying to preach, and in also pushing for action in that regard, starting from the Nassau Declaration, which specified that the health of the region is the wealth of the region. That led to the formation of the Caribbean Commission on Health and Development, which came up with a report, a bold report that stated a healthy population is an essential prerequisite for the economic growth and stability of the Caribbean. And of course, that led to the Declaration of Port of Spain, uniting to stop the epidemics of chronic NCD, which many people working in the NCD would have had one thing or the other to do with, either in making that declaration possible or in the implementation of the actions related to the declaration. And this led to, at the UN, the call for making this not just a regional issue, but making NCD, the fight against NCD, to be a global issue. So this was again pushed by CARICA, and with the support of other health organizations, international health organizations, this came to be a major event at the United Nations, a high-level meeting on NCD in 2011. Then subsequently, there was a high-level meeting at the General Assembly in 2014. Then it became more of a routine, where the third high-level meeting was held in 2018, where the time to deliver commitments, it's about time, that was in 2018 to deliver, by accelerating our response to address the non-communicable diseases for the health and well-being of present and future generations was made. And then the preparation for the next high-level meeting in 2025 is currently ongoing. So we now have an opportunity to inform what will be done in 2025 at the fourth high-level meeting. Now, this is nothing new, like I said. The global burden of NCD is what you all know very well. And so with the economic burden, there are two areas that we always try to emphasize: the cost of care and the productivity loss from excess morbidity and premature death. In the Caribbean, or actually more globally now, there are 4 major NCDs: cardiovascular diseases, cancer, chronic respiratory disease, and diabetes, in addition to mental disorder, have been projected to in the 2 decades of 2010 to 2030, will amount to a burden, an economic burden of $47 trillion US. Of course, that's a lot of money, and we're looking at a 20-year period. A lot of things may change during that period, which could hopefully reduce this cost. But if you don't take action, that cost may actually go astronomically. Now, but that's a little far away because we are talking globally. Coming down to the Caribbean level, again, the burden of disease ranges from, in terms of NCDs accounting for death in the Caribbean, it could be as low as 57% in Haiti, or as high as 83% in Barbados, based on the last available WHO data. Now, the NCD risk factors are very prevalent. One issue that I will further emphasize on is the childhood obesity, which is currently an average being projected to be around a third the prevalence rate of childhood obesity in the Caribbean. Now, NCDs, looking at this data from Trinidad and Tobago, I just couldn't take my eyes off it, that between 2010 and 2015, more than 50% of all hospitalizations in the country were due to NCDs. So that's a very compelling data that should get the attention of anybody. And it did, because some actions have been taken since then. Now, with respect to economic body, this is from a study that we did much earlier on in my career with my very good friend, Dr. Cornel Murray and Professor Forrester, where we did an estimate of the burden of NCD in the Caribbean. Since then, and this was about 20 years ago, maybe close to it. Since then, there have been a number of studies, maybe about 15 years ago, a number of studies, also estimating or projecting what the burden of disease of NCD is, maybe in specific countries. And when you look at the comparison, they are not too far off. Of course, they focus on different aspects of NCDs. And in Jamaica, for example, the NHF, which has been quite active in providing funding care for NCD, those suffering from NCDs, or those who have NCD conditions. In 2011, the expenditure or the expenses, the disbursement from NHF amounted to 7.63% of the government health expenditure in general. So that's quite substantial. In Anguilla, more than half of annual cost of domestic healthcare is due to NCDs. And that's for domestic. And we know for small island developing states, and especially those countries that we call the associate members of ECLA, the non-independent territories. Most of the time for secondary tertiary healthcare, they will have to travel to get that, which the cost will be significant as well. So if you focus on productivity loss and looking at not just mortality, but looking at the combination of mortality and morbidity using the disability adjusted life years. For the active working age group, 25 to 49 globally, if you look at the top 10 causes of NCDs that fall within the top 10, accounted for a quarter of all the dialysis for that age group. Now, if you, and we're just coming out of, hopefully, of COVID-19. I mean, COVID-19 is not gone altogether, but during the peak of COVID-19, we know from that those who have at least one comorbidity of NCDs were adversely affected, right? And about 61% of deaths from COVID-19 have been linked to those who have at least one NCD comorbidity. In terms of indirect cost, from the study I mentioned earlier, we estimated the indirect cost to be within the range of 39% to 73% for diabetes and about 47% for hypertension. Talking about the obesity, again, in the prevalence of obesity in children, if we have 30% of the current, those who are considered to be children, who will grow up to be in this 25 to 49% active working age persons, then we need to start looking very carefully. But I will come back to that. Now, this is the economic burden of NCDs. Looking at a specific example from Trinidad and Tobago. So we did an estimation in 2001 and another study by the RTI, Research Triangle International, conducted in 2016. We projected that the cost of NCD was 8% for Trinidad and Tobago. They came out with a 5% figure, although there are differences in the scope of the analysis. But what I want us to focus on, irrespective of the scope, when you look at the indirect cost from both studies, the percentage as a percentage of the total cost, hypertension, we find hypertension to be the indirect cost of hypertension to be 47%. They found it to be 58%. We found diabetes to be 70%. They found it to be 65%, not too far off. We did not cover cancer. They did incorporate cancer in their analysis. And the indirect cost of cancer treatment, of the burden of cancer, was 90%. Now, so most of the time when we talk about the cost of care, we tend to focus on the cost of medication, the cost of lab, the visit to the doctor's office, not so much about the indirect cost. But it's showing that in some cases, the indirect costs could actually be higher than the actual direct cost of treatment. So have that in mind. So there are two population dynamics that we have to look into: the aging of the population and the prevalence of obesity in children. So with the aging population, I indicated for the working force what's the level of dialysis that's approved from the top 10, the NCDs in the top 10 causes of dialysis. If we look at the age group 50 to 74, the quota, the 25% that we saw for the active working age will now increase to 45% for the 50 to 74 years old, and again to 55% for persons over 75 years and older. So in a study that we did in Jamaica in 2012, and this is a study that was actually led by the late Dr. Catherine Mitchell-Ferron, who was quite passionate about applying economics to health analysis. The focus of the study, or the subject of the study, were persons 60 years and older. And we looked at hypertension in particular. And the cost of care, the annual cost of care, was estimated to be about $1,200 US. The direct cost was 57% and the indirect cost 43%. The indirect cost in this case didn't look that bad. But when you look at the cost of care as a component of all cost items, and I think that's in this next chart, you see that the cost of caregiving represented 35% of the total cost, which was higher than the cost of lab procedures, medication, or any other, even hospitalization. So that's a huge cost, which most of the time will not be accounted for, because this will be the cost of maybe a child taking care of their parent, or a grandchild taking care of a grandparent, or it could be a grandparent taking care of a child that has chronic NC. So this is something that we have to focus, because with the aging of the population, people and the people living longer, they will develop NCs, and there has to be a way to look at how their care will be taken care of without jeopardizing economic growth. So this is a snapshot of, see if I can get a snapshot of the rate of childhood obesity. And this is from the Healthy Caribbean Coalition, which shows that for most parts, you have, for the countries that we have here, the prevalence of NCD ranges between 24, a low of 23, to a high of 30, 35, which is quite high. And the implication of this for the future is that, we know that NCD, or being overweight or having obesity as a child, is a main predictor of NCD in adulthood. And that if we have a sicker and less productive workforce in the future, because of them having a predominantly, or there is a high prevalence of NCD, then that will also have, not only will it have implication for economic growth, it will also have implication for high cost of care. And then you have fewer people who are healthy and able to work, pay taxes in order to support those who are now old and will be on pension with increased healthcare costs spending. Let me move to what I really want to get at. That we have, and I'm using an example of physical activities. That there is a mixed trend where in Barbados and in Jamaica, we see that, using women as an example, that there is a decrease or an increase in physical inactivity. But in Trinidad and Tobago, there's actually a decrease in physical inactivity between 2010 and 2016. And in Jamaica, I also know that there is the Jamaica Moves is a program that has been implemented, and the positive response to such a public intervention. Now, I saw just recently a study done by my colleague Colette Cunningham-Mary with other colleagues on positive deviance for physical activity. And when I look at what they find out, and we know the Caribbean is a very active, physically active community. The Caribbean countries dominate many international track events, especially at the youth level. So why can't that translate to action at the local level? You need to drive that one way or the other. So how do we incentivize meaningful action to promote positive deviance in this case as one of the means of addressing childhood obesity? So let me tell you quickly a story, which is something that's quite meaningful to me. When I was at CDC as a young postdoc, there was a project being implemented by the West Virginia University Prevention Research Center. And that was a pilot for the NOT, the Northern Tobacco Program. It's supposed to be, it is a teen cessation a teen smoking cessation program, which was at that point was at a pilot stage. And they were trying to make this be a standard practice to be adopted by the states, which eventually became an American Lung Association signature program, which has been implemented in all states of the US and even in other countries. But what made that, what really led to that, made that impact was they came to us at the CDC, and they were an affiliate center of the CDC, and then we got involved with them. And we did a projection of the economic effectiveness, of the cost effectiveness of this intervention, which made the case for really investing in this. And I could tell you that it wasn't an easy thing for the health professionals to accept, because they were not used to it. They didn't know what it was. They were quite a little bit not too sure what it would lead to. But the good story was that it showed that the intervention was effective, was cost effective, although the meaning or the interpretation of the result wasn't something that they quite understood or were comfortable with. But with the evidence, this became an American Lung Association adopted program. So why can't we adopt such an action? For example, we were speaking about the study that Colette did. They've identified a number of issues or a number of characteristics that will make somebody adopt a deviance, a positive deviance action. Why can't we do a kind of an economic projection of, if you have, we have childhood obesity, what will make being physically active to be really a cool thing that government and private companies and all the other stakeholders will really want to invest in that and make it something that will even employers. So we need to make the economic case. You need to make analysis. You need to show what those who have, hopefully, who have adopted that and they have maybe gain employment, or they have a better health outcome, and then do the economics of what that means compared to those who have not adopted these positive deviance characteristics. So, but there is a problem now, and I'm rounding up now, that in looking at the CCH4, there are 5 strategic priorities that are being and one of them is health financing. And the CARFA did a report recently on the performance of the CCH4. And in that report, and this is a traffic light kind of analysis, where of course we know what red is, amber is, and green is. Gray now it shows that there are no data. And one of the key areas in which we do not have data is in 1.2.3, which is regional repository of health and economic impact data for varying disease conditions. This is not excusable. If we are trying to make the policymakers, or we are trying to make those who will invest in health, who will support healthcare financing, but we do not have the economic data to make the case, then we are not doing a very good job. So this is my call to you. To those of you that are professionals, that are decision makers, that we need to mainstream health economic systems, especially those that are intended to inform health policies. And there is an acute shortage of health economics. I must have offended quite a number of people because they reach out to me, I'll give them an indication. And truly, I would like to get involved, be part of the study, but I just cannot because I have so many other obligations that I can get into. But I will be so glad to have many more people who are doing this, that we can share ideas together, and then it will become. So we need to devote resources to developing more expertise in this area. And that will allow us to narrow the gap. I was referring to a study we did in 2008 based on the 2001 data. But we haven't done enough data of that since then. We need to do better. So emphasize more the economic case for investing in NCD prevention and control. And when we start doing that, I think we will start seeing the case being made and increase investment in those interventions that have been termed to be best buys, and a few of those that are considered to be good buys in preventing and controlling NCDs. So I hope I have done a little bit of good job in advertising to you the importance of economics in health research and health policy and programs that we implement. So thank you very much, and I look forward to the discussion.
Thank you, Professor. A very good presentation and highlighting some of the difficult challenges in terms of making policy without having the necessary information to guide us. Now, we're at the question and answer stage of our event. My only caveat that I can take just 1.5 questions. So anybody on the, and maybe I'll put another half so that 3 people can ask. Any questions from the virtual space? Any questions from the physical space? Once, twice. All right. The opportunity has now left. So what is left for me to do is to thank Professor Abdul Kadri for his very insightful presentation, and I invite the room to join me. Thank you, Professor.
Thank you very much.
And I guess you will share your paper, you say, right?
Yes, sure.
Yes, because Ministry of Health is interested in the last recommendation.
I think they already have it. Yeah, Ms. Mullins already has it.
Okay. All right.
Thank you.
So moving right along, the program says commercial break. A 2 minutes commercial break, and the clock is running. All right, so I join you again for the next Health Econ session in 2 minutes. Thank you.
The Oversight Committee visited the site and inspected the building, and we all concluded that it was a worthwhile building to renovate. To construct a new building would cost 10 times as much of what we are spending to do the renovation.
The hospital is a 450-bed facility. It was pretty much full and has been consistently so. And the options to close would mean having nowhere to put persons. People would literally die if we close the hospital.
This project is approximately $3.5 billion. The first phase was to fix the roof, fix the structural problems. The second phase was to the demolition of the building. That is to remove all the internals, because a lot of them were identified to be mold infested. And then the third phase would have been the rehabilitation of the building.
We have not compromised on one service, one era of service that we are doing before the hospital was closed. We would have removed and built a standalone building to accommodate our CT machines, our X-ray machines, and so on. We would have expanded our accident and emergency unit, constructed intensive care units to be used for COVID, converted living spaces into wards, constructed 3 additional operating theaters, expanded even our dialysis area. When it is completed, we'll have a brand new hospital, a brand new building, brand new facilities, modern facilities, because it is totally being redesigned.
The collapse of the Cornwall Regional Hospital posed a challenge to public health that I don't think we have seen post-independence. We engaged in a technical assessment to determine the value of what existed despite the challenges that were there, and it was determined that the building was sound. What we needed to do was to correct the air quality issues at the institution. You had to continue to use the building even with the challenges that you faced and the risks that were involved in that process of air quality issues, while transitioning and creating additional infrastructure around that main building to continue the services that were essential to saving lives. I'm hoping over the next year or so, we will make substantial enough progress to see a gradual return to normality. Cornwall will one day become the best hospital in the West and probably one of the best in the Caribbean, based on the work that is being done now.
This project is approximately $3.5 billion. The first phase was to fix the roof, fix the structural problems. The second phase was to the demolition of the building. That is to remove all the internals, because a lot of them are identified to be mold infested. And then the third phase would have been the rehabilitation of the building.
I'm hoping over the next year or so, we will make substantial enough progress to see a gradual return to normality of the main building. I will be elated, not just for me or for the ministry, but for the people who use the facility. Doctors and the nurses who have put up with all the challenges over time, the patients who use the facility, who have understood the nature of the inconveniences and why this is the case.
It's time? All right. Welcome again, ladies and gentlemen, from that short commercial break, those in the virtual space and those present here. We're now moving into the second session, the second health economic session. We have 4 presenters. We will take 2 first, then question and answer, and then we'll take the second 2. So the first 2, it's my pleasure to introduce Dr. Valence, okay. A. Jordan, he's an ophthalmologist at the Cornwall Regional Hospital. He holds DM in ophthalmology from the University of the West Indies and is a fellow of the Royal College of Surgeons of Glasgow. That's in Scotland, ladies and gentlemen. His main interests are in glaucoma, anterior segment surgery, and oculoplastics. I hope I got that correct. His presentation will be on vision-related quality of life in Jamaican glaucoma patients and economic perspective. Our second presenter is Dr. Kimikawa Morgan Channer. Right, got that right. And she's an internal medicine consultant. She's a board-certified physician with the American Board of Internal Medicine. She is the American College of Physicians 2018 to 2019 IEP Fellow Awardee in Stroke/Vascular Neurology at the University of Miami-Jackson Memorial Hospital, Stroke Center, Florida. She's presently the Senior Registrar and acting consultant at the Kingston Public Hospital. Her passion is stroke education and hopes to improve stroke care and prevent stroke in Jamaica. And her presentation is titled Financial Burden of Inpatient Stroke Care at Kingston Public Hospital in 2020. They each have 10 minutes to share their work with you. So I invite them, with your help. I start with Dr. Jordan. So help me welcome him. And also welcome Dr. Morgan Channer too. So just a quick slip in and out.
Good morning, everybody, and thank you for having me. Okay, so this morning I'd like to talk a bit about a topic that I think doesn't get enough attention in Jamaica, which is glaucoma. So this is a study that we did, but I'm actually looking at the economic perspectives that we found as a result of the study. So first of all, glaucoma is a disease. It's actually a non-communicable disease in which there's progressive damage to the optic nerve. Now, when the optic nerve is damaged, you get loss of your visual field, and a lot of patients with glaucoma actually have a high intraocular pressure. So if you look at the picture here, you see what a normal optic nerve is like, and you see an optic nerve that has lost a lot of the nerve fibers. So in the center, you see that white area. That's what we call cupping. and that gets worse as the glaucoma progresses. This is a picture to show us what it looks like when you have glaucoma. So you see that you actually gradually lose your peripheral vision, but your central vision can remain right up until the end, until you've lost your vision completely. So a lot of glaucoma patients aren't aware that they're losing vision because they're able to read and function otherwise sometimes. Now, glaucoma is one of the leading causes of blindness in the world. The United States spends about $2.5 billion annually to treat it, and it's about $1,000 to treat each patient. But it's not just a worldwide problem, it's also a Caribbean problem and a Jamaica problem. From the 1950s, we know that at Kingston Public Hospital, Dr. Degazon found that there was a lot of glaucoma there at the time. And from the only regional study we have right now on prevalence, the Barbados Eye Study, about 7% of persons of black African descent had glaucoma. And it's believed to be somewhere between about that and 12% in Jamaica. A study is actually ongoing to determine the prevalence in our population. But what we know from United States statistics is that black patients do worse. They're 4 times more likely to go blind, they're more likely to get it younger, and they're more likely to be at the advanced stage when they're diagnosed. Now, what we aim to do with glaucoma treatment is to lower the intraocular pressure, to prevent progression of glaucoma, and to maintain quality of life in these patients. Now, by progression, I mean evidence that the glaucoma is getting worse. And we can find this either by looking at the structure of the optic nerve or looking at the function of the optic nerve. Now, we can look at the structure of the optic nerve by examining it. You saw a picture before of what it looks like when an optic nerve becomes more glaucomatous. And there's also a scan called an OCT. And then for functional changes, there's visual field testing that finds out if your peripheral vision is being lost. So here is a picture of a printout on 4 different occasions from a patient with glaucoma, and you can see that that black area is getting larger and denser, and that is what we'd call progression on the visual field. And this is to show you a printout from the OCT where there's actually thinning and loss of the nerve fiber layer. To treat glaucoma, there are several options: eye drops, systemic drugs, laser, and surgery. Usually we start with eye drops. Now let's talk about the effects on patients. So it can be functional, psychological, or economic. Functional in terms of losing your visual field. This means that you might not be able to drive or perform other tasks, and also ultimately blindness. And of course, fear of blindness is a psychological impact, and the perception that your function is worse or your vision-related quality of life is worse. And then you have economic problems, which can be direct or indirect. So, or direct include transportation costs, medications, investigations, losing your work or your potential to earn. And then also, family members may also lose their potential to earn, or they may lose days from work because they have to become caregivers. So, from the data that we had, we wanted to evaluate the economic factors that affected our patients at KPH and to determine if there's an association between those factors and the vision-related quality of life. So this was a cross-sectional study, and we collected a lot of data. We actually had 96 participants with a mean age of 67.4. All were of African descent. I mean, it's Jamaica, we're predominantly of African descent. And then 54.2% were female, and the remainder were male. A lot of our patients had comorbidities as expected. 29.2% were diabetic, 66.7% had hypertension, and as you know, these also mean more healthcare costs for these patients. Now, this is a slide that I think we should look at very carefully, because of all the patients, 96 patients, 76% of them had a monthly income of less than $50,000. Jamaican dollars, not US dollars, Jamaican dollars. That's a problem. Also, remember the average age was 67, so the majority of these patients were also retired. That's 56% of them. 16% of them were unemployed. Only 28% of them were employed. And then, with regards of what medications they were on, the most common was the prostaglandin analog, which is the first-line eye drop across the world. But you can see that the cost is quite a lot. It can be up to $12,000 for these patients. And remember, they're only earning about $50,000 per month. And not only that, but a lot of patients were on more than one medication. 41 were on one eye drop, but progressively, 24 were on 2, 18 were on 3, and those costs obviously are going to add up. Now, visual fields. I showed you before what it looks like to have progression on a visual field. It's very important to know if the glaucoma is getting worse so that we can either add eye drops or we can try other methods of treatment. But the patients, within the past 2 years, only 26 had a visual field on record. And this is something that should be done every 6 months so that we can know if there's progression. And only 17 within the past year. So this is poor. It costs about $5,000 to get a visual field. But most patients didn't have one. And the reason, we'll come to in a bit. Now, with regards to the quality of life, we couldn't find an association with the marital status, the employment status, or the education level. And unfortunately, we couldn't really compare based on income because the vast majority of the patients had a very low income. But what we did find also is that rural patients actually had a lower vision-related quality of life than urban patients did. So this is noteworthy. Male patients did worse than females. So we have to consider why this is and what could be done to improve the quality of life and to reduce the risk of blindness in these patients. Because in the study, actually 24% of the patients were blind in at least one eye. So what I want to talk about is how can we improve patient access to medications, given that they have such low income. And thankfully, the news isn't all bad, because we do have the National Health Fund and JISTV, and glaucoma is thankfully one of the medical conditions that is subsidized by the NHF and JISTV. But we have to make sure that our patients are getting this. Also, investigations. Remember, I showed you the visual field, I showed you the OCT, but you see that our patients are not able to access it, and the reason is likely because they have such low income, and the visual field is going to take up such a large chunk of that. So it would be important to have a visual field machine in the public sector. Actually, since glaucoma is so common, it should really be in every public hospital that has an ophthalmology department. Sadly, only the University Hospital of the West Indies and KPH have a visual field machine, and neither of those are working. Kingston Public Hospital has an OCT machine. It is working for now, but we have to make sure that it is serviced. But it's very important that at some point we get visual field machines in all of these hospitals. It's a big problem. Also, financial support. The Jamaica Council for Persons with Disabilities can provide a grant to help patients with medications, but this is one-off. This is not a monthly thing. So, in conclusion, the majority of glaucoma patients that we had at the Kingston Public Hospital are from low-income households. And we can see that glaucoma would further affect this by limiting their earning potential and causing loss of work days. And even though healthcare is free, patients may have to pay out of pocket for their medications and their investigations. And finally, and I've put this in bold because I want you guys to remember this, visual field testing needs to be available in the public sector. Thank you very much for your attention.
Good morning, everyone. I want to thank the Ministry of Health and Wellness to give us this opportunity to present evidence that have impact on the quality of care that we offer Jamaican citizens at the Kingston Public Hospital. So, stroke. Did you know 1 in 4 globally has a lifetime risk of stroke? 1 in 4 globally will have a stroke in their lifetime, globally. But what do we know about the economic burden of stroke? They say estimated costs of stroke care is enormous. They say approximately 34% of global health care expenditure is spent on stroke. And so we thought we should look at the stroke burden, the financial direct costs of stroke. So, financial burden of inpatient stroke care at Kingston Public Hospital for 2020. I'm one of the investigators. Other investigators include Dr. Amazad Ali, Dr. Kadeh Wright, Sister Diane Buckley-Smith, and Dr. D. Henry McCoy. We estimated the direct cost of stroke care at Kingston Public Hospital for every stroke patient admitted through the Accident and Emergency Department. And this was for the year 2020. We estimated the total direct costs for the health system perspective using an incidence-based approach bottom up. And we estimated the direct costs for stroke etiology workup, such as echo, EKG, CT scan. And then we looked at inpatient costs on the ward, nutrition, when a patient has to get an NG tube, enteral nutrition, the nursing supplies that we do for our stroke patients on a daily basis. And we use a 4-day as the typical average stay for a stroke patient. Then we looked at the disability of the stroke patient, which is the MRS score of 4 and 5. That means the person is moderately or severely disabled. They require help for activities of daily living. They need to be turned. They need to be fed. They are immobile or partially mobile. Then we looked at this kind of patient passing through the model KPH stroke care pathway, where that patient comes in A&E, they're assessed quickly, they get a CT scan, they're determined if they are a candidate for thrombolytic therapy or IVTPA, and then they are admitted to the ward where they're monitored, rehab consultations happen, and nursing care and nutrition occurs. And then once stroke workup is done, they are discharged within 4 days. So this is the model average stroke care pathway analysis for a patient in 2020. All right, so we did not look at outpatient costs for stroke. We assumed that most people use this model stroke care pathway. And just to note that some people take time to get their CT brain inpatient, if at all, based on the limitations at KPH. So, lack of acute imaging upon arrival in A&E is one of the limitations we have with the stroke care pathway. And therefore, we are unable to determine if this patient is a ischemic stroke or a hemorrhagic stroke in that 4 days. And because of that, we are unable to do direct costs for the person who has an ischemic stroke who is an eligible person for IVTPA. So what we did was we looked at world statistics or the American Heart Association circulation journal, where they estimate that 7% of stroke cases are eligible for acute stroke care management with IV thrombolytics. And then 87% of these strokes would be also ischemic stroke. All right, so of the 1,090 stroke patients that came through the A&E department at KPH through the year of 2020, 948 strokes were likely ischemic based on these assumptions. And so our results, direct costs per patient range from $97,103.40 to $276,373.70 Jamaican dollars for the average length for a 4-day stay for the stroke patient, as I mentioned earlier. Total direct costs then could be estimated for 2020 to run as high as $117,674,551.74 Jamaican dollars, which approximately works out into US $764,120.46 US dollars. So, our conclusion. Our data suggests that the total cost for direct stroke care for KPH is over 117 million Jamaican dollars for 2020, a significant financial toll. Our study does not include stroke outpatient costs, which could be not only financial, but psychological, and also the loss of earning potential for the family and the individual. The financial loss from disability affecting a stroke survivor and their family is significant additional variables that we would love to investigate further. However, one of the limitations with our KPH stroke registry is that it is not an electronic medical record, so certain things are not captured. We're able to capture gender and age, but demographics such as the lifestyle risks that stroke have, factors such as diabetes, hypertension, is the patient obese, where are these patients coming from? We are unable to capture with our manual counting system that we have for the KPH stroke registry. And so we're looking forward for the technocrats to put in that electronic medical record so that the information that we have is as accurate and reliable as possible. And we can use that to impact the care that we're having right now. Right now, we know thousands of people are passing through stroke care, and this is just A&E. We're not looking at other places where we're having stroke, and they are being serviced at KPH. And how the stroke care model is being limited right now, where we're unable to say how many people are getting CT scan. If we have electronic record, we have an integrated system, we can look at that. How are we addressing? Because time is brain. You lose 1.9 million brain cells after every minute of a stroke. Time is brain. So we can't have patients waiting 24 hours. We can't have patients waiting 6 hours. We need to get patients into the CT scanner within minutes. The stroke target guidelines for the American and adopted by the World Stroke Organization, we need to get people to CT within 20 minutes. And we need to get people to therapy within an hour. So we need national-based programs to promote healthy lifestyle, which we know are impacting our stroke numbers, to reduce the prevalence and modifiable risk factors of stroke, which also will reduce the financial burden of stroke, island-wide, including KPH. Thank you so much for allowing me to share the data for the KPH Stroke Registry Group. We hope the technocrats and everyone will make a voice for the stroke patients. Let's do stroke care at international level, because we're Jamaica and we can. We little, but we talawa. Thank you, everyone.
Okay, thank you, Dr. Jordan and Dr. Morgan Channer. Ladies and gentlemen, the mic is on? Oh, I have to lift up this? Okay. All right, thank you. All right, We have the Q&A now, but what we're going to ask you to just indulge us, those are the people inside here. We will work through the break. We'll take the questions. You can go get your break, ask your questions, and so. Is there any questions, though? Yes, a whole heap hands. So which one we take first, the online or the in-room? In-room? All right. I saw a hand there. I'll take that hand, then, okay. All right, I'll take this hand then, and then the one on the back.
Okay, so this question is for Dr. Kimwawa. The disability adjusted life years lost, you had indicated that later on it would be calculated.
We would hope to, we would be hoping to do that kind of work, yes.
Okay.
In the future, we'll look at that data, but as I said, there is limitation with the manual counting as well as the logistics of creating a disability adjusted years. We could look at it from a formulation sort of way, so we can look at that, definitely.
Okay, so my question is, what is the last disability adjusted life years lost for stroke persons? And I noticed you calculated some cost, and to what extent does it impact GDP? I don't know if you have done that, but if you haven't done that yet, it would be good from a health economics perspective. And by the way, let me say it's an awesome presentation. You have us quite captivated.
Thank you so much. Definitely we have to look that up in the future.
Okay, second question.
Thank you, Mr. Chair. Thank you for the opportunity to comment. I'd like to thank both Dr. Jordan and Dr. Morgan Channel for these wonderful presentations. It is so important for us to put cost to the services that are provided. And, you know, we're of this impression that healthcare is free, but it costs somebody. And the other thing I'd like to speak to, as it relates to a comment Dr. Morgan Chana made regarding electronic healthcare system, I am always of the impression that we should practice proper documentation with our paper-based system so that we can have an efficient electronic system. Because if you don't do that, you're going to have rubbish in, rubbish out. Because if you're not practicing with what you have to do the correct thing, it's just going to move right into electronic system. And so I know that the electronic system would provide access and manipulation of the information that is there, but I'd like to encourage us, because it limits the information that we're able to get to inform planning when we don't use what we have efficiently. That's just my comment. Over to you, Mr. Chair.
Okay. Thank you for those comments. Another question?
Okay, thank you. Thanks to both presenters, two very good presentations. To Dr. Jordan, glaucoma and an association with the lower economic status, I found that correlation quite surprising. Can you expand on that a little bit more? I thought glaucoma would just attack anyone randomly. So glaucoma and it being associated from your study with the lower socioeconomic group. Is there a correlation that, or it just was particular for your study?
Well, the thing about it is I think that the study mostly had patients that were of low socioeconomic status. So unfortunately, we can't compare with those who have probably sought private care elsewhere.
Thank you, because I was wondering, I was quite surprised that it might just be associated with only those of the socioeconomic group, but your study was limited to that particular group.
Well, that's the population that we have at KPH for the most part.
Okay, thank you. Good.
Okay. No more questions from the room. The questions from the virtual space.
Dr. Jordan, since glaucoma care and management is so expensive and not easily accessible, could public education programs aimed at preventing glaucoma help prevent increase in this condition in our population?
Well, unfortunately, primary open-angle glaucoma, which is the most common glaucoma we have in Jamaica and worldwide, isn't something that you can prevent. There are genetic factors at play here, and there isn't any real way to prevent it. What we can do is actually catch it early and then treat it. And the earlier we treat it is the better the prognosis for the patients, and the less loss of visual field, etc. But of course, in order to know if their visual field is getting worse, we have to be able to know what's happening to the visual field. So I think that if we're going to have a campaign, it should really be to let people know that if they are over the age of 40, particularly if they have a family member, first-degree relative with glaucoma, that they need to see an ophthalmologist and be screened. Because the patients are coming in late. That's why so many of them are going blind.
Do you think that cataract-induced glaucoma has been factoring to the number of glaucoma cases? And do you think that having the cataract surgeries in public health system readily available would impact the situation of glaucoma in Jamaica?
The truth is that cataract-associated glaucomas, they're not that common in terms of all the glaucoma that we have. Definitely, it's important that we have more cataract surgery. That's another topic altogether, because cataract is also very common. But thankfully, this is something that is reversible with surgery, unlike glaucoma, which is a permanent loss of vision. So definitely, it would be good to do more cataracts, and a few patients may develop glaucoma associated with their cataracts. But for the most part, primary open-angle glaucoma is the problem that we have in Jamaica.
Dr. Morgan Channel, will your stroke registry be expanded to include other health facilities? And do you register the time of onset and time of seeking first contact with the healthcare facilities in the stroke registry?
So what happened now is that we are unable to do time of when the patient was last seen normal, what time of arrival. We are unable to do time endpoints based on what we have available in the A&E admission processes. So it is something we definitely need to do to appropriately analyze the stroke care pathway and to make sure we're up to international standards. Right now, we have a study going on as how long does it take to get radiological imaging for acute stroke. That is being done electronically by all members of the health team, primarily or medical doctors, when they are discharging stroke patients. So we're now looking at that particular variable, but definitely time endpoints need to be looked at, and when the data is when it's easy for medical staff to put in that data, then we will look at it for sure. But we're now starting and looking at how long does it take for a CT brain to be done for stroke care.
Okay. What are the plans, if any, for stroke patients at other facilities in Jamaica? Say, for example, at Cornwall Regional Hospital, what are the outpatient resources available there?
So I'm going to ask you to just look at, this is on the side, because KPH is Territory Referral Center. We only looked at KPH. But definitely plans are afoot with the Jamaica Stroke Alliance, which I'm connected to. And you can contact Jamaica Stroke Alliance at gmail.com, where you're going to get some information on what's happening, what we're going to be doing in developing stroke care at other territory institutions. A matter of fact, the the Minister of Health and Wellness was at the Brazilian Stroke Summit, and he made commitments that we should have primary stroke centers at KPH, at Cornwall, and UWI Hospital. So plans are being worked out, and it will come in soon. I'm also part of helping that implementation.
Okay, Dr. Jordan, what could account for someone diagnosed with glaucoma but having normal intraocular pressure?
Okay, so there are different kinds of glaucoma, and most patients with glaucoma actually have a high intraocular pressure, but what we also have is normal tension glaucoma. Now, the theories as to why the damage to the optic nerve is present are both to do with direct injury from the pressure in the eye, but also a vascular problem at the optic nerve level. So it's believed that to a large degree, these patients who have a normal intraocular pressure may actually have something vascular affecting the optic nerve. So people who have like nocturnal hypotension, persons who are especially taking their hypertensive medication at nighttime, we can't tell if their blood pressure is going low at nighttime, if they've been in an accident or something and have a hypotensive episode. This can affect the optic nerve as well. But apart from that, what we consider to be a normal intraocular pressure, this is for the population in general and taken at 2 standard deviations from the mean. But that doesn't mean that that is normal for everybody in the population. So actually, it could just be that their optic nerve is unable to withstand what we consider to be normal, but is not normal for them.
Okay. All right, so that was the end of the question and answer session. Sorry, you have to ask him outside. All right, so now, ladies and gentlemen, we're moving into the second phase of the health econ section. Our other 2 presenters on this side, Dr. Heather Reed Jones. She has been a medical doctor for over 30 years and a public health specialist. She has held several positions in the public health sector, including Regional Technical Director of the Southeast Regional Health Authority since 2021. She has been on assignment to the Office of the Chief Medical Officer and has been conducting a COVID-19 impact assessment on service delivery in the public health sector. She's also involved in the Primary Healthcare Reform for Jamaica initiative, and her presentation will be the assessment of the impact of COVID-19 on cervical cancer screening in Jamaica. The second presenter is Dr. Adedamola Soyibo. I got that right? Thank you. He's a consultant neurologist at University Hospital of the West Indies and a lecturer at UWI Mona. And his presentation is adding injury to infection, COVID-19 disease, and acute kidney injury, AKI. Ladies and gentlemen, virtual and in space, let us welcome them. And also thank the previous 2 presenters as well. They will keep their seats until the end.
Good morning, everyone, and thanks to the committee for inviting me to present today. We'll be looking at an impact assessment of COVID-19 on cervical cancer screening in Jamaica. Okay. Cervical cancer, we know, is highly preventable through a program of vaccination and robust screening. In 2016, less than 50% of women ages 15 to 54 had a pap smear done within the last 3 years. And 2010 revealed a cross-sectional study revealed a high prevalence of human papillomavirus. The World Health Organization has a target to eliminate cervical cancer as a public health problem by 2030, meaning having less than 4 cases per 100,000 women per year. So what's the situation in Jamaica? We see, compared to our Latin American and counterparts, both for incidence and mortality, we are quite high, almost twice and almost 3 times. And cervical cancer is the 5th leading cause of cancer-related mortality and the 2nd most common cancer in females. The first case of COVID-19, which we all remember well, was confirmed in March 2020, and that resulted in a suspension and or scaling down of services in the government health facilities. And in 2021, the CMO commissioned an assessment to look at the impact of COVID-19 on the public sector for all officially sanctioned programs and services. The presentation's focus is on the cervical cancer program, which is primarily executed at health centers and at the gynecological services in secondary care, and targets women between the ages of 25 and 54, and especially high-risk women such as female sex workers. And the overall aim is to reduce the incidence of cervical cancer in Jamaica through interval pap smear screening. The data was obtained from the Cervical Cancer Program database at the Ministry of Health. Exclusion criteria, pap smears done in the private sector, whether in hospitals or private offices. Secondary analysis of data on first ever and new pap smear procedures for 2015 to 2020 was carried out. 5-year thresholds were prepared by determining the mean and standard deviations per quarter for 2015 to 2019. Data for 2020 was then compared with the threshold levels. Mean and first ever pap smears were computed per quarter for 2015 to 2020. Statistical significance testing was done and the data was disaggregated by regional health authority. The results, we'll start with the Southeast Regional Health Authority, and just to get you orientated a bit, the blue bars represent 2020, the green lines, the mean, and the 2 red lines represent the upper and lower threshold. So we look at first ever pap smears for sero. Decreases in first ever pap smears were observed in all quarters of 2020 compared to the mean. First ever pap smears in the 2nd and 3rd were below the lower threshold at 31% and 27% respectively. For total pap smears, the 2nd quarter was below the lower threshold and also 44% less than the mean. We move to the Northeast region. In Nero, for all quarters in 2020, the first ever pap smear was below the mean, and we note particularly in the 2nd quarter and the 4th quarter be less than 72% and less than 43% respectively. Total pap smears in Nero, the 1st, 2nd, and 3rd quarter were below the mean, with the 2nd quarter being below the threshold. Moving to the southern region, first ever pap smears fell below the mean in the first 3 quarters, decreases ranging from 10 to 41%, but there was a rebound, thankfully, in the 4th quarter. For total pap smears, this was below the mean for all quarters, with the 2nd quarter be also 41% and below the lower threshold. And for the Western Regional Health Authority, we see first pap smears below the mean for all quarters and marginally so, although marginally so in the 1st, 3rd, and 4th below the threshold. And for total pap smears, we see the last 3 quarters in particular being below the threshold. In terms of statistical significance testing, For total pap smears, this was significant for Sarah, the southern region and the western region, and for the northeast region, this was for first ever pap smears. And this just shows that 2020 really was not a good year in terms of the mean number of pap smears done, both for first and for total pap smears. So to summarize our results, the number of pap smear visits per quarter was lower in 2020 than for all other years across the RHAs. First ever and total pap smears for 2020 fell below the threshold levels for at least 1 quarter in all 4 health regions, indicating notable reductions in pap smear screening during this period. Okay, so what are the possible contributory factors to the reductions? We all would have experienced the non-pharmaceutical measures, which included movement restriction, and probably women prioritized what was important to move if you had to move during COVID. It's also possible that there's a fear of exposure to COVID at health centers, and so coming for probably what is not deemed an acute situation discourage persons from coming. We know our human resources were constrained because a lot of family health staff who are primarily involved in the COVID response were diverted to the COVID response. There would have been less interactions with health staff, and amidst all the COVID messaging, there may be an actual or perceived reduction in national cancer prevention messages. Limitations: there's no mechanism to identify women who opted out of treatment, nor were we able to look at missed appointments, as this would require a manual review. We don't know if women sought services alternatively in the private sector, and we were able to assess the influence of a lack of access due to clinic suspension. And finally, we were unable to assess any non-COVID impacts, such as closure for infrastructure work. So the conclusion is pap smears in government health facilities declined in 2020. Promotion of cervical cancer screening among first ever clients may be needed to increase testing to pre-pandemic levels and improve our overall coverage. In terms of interventions that work, Black in 2002 found that combining mass media campaigns with other strategies are more effective. Group education included, as well as personal invitations and automated reminders. And HPV self-testing in Central America was found to increase the coverage, although we would have to see if that is socially acceptable and culturally acceptable in our settings. Our recommendations: conduct surveys among women who kept appointments to determine the reasons for compliance. The regional health authorities to do a review of their programs to determine the resource needed. The National Action Plan to accelerate elimination of cervical cancer. These are a list of references, and I especially would like to thank the NCD unit of the Ministry of Health, the health departments, the regional NCD coordinators, and of course the National Epidemiology Unit team who are responsible for the analysis. Thank you.
Good morning, everyone, and thank you for the invitation to share this paper with the rest of Jamaican population. I'm a nephrologist, not a urologist. Can I get the slides being displayed, please? I'm not seeing it here. Okay, thank you very much. Okay, so my role this morning is just to give you a little snippet of what, COVID-19 has done to us. Well, most of the data, all the data is from University Hospital of the West Indies. And there are other presenters after me that will share, the impact of COVID in specialized population. Not to mention the fact that we did have a lot of persons with COVID-19, and acute kidney injury was one of the very miserable tasks of having to provide dialysis for this patient during the pandemic. So first, I would like to thank all the collaborators, and I would like to present this on their behalf. So it's a big thing with COVID-19. I think personally, I am mentally traumatized by it. But nonetheless, we managed to sort of collect data to see what was happening with COVID-19. So the initial study, the grant was given for 2 years between March of 2010 all the way to March 2022, which completed this year. But the data I'm going to be presenting has to do with just the time period of 1 year. And at the time when this was written, there were approximately 40,000 persons confirmed with cases, with 613 deaths. And majority of the deaths occurred in, at least as we know, in the tertiary hospitals, because those are the persons who present with hypoxia and seeking medical attention. We're not sure about those who stayed home and those who died. And as you can imagine, we will not know about those persons who would have had acute kidney injury and they remained at home. So the initial objective of the study was to sort of know what's the prevalence of AKI in COVID-19 population and what are the related risk factors for these patients that were admitted to a tertiary institution between the time frames specified. But this was later modified for this presentation to look specifically the negative predictors of outcome in acute kidney injury patients of Afro-Caribbean descent. And this was done in one particular center. So all the patients who were diagnosed with SARS-CoV infection confirmed by PCR were included in the study and during that time period. And those that were excluded are patients who have indeterminate or unconfirmed SARS-CoV infection, or patients with SARS-CoV infection who were not admitted to the University Hospital of the West Indies, and also patients who historically will have reported having a pre-existing renal impairment. So we're looking purely at those persons who've had first-time kidney disease, acute kidney injury diagnosis. So what was the case definition of AKI? So we used the KDIGO definition, which is when you have an increase in your serum creatinine more than 1.5 times from baseline, if you know what the baseline is, in the past 7 days, or an absolute serum creatinine rise of more than 26.3 micromoles, which is what we had to use in most cases, in the past 48 hours, or if you're admitted to a unit where urine output is being monitored, you can look at a urine output that is less than 0.5 mils per kilogram per hour for the past 6 hours. And the cases in these studies are selected because of specific conditions of acute kidney injury, either directly or indirectly secondary to COVID-19 disease. So it will be difficult to tease out the difference between those who had acute kidney injury directly from COVID-19 or secondary to other diseases that were happening at the same time. So the method, this was prospective initially and retrospective study reviewing. So we got 138 cases of AKI patient between that 1 year period. And those were confirmed with COVID-19 infection. Now, what we found is we did some, laboratory investigations. So we looked at the CBC, the URNAs. We focused on also the presenting symptoms, those who had dyspnea, those who had fever. And we looked at the requirement for aggressive management associated with severe COVID. So, if they were admitted to the ICU, if they required ventilation, non-invasive, invasive ventilation. And of course, the likelihood of a fatal event was evaluated using a univariate and multivariate analysis among the study population. So of the 138, most of the patients were in stage 1, 49%, which is in keeping with international standard, or what they found. And also stage 2 was 17%, and stage 3 was 34%. These are the ones who will require some form of renal replacement therapy. And the mean age was 62, a little bit higher than those that were reported in meta-analysis, which was like about 52.4 years of age, and they were predominantly male at 59%. And the presenting symptoms like dyspnea and fever were the most likely to be associated with adverse outcome. Interestingly, when we compared this to the AKI, community-acquired AKI, that was done in 2015-2016, we also noted that those who had respiratory or dyspnea and fever accounted for most of the presentation and the adverse outcome of developing AKI. And the mean serum creatinine difference, so those who had creatinine and presentation and the maximum creatinine that they reached, were indicators of AKI severity and also mortality. So continue with the results. Most of the patients we had AKI to be, we found it to be oliguric or anuric. They were more likely to receive remdesivir. I know there are, discussions out there about, toxicity, nephrotoxicity of remdesivir, but in most of the studies, what they found is actually related to the disease process as opposed to use of the drug, and those that require dialysis. Also, increased mortality was associated with increased number of symptoms. So the more symptoms you have on presentation, the more likely that you are going to develop acute kidney injury. And of course, those who were anuric or oliguric also. Now, what was interesting was low serum albumin. That was not something that was expected, but low serum albumin was also a significant predictor of mortality, as well as, patients who are not passing that much urine. So to conclude, in that study, what we found was like low serum albumin levels and increased number of symptoms at presentation are the key predictors of adverse outcome in AKI patient with COVID-19 infection. Now, we must say that the limitation of this study is the fact that this is a single site study, and the findings are not, do not contend for COVID-19 positive individuals who were hospitalized in other private hospitals, or even the major hospital like KPH, Cornwall Regional Hospital, Spanish Town, Manda Regional Hospital, which we will love to have, information, and we do invite, collaborators on that. And also, we don't know what's the prevalence of those persons who were not actually hospitalized. Thank you very much.
Okay. All right, so we'd like to thank the two presenters for this session, Dr. Reed Jones and Dr. Ademola Soyibo, consultant nephrologist. I guess I got it wrong the first time. My apologies, sir. All right, any questions in the room first? No. Online? No. A question is behind me? I can't see. Okay.
I wanted to ask Dr. Soyibo, it was interesting that remdesivir was one of the variables that was associated with the increased likelihood of developing stage 3 AKI. Is remdesivir known to have some nephrology impact, nephron impact?
Hello. Yes, thank you very much for that question. So we do dose, we know that remdesivir is potentially can be, and with all the noise that was going on during COVID-19, we do adjust for kidney function, and depending on the GFR, it may be also contraindicated, as well as, if you have hepatotoxicity. But I think in this study and in most other meta-analysis, what we could probably look at is the fact that there were specific indications for those who would benefit from remdesivir when they have COVID-19. And that usually will imply you have severe disease. So when you see severe disease, you're more likely going to develop AKI as opposed to the drug being the cause.
All right, so I guess there are more questions? Oh, okay. All right, so who first?
I have a question for her.
All right, they're trading questions, and we'll get to you.
So thank you very much for that presentation. So the question I have, just hearing your talk, is so there's definitely a drop in health-seeking behavior, I think, in general, and you're looking at cervical cancer. Now, what I want to know is, you probably won't have the information, but it's probably worth looking at also, is the fact that what is the percentage positive rate for those that were screened? Reason why I say that is, if you have a high positive rate and you have a significant drop in your screening during that period, is it that we will have missed potential persons that we could have treated and saved in the early stages?
Okay, thank you. And indeed, I don't have that information. It is probably something that the NCD unit would like to look at in more detail along with the regional health authorities. Unfortunately, a lot of our registers are manual, and so it will take a bit of sorting through to see what happens.
Okay, no more questions behind me, so Naman, I'll take the questions from the floor now. So, go ahead.
Hi, excellent presentations. So my question is to Dr. Sebo. So we know that as nephrologists that acute kidney injury increases your risk of CKD later on. Is there a plan to follow the patients longitudinally to see what their outcomes are? Does it cause progression of CKD if they had underlying CKD, or progression of worsening renal outcomes?
Yes, excellent question or comment. So we know there's a nexus between AKI and CKD. And in this population of patients, yes, so we will have something put in place because we have their contact information to look at their progression if they do. Unfortunately, because of the number of deaths, it might be difficult to get the actual numbers to make any statistical significance in the future. But we do plan to follow them up.
Okay, so mine isn't a question. It's just to add to what Dr. Heathery Jones had pointed out regarding the cancer care during COVID-19. We recognize that for the insertion of the IUD, that figure had also dropped significantly during COVID-19. And upon investigation, we realized that it was because of fear of contracting the virus from both the healthcare provider and the patient. And Dr. Kimi Kawa, this is not a question for you, but just a recommendation for the health economists in the room, like Mr. Howard Lynch. We were having a discussion earlier, and we noted the seriousness of your presentation along with Dr. Soibo. And the question is, what's the cost for when you delay care? We talk about disability-adjusted life years lost and its cost and its impact on GDP, but does one take time out to look at the delay in treatment, the delay in care? And so It may not have happened yet, but we hope that it is one of the recommendations going forward from this conference. Over.
Yes, thank you so much. As I said before, we're looking at delay in CT brain imaging. And as I said to you, if you do not have brain imaging, you do not know what type of stroke you're dealing with. And therefore, you're unable to determine if the patient is an IV thrombolytic candidate or not. If the patient has hemorrhage, it's a totally different stroke care pathway from a patient who is an ischemic care pathway. And therefore, brain imaging is huge. So we're looking at one aspect, delay in imaging.
Thank you. Thank you for your presentations. Good morning, everyone. It's a pleasure to be here. I have questions for presentation 15 and 16. That is Reed Jones and Dr. Shoimbo. Now, for Reed Jones, the case of the cervical cancer screening, could it have been a case where we were being told not to come to the hospital? If you have X and Y, don't bother come. Probably those individuals would have sought medical care elsewhere, or don't even bother to seek at all, like that was not to them life-threatening. Okay? That's one for you. Then for Dr. Shoimbo, now that we know that remdesivir, the drug that was utilized, could, okay, let's assume those who had the problem were given these drugs, it was a small population. Do you advise, in your opinion, to continue to use the drug, knowing that some persons who will have severe disease already based on COVID, and do we still use this medication on them, or do we seek alternative? Thank you.
Okay, thank you for your observations and comments. At various times in 2020, and actually even continued into 2021, services were suspended, and particularly hospitals went into emergency mode. And I believe some of the outpatient departments were scaled down significantly or suspended. And then we also have to recognize that if I don't perceive it as something acute, it's not something that I can see, perhaps I will wait until this is over, and then all the other complications of life with COVID would probably have put it on the back burner.
Yes, so let me just, repeat. So I'm not saying that remdesivir caused acute kidney injury. And when you look at this, it's not a lot of people out there who would biopsy those persons with acute kidney injury. But in those series that got biopsied, it was a small number, like about 44. What they found was most of them had FSGS, which is focal and segmental glomerulosclerosis, so which is like a glomerular problem. But the majority had acute tubular necrosis. Acute tubular necrosis is what you will find in anybody who has severe sepsis, who has ARDS. So the pattern of AKI was not different in acute COVID-19 patient compared to what you will find in a normal ICU setting, or in a very sick patient.
Okay, so that's it. No more questions. All right, so ladies and gentlemen, in the virtual space and here, join me in thanking our panelists for a very stimulating presentation and thought-provoking presentation. It could be louder. And ladies and gentlemen, my name is Howard Lynch, and that is my time. So I hand over to the next, I don't know who that next moderator. Oh, that's mine? I get some things.
Mr. Lynch,
Good morning, everyone. Mr. Lynch, thank you for your such able moderation of the 2 sessions, and we hope you will continue to work with us at the NHRC. Thank you.
Thank you very much. It's Christmas.
Thanks again for coming back, everyone. And today, my name is Brandon Christie, and I will be your host for our conference fun. If you're like me, I like winning, so here we are. What you need to do is just to send in your name and the answer via text message or WhatsApp to 876-344-3204, and that number is 876-344-3204. So here we go with the questions. The first question for our conference fund today would be, when was the first National Health Conference research? The first question is, when was the first National Health Research Conference? The second question, what was the theme for the 7th conference in the year 2016? What was the theme for the 7th conference in the year 2016? And remember, guys, please to text your name and the answer to the number 876-344-3204. The third question today, how many posters are being presented for NHRC 2022? How many posters are being presented for NHRC 2022? The fourth question for us today, what is the name of the poem commemorating our Health Research Conference 2022 theme? What is the name of the poem commemorating the NHRC 2020 theme? And the last question for us today, that I am sure some persons will have the answer to, is what is the name of the virtual partner for the NHRC 2022 conference? What is the name of the virtual partner for the NHRC 2022? All winners will be advised to pick up your prize at the Ministry of Health headquarters at 15 Knutsford Boulevard. So please, people, I'd ask of you to just text your name and the answer to 876-344-3204, and all winners will pick up their prizes at the Ministry of Health headquarters at 15 Knutsford Boulevard. And the number again, for those who never heard or never wrote it down, is 876-344-3204. And we will be awaiting all your answers because the prizes are bearing surprises. Thank you.
To provide oversight of the redevelopment of the Connaught Regional Hospital. The oversight committee visited the site and inspected the building, and we all concluded that it was a worthwhile building to renovate. To construct a new building would cost 10 times as much of what we are spending to do the renovation.
The hospital is a 450-bed facility. It was pretty much full and has been consistently so. And the options to close would mean having nowhere to put persons. People would literally die if we close the hospital.
This project is approximately $3.5 billion. The first phase was to fix the roof, fix the structural problems. The second phase was to the demolition of the building. That is to remove all the internals, because a lot of them are identified to be mold infested. And then the third phase would have been the rehabilitation of the building.
We have not compromised on one service, one era of service that we are doing before the hospital was closed. we would have removed and built a standalone building to accommodate our CT machines, our X-ray machines, and so on. We would have expanded our accident and emergency unit, constructed intensive care units to be used for COVID, converted living spaces into wards, constructed 3 additional operating theaters, expanded even our dialysis area. When it is completed, we'll have a brand new hospital, a brand new building, brand new facilities, modern facilities, because it is totally being redesigned.
The collapse of the Cornwall Regional Hospital posed a challenge to public health that I don't think we have seen post-independence. We engaged in a technical assessment to determine the value of what existed despite the challenges that were there, and it was determined that the building was sound. What we needed to do was to correct the air quality issues at the institution. You had to continue to use the building even with the challenges that you faced and the risks that were involved in that process of air quality issues, while transitioning and creating additional infrastructure around that main building to continue the services that were essential to saving lives. I'm hoping over the next year or so, we will make substantial enough progress to see a gradual return to normality of the main building. Cornwall will one day become the best hospital in the West and probably one of the best in the Caribbean based on the work that is being done now.
This project is approximately $3.5 billion. The first phase was to fix the roof, fix the structural problems. The second phase was to the demolition of the building. That is to remove all the internals, because a lot of them are identified to be mold infested. And then the third phase would have been the rehabilitation of the building.
I'm hoping over the next year or so, we will make substantial enough progress to see a gradual return to normality of the main building. I will be elated, not just for me or for the ministry, but for the people who use the facility. Doctors and the nurses who have put up with all the challenges over time, the patients who use the facility, who have understood the nature of the inconveniences and why this is the case.
What will that moment of seeing that project to completion and walking into a new building feel like for you?
Well, you know, for me, it is likely to be, it will be a very fulfilling moment, without a doubt. I'll be extremely satisfied. It could be an emotional moment because we have seen the lows, we have seen the disappointments, we have seen the frustration, and to see now the success of a fully restored building will create joy and maybe even tears for some people. And for me personally, I will be elated, not just for me or for the ministry, but for the people who use the facility. Doctors and the nurses who have put up with all the challenges over time, the patients who use the facility, who have understood the nature of the inconveniences and why this is the case. You know, I look forward to that day, and I will celebrate on behalf of all who will benefit from the restoration, and indeed take those lessons. In fact, I've asked for a case write-up of the Cornwall experience, because I think the lessons to be learned should be transmitted to all across the public health system to avoid any other institution from having the same fate. So in a sense, Cornwall Regional Hospital should be a teaching moment for us. And that's one of the major objectives that I would have in terms of moving the process forward.
Hello, Jamaica. I'm Dion Jax-Miller. It's unbelievable to me whenever I buck up somebody who is still asking if COVID-19 is real. Because my doctor died of COVID-19. I had COVID recently, and it was a severe case. Most of my lungs were affected. I am so grateful to be alive. Take COVID seriously, guys. Some people won't be affected, that's true, but others may have long-term effects, and some people will die. Let's do all we can to protect ourselves and to protect others.
A message endorsed by the Ministry of Health and Wellness.
Severe pains, shortness of breath, worsening with fever, lack of appetite, extreme weakness, and overall grazing beside death's door. This was my experience with COVID-19. Hi, I'm John, and I'm so thankful that I survived COVID-19. As an asthmatic person who lives alone, I know that COVID could have claimed my life. Listen, don't drop your guard with COVID-19. It only takes a second for you to catch a virus. Initially, I thought I had the flu until things got worse. Don't leave your mask, wash your hands as often as you can, and always keep a physical distance from others. And I want to tell every Jamaican to choose a vaccine before COVID chooses you.
A message endorsed by the Ministry of Health and Wellness.
Cornwall Regional Hospital was built in 1974. It was a gift of the Canadian government. They did all the technical work and provided the resources to build the facility.
Over the years, clearly, there was poor maintenance of the building, but also the building was modified by non-experts. People were constructing offices. What that does is
All right, good morning, everyone, and welcome to Scientific Session 5. And we're continuing under the theme for the Health Research Conference, Combating Non-Communicable Diseases, Looking to a Healthier Future. This session will focus on COVID-19, which is still relevant, although we have a non-communicable disease theme. COVID-19 was a cause of increased morbidity and mortality among persons with comorbidities, including the non-communicable diseases. So it's good that we're focusing on it, and we'll do so in this session. I'm Ardeen Harris. I'm a medical epidemiologist and acting national epidemiologist at the Ministry of Health and Wellness, and I'll guide you through the next 4 presentations. I'll now introduce our presenters, starting with Dr. Johan White. You can just nod, Dr. White. Yeah, that's Dr. White. He's a medical epidemiologist in the National Surveillance Unit, a part of the National Epidemiology Team in the Ministry of Health and Wellness. His portfolio responsibilities include HIV, tuberculosis, and sexually transmitted infections. Dr. Lorian Fisher, you can just nod, yes. Dr. Fisher is a consultant nephrologist and intensivist at the University Hospital of the West Indies and an honorary lecturer in the Epidemiology Research Unit of CARE. She completed her internal medicine residency and chief residency at Good Samaritan Hospital in Maryland. The third presenter will be Dr. Andrea Garbott. Yes. She completed her undergraduate studies and doctor of medicine studies in pediatrics at the University of the West Indies, Mona. She has completed a clinical fellowship in developmental and behavioral pediatrics. Dr. Garbott is a lecturer and a consultant pediatrician at the Child and Family Clinic at the University Hospital of the West Indies. And the fourth presenter will be Dr. Patrick Toppin. He'll join us soon. He's doing the poster presentation now. He'll join us when he's finished. He is a lecturer at the University of the West Indies in the Department of Surgery, Radiology, Anesthesia, and Intensive Care. He has completed fellowships in critical care, cardiac anesthesia, and anesthesia for transplant surgery at the University of Toronto. Dr. Toppin has a particular interest in the epidemiology of injuries, understanding the implications of Jamaica's aging population on surgical services, and the creation of electronic medical databases. Make our presenters welcome, please. All right, so we'll move into our first presentation that will be done by Dr. Johan White, and he'll present on anti-severe acute respiratory syndrome coronavirus 2, that's SARS-CoV-2 nucleocapsid antibody status among healthcare and restaurant workers in Jamaica between February and July 2021. Dr. White.
Thank you, Dr. Harris. Good morning, and thanks for the opportunity to share our research in this forum. It is estimated that up to 1 in 3 persons infected with severe acute respiratory syndrome coronavirus 2 or SARS-CoV-2 may have no symptoms, but these individuals may be able to transmit the virus to others. Certain occupations have been shown to be associated with an increased risk for infection with SARS-CoV-2. Testing for antibodies to SARS-CoV-2 may identify persons who had been infected. We sought to describe the seroprevalence in 2 high-risk settings and to explore the performance of a point of care compared to laboratory-based antibody testing. Participants were followed up for 3 months and had antibody testing at baseline, 2 weeks later, and at a 3-month time point. Participants were also invited to complete an electronic survey with questions related to their general health and COVID-19 related symptoms. The study was approved by the Mona Campus Research Ethics Committee and the Ministry of Health and Wellness Advisor Panel on Ethics and Medical Legal Affairs. Participants provided written informed consent. There was a total of 312 study participants. Overall, participants were of median age 31 years, with age ranging from 20 to 68 years. 21% were males, and 129 participants were hospital workers, and 183 were restaurant workers. 1 in 4 participants reported having a chronic medical condition. 1 in 5 resided in a household where at least one other household member was aged 65 years or older, and 50% were first responders or had a household member who was a first responder. Based on Roche Alexis electrochemiluminescence immunoassay, or ECLIA, laboratory testing for antibodies against the SARS-CoV-2 nucleocapsid, restaurant workers were statistically significantly more likely to be antibody positive compared to hospital workers, with seroprevalences of 46% and 18%, respectively. A point-of-care antibody test from SD Bioscience had 93.9% sensitivity and 100% specificity using pre-pandemic frozen archived samples from 43 donors and serum samples from 33 polymerase chain reaction confirmed cases. 2 participants, both healthcare workers, were positive for the IgM, immunoglobulin M antibody, but negative for IgG antibodies on the point-of-care test. Overall, 36 participants, that is 28 restaurant workers and 8 healthcare workers, were positive for both IgM and IgG antibodies. Overall, persons in the age cohort 20 to 24 years had the highest seroprevalence for both males and females. Further disaggregation based on age, sex, and place of work suggested that younger age groups tended to make up most of the positive cases. Anti-SARS-CoV-2 antibody titers were significantly higher among restaurant workers compared to hospital workers. Hospital workers were more likely than restaurant workers to report having received vaccination against COVID-19. As expected, antinucleocapsid antibody titers were significantly higher in the unvaccinated participants compared to participants who had been vaccinated against COVID-19. Seroprevalence among hospital workers over the 3-month follow-up period was 18% at baseline, 20% at 2 weeks, and 24% at 3 months after baseline. Interestingly, hospital workers in clerical or administrative job roles were more likely to be antibody positive and had higher antibody titers compared to clinical staff. Among hospital workers, there was no significant difference in mean titers across study time points. However, the study attrition rate was high. Of the 123 participants who did the questionnaire, 51% reported that they had had symptoms suggestive of COVID-19. This chart summarizes when blood samples were taken for antibody testing relative to symptom onset. Headache, loss of sense of smell, loss of sense of taste, and fever were associated with antibody positivity. A history of being symptomatic, using public transportation, and the place of work were associated with antibody positivity. In multivariate regression analyses, we identified that ever being symptomatic and place of work were significant predictors of antibody positivity. In summary, restaurant workers were more likely to be antibody positive and had higher antibody titers compared to hospital workers. A history of symptoms suggestive of COVID-19 was associated with being antibody positive. We also found that point-of-care antibody testing correlated well with the laboratory-based antibody testing. There are important limitations to consider in interpreting these findings. The study used a convenient sampling approach, and RT-PCR was not available for everyone, as testing was risk-based due to resource constraints. The study's start time also differed for individuals, and attrition in the study was high. In terms of our next steps, we would like to explore antibody function, including antibody-dependent cellular cytotoxicity and their role in preventing infection or mediating post-infection status, such as in long COVID. Recombinant proteins, such as illustrated here, can be used as targets for antibodies in assays, and the ability of the antibodies to bind or trigger cell functions or lyse infected cells can be examined. Assay readouts can be in the form of titers or monitored over time. Thank you for your attention, and thanks to my colleagues and the study participants.
Thank you, Dr. White, and we'll hold the questions for Dr. White until our next presenter delivers her presentation. Dr. Fisher will present on acute kidney injury in sickle cell disease patients hospitalized with COVID-19 infection at the University Hospital of the West Indies, Mona. Welcome, Dr. Fisher.
So thank you, organizers, for allowing me to present our data on acute kidney injury in sickle cell disease patients hospitalized with COVID infection at the University Hospital. So as we all know, COVID infections since November 2019 has occurred in 650 million cases, resulting in about 6.5 million deaths worldwide. As we recall, the first COVID case was reported in Jamaica in March 2020. We've now recognized, after 2 years of experience with COVID, that acute kidney injury or acute worsening in kidney function is common in COVID-19 hospitalized patients and occurs in a range of 30 to 80%. It is independently associated with high mortality. Looking at sickle cell disease, it's the most common hemoglobinopathy in the world, with 300,000 infants born annually worldwide with sickle cell disease. In Jamaica, we have a high burden of sickle cell disease, with 1 in 150 live births in Jamaica. And now, as we've gotten better with managing sickle cell infectious complications, people are living longer with sickle cell disease, and now we're finding that renal disease frequently complicates the life course of sickle cell disease, occurring in up to 70% of persons living with sickle cell disease after the 3rd to 4th decade. AKI is now being recognized as a common occurrence in sickle cell disease, with reported data from North America and Sub-Saharan Africa of a prevalence of 8 to 36% of admissions with vaso-occlusive crisis. Persons with sickle cell disease are 3 times more likely to have acute kidney injury, and when they do, they're 10 times more likely to die. In COVID-19, we found that the mortality may be higher in sickle cell disease and sickle cell trait, and most recently in a retrospective analysis published in JAMA, sickle cell trait itself is an increased risk of AKI in COVID-19 infection. Surprisingly, the mortality of sickle cell disease in COVID was less than anticipated for the in-hospital mortality, with databases with retrospective data from France and United States reporting an in-hospital mortality of 2.2 to 10%. They also found maybe sickle cell SC disease had higher mortality with higher risk of mechanical ventilation. However, in looking through the data, there's no data worldwide on acute kidney injury and outcomes in sickle cell disease itself. Thus, we performed a retrospective cohort study of persons admitted with sickle cell disease to the University Hospital wards between June 1, 2020 to May 31, 2022. We included persons with documented sickle cell disease and a positive COVID reverse transcriptase PCR at the time of admission or in the course of the hospitalization. We excluded persons with end-stage renal disease or dialysis pre-admission, or children under the age of 1. Our data was collected through chart review. We waived informed consent because it was retrospective, and we obtained ethics approval from the UA Ethics Committee. Fortunately, due to a lot of the sickle cell patients were actually from the sickle cell unit, we also accessed the records from the sickle cell unit to determine their baseline clinical status, their comorbidities, baseline hemoglobin, and baseline creatinine, as well as their sickle genotype. We also reviewed the medical records for clinical laboratory data and need for renal replacement therapy in hospital or death from any cause in hospital. So the table shows the criteria for acute kidney injury. We defined acute kidney injury using KDOQI-based guidelines. So essentially, at either 1.5 1.5 times increase from baseline, or an absolute increase by greater than 0.3 or 26.5 micromoles per mil. We compared this to baseline creatinine, which we defined as the creatinine in the medical record at least 6 months to 1 year prior to the admission, or if baseline, and we compared the peak creatinine to that baseline creatinine. If we did not have baseline creatinine, we compared it to the admission creatinine. If the admission creatinine was elevated, we compared the admission creatinine to the lowest creatinine in the hospital record. Study data was organized using the REDCap database, and we de-identified the data. We used descriptive statistics and logistic regression models to determine the effect of risk factors for AKI. We only reported age-adjusted odds ratios because we anticipated a slow number of events. So in total, 21 of the 38 persons who met study criteria developed acute kidney injury. That's about 55% of patients with sickle cell disease. The mean age was 38.6. Of note, the importance of this slide is that persons with acute kidney injury were older. They were more likely to have baseline chronic kidney disease and baseline chronic lung disease, right? And what's really concerning was that only 3 of the entire cohort of 38 were vaccinated, although the majority of the admissions occurred at a time where vaccinations were widely available. Again, a lot of stuff on this slide, but the important take-home points here are that patients with acute kidney injury were more likely to have higher respiratory rates on admission, lower saturations at admission, more likely to require ICU, were more likely to have acute chest syndrome, and were also more likely to have a lower hemoglobin at the time of admission, and were more likely to be transfused red blood cells at the time of in the hospitalization. And I say this slide, I think this is kind of the most important, one of the most important slides. Length of stay was higher in persons with acute kidney injury, 12 days median compared to 5 days for people without acute kidney injury. And essentially, the associations with risk factors, the risk factors that we found on age-adjusted odds ratios were that red cell transfusion was associated with an 8-fold increase in acute injury incidence, a decrease of hemoglobin by each 1 unit compared to baseline increased risk of acute kidney injury. An increased oxygen saturation at the time of admission protected acute kidney injury, and also people with more severe COVID infection and higher respiratory rates at the time of admission were more likely to have acute kidney injury. So, interestingly, we found high rates of acute kidney injury. Over half, 55% of persons with sickle cell disease developed acute kidney injury. What's concerning is that the majority of them were more severe stages, CKD, KDOGA stage 2 and 3. And you compare that to the other kind of presentations of acute kidney injury in COVID infection. So 13 of the 21, or 62% of the cases of AKI were stage 2 or 3. 3 persons, or 8% of persons, required dialysis in the hospital. The in-hospital mortality was 13.2% in sickle cell disease. That's higher than what's reported globally of 2 to 10%, but lower than what was reported of the all-cause in-hospital mortality at our institution. There was a high rate of red cell transfusion and low admission hemoglobin in AKI. And when you compare hemolysis markers in persons with AKI and without, they were about the same. There's no difference in hemolysis markers. Each 1 gram reduction in hemoglobin from baseline resulted in a 3-fold increase in AKI, and there was a very low rate of COVID vaccination. We are limited by the small sample size, single center, and urine output criteria was not used because it wasn't universally available.
I think take-home messages here are we need to recognize AKI early in our patients with sickle cell disease with targeted interventions to improve short and long-term outcome. We need to try to get preventative strategies and studies geared towards understanding barriers towards hydroxy use and vaccination in our sickle cell population. And we need to get data on long-term outcomes of COVID-19 in sickle cell patients and its influence on end organ complications. Thank you for your time.
Great. Thank you, Dr. Fisher and Dr. White, for two excellent presentations. And we open the floor now for questions and comments on the first two presentations in this session. We will take the questions from in the room first, and then we check online for questions and entertain them. We have a question. You can go ahead, Mrs. Nelson.
Good afternoon, everyone, and thank you so much, Dr. White and Dr. Fisher. Two very, very, very excellent presentations. Very informative. My question, though, is to Dr. White. As your study looked at the responses of the COVID-19, and you would have identified that the restaurant workers happened to be those that were yielding more positivity, increasing the positivity rates as against, or had the higher rates then, as against to the healthcare workers. While you were doing the study, anywhere there, were you able to identify any reasons that would have at least contributed to those results, or could you share on that for me, please? Thanks.
Thank you for that question and for your comments. We did suggest several of the possible underlying reasons, but in the hospital setting, especially clinicians would be expected to be adhering to infection control measures and usually would be provided personal protective equipment and generally are more knowledgeable about protecting themselves from exposure. In a restaurant setting, it's really a sort of a microcosm of the general non-clinical society. So we would anticipate that their risk factors are similar to the general population. Public transportation use was one significant risk factor that remained so even in the various analyses that we did. They also tended to perhaps have younger persons, making up the workforce, especially in that profession, it's usually of a younger age cohort. So those were some of the risk factors, but there are other things, as you can imagine, in a restaurant setting, maybe more enclosed compared to a hospital that has usually good ventilation, because we tend not to have air-conditioned hospitals such as other places overseas, so we have large windows and we tend to be properly ventilated usually. Whereas in an enclosed setting, there's less space and perhaps more persons per square foot.
Thank you so much, Dr. White, for your response. Over to you, Don.
Hello? Okay, hi. So my question is for both presenters. And I don't want to play devil's advocate, Dr. White, but listening to your presentation and what is happening out there even in the medical fraternity, not just the general population, in terms of persons who've had COVID and they're naturally immune compared to those who've been vaccinated. This data, well, I guess if you were to interpret it, it could be misinterpreted or it could be correctly interpreted, but I want to know what's your view on that data that you just presented and this whole vaccine and no vaccine.
It's an excellent question, but first let me clarify that we measured anti-nucleocapsid antibodies. Nucleocapsid is a protein that is not or was not in the vaccines that were given. The vaccines have spike proteins, so we were not measuring anti-spike antibodies. So our measures would be reflective of natural infection. Now, SARS-CoV-2 has been described in the literature as having the ability to undermine your immune response to it. So, for example, it downregulates interferon gamma production that is needed to counter the virus. So natural infection does not give long-term immunity in the way that vaccination would, because vaccination is designed to elicit the appropriate types of antibodies that would have neutralizing ability. And because the entire live virus is not entering the body, then the decoy mechanisms and the down-regulatory mechanisms that the virus has to manipulate the immune system would not be present with the vaccine. So in short, vaccination does give more appropriate antibody repertoire production, longer lasting antibodies, and clinically protects persons from infection and severe disease more so than natural infection, and natural infection tends to wane faster.
Important then to have some kind of insert in that, so that the general population and some physicians should not use that information or misconstrue that information to support their agenda. I think that's very important.
Thanks.
The second question is, Dr. Fisher, is the fact that, the data from France and the other group out of Europe in terms of sickle cell disease and their unexpected outcome in terms of mortality, right? So my thing is, in your study also, I think you found that people who had SC had more severe disease. Was that?
No, that was not correlated with my study. The predominant genotype was HBSS. So a couple things about taking into account the data from France, which had the largest cohort of sickle cell disease. Their data was from 2020 to 2021. The mortality in-hospital mortality was relatively low for that period, but the majority of their patients were also SS. Their mortality was about 10%, and they had about 305 people. And these are, France is a huge country. We didn't find that in our population, but remember, we have to take into account that our sample size was very small, 38. The data from North America, I should have clarified, included both in hospital and those who were managed at home. So the study from North America, only 41 people were admitted, and the rest were, managed as an outpatient. So that mortality may be falsely low because of that, right? Overall, the most common presentation was vaso-occlusive painful crisis, and the severity of the illness had to do with more, people who had more acute chest syndrome like symptoms, and I think the thing that surprised me a lot was just the degree of although the majority of the persons had been admitted from 2021 onwards, and we had quite a few patients in Omicron, peak. The vaccination rate was extremely low.
And then my follow-up to that was, I know the number is small. Nobody received remdesivir?
So yes, I did. I just didn't present it.
Okay,
Sorry.
no problem.
So yes, so 2 people received remdesivir, and 2 people received tocilizumab.
the same too. So the patients that required ICU ended up getting both. They both died. And again, their illness was severe.
Thank you for those questions. It seems like those are the ones from in the room. So any questions online? You can go ahead.
For Dr. Fisher, are there any thoughts to do a follow-up among your participants, perhaps qualitatively, to determine the barriers to vaccination?
Yes. Sorry. I turned off the microphone by accident. Sorry. Yes, and actually I want to look at readmission rates, because when I was collecting the data, I found these people were being readmitted a lot. So it'd be interesting, although sickle cell disease in itself has a high readmission rate by its nature, it would be interesting to kind of look at long-term outcomes of these patients, not only for pain, and my interest would be clearly kidney disease later on.
Dr. White, did you explore the number of contacts for each participant?
Great question. We had not asked that specific question. Thank you.
Right. Just out of curiosity, not sure if I heard you correct, Dr. White. Did you say that the healthcare workers had a higher antibody titer?
No, the restaurant workers had a higher antibody titer.
Oh, the restaurant workers had a higher antibody titer. Any, suppositions as to why this might be so?
Right. So firstly, the rates of infection were higher among restaurant workers. So a greater number of persons were infected, or a greater proportion of persons from the restaurant workforce. But they tended to also be more exposed, so perhaps the infecting dose or the number of virions that they're exposed to would have been higher. Also, they reported lower vaccination rates. And we had started giving vaccines around that time, and the reported vaccination rates were higher among the hospital workers. So they have more vulnerabilities. Also, the socioeconomic factor is important, because they're more likely to take public transportation, so crowded buses and taxis, because they have to get to work, whereas healthcare workers are more likely to have their own vehicles and less likely to be exposed to crowded situations. So those are some of the thoughts that I could share about the underlying reasons. Right.
Sir, thank you. Like right here, we have persons attending to us, okay? So what will be the recommendation? Should they still wear the mask? Because I see persons not wearing masks. I go to the different food stalls, they are not wearing their masks, and they are talking over the food, handling the food. So what do we do?
Right. So like we've seen, persons are careful when they get to work. So within the workplace setting, there are infection control measures. So we do know that staff are required to wear masks, especially around that time. They're required to sanitize. There was no dining in of the patrons. So all of those measures were in place. However, when you leave work and you have to be on a taxi or in a bus, that situation is different. Perhaps, and it had come up, I do recall the Ministry of Health also mentioning in previous announcements that public transportation was an important risk factor. So perhaps infection control measures limiting the number of persons allowed on a particular vehicle, having hand sanitization measures at the door, etc., would be important factors as well. Other factors, vaccination uptake by the general public in Jamaica has generally been low, and we just have to continue to impress upon persons the benefits of vaccination. And I alluded to earlier that natural infection elicits antibodies, but not the appropriate antibodies that last and that protect against the virus. They wane much faster and are less effective in fighting the virus. whereas vaccination is targeted to eliciting the appropriate antibodies, and they tend to last a longer time, even though they also do wane, but they tend to last a longer time.
Thank you. We've come to the end of this question and answer session for the first two presenters. So we'll move to the next two presentations. The first will come from Dr. Andrea Garbott, and she'll present on students' online learning experience in Jamaican schools, the COVID-19 pandemic, and beyond. And that will be followed by Dr. Patrick Toppin's presentation on the prevalence of acute kidney injury and mortality in COVID-19 patients admitted to the University Hospital of the West Indies Intensive Care Unit. And after those two presentations, we'll have another brief question and answer session.
Good afternoon, everyone. Thanks for inviting me and allowing me to share with you guys our team's experience in terms of learning about our students' online learning experience in Jamaican schools and the COVID-19 pandemic and beyond. So on March 11, 2020, COVID-19 was declared a pandemic, and with that came a whole heap of changes. The global response was more or less similar. We had medical and non-pharmaceutical interventions, and those in themselves had implications, and implications not only for health, but also in the educational world. Classroom closures came swiftly, and by March 13th, schools were closed in Jamaica. And after that, it will forever be etched in our minds and our memories about emergency remote learning, about emergency online learning. And all it meant was that our students were no longer learning face-to-face with their teachers, but now were placed at a distance. Whether this occurred synchronously or asynchronously, it didn't matter at that point. So having had reports, being in the pediatric world, concerns about parents, we decided we had to look at the modalities and the strategies that were being utilized by learning institutions, both at the primary, secondary, and the tertiary level for online learning during school closures. And we explored the experiences of the students and their psychological well-being during this time. In terms of our methodology, this was a cross-sectional study that was administered between 2020 to 2021, a year's time, and the students had self-administered questionnaires. It looked at demographics, it looked at what devices they use, how they connected, their resources they had, their experiences they had with learning, but also it looked at psychological well-being. Statistical analysis was done using the SPSS package. In terms of our general characteristics of our patients, of our students, there were about 289 students who participated, and they came from a range of schools, both at primary and secondary levels. We had rural and urban representation, and we had schools being represented from the grade 3 level up to the tertiary level for our students. Now, what device did they use? And this one we did both pre-pandemic and during the pandemic. As you can see, smartphone was a preferred device at the primary level, both before and during the pandemic, and there was a rise in its use during that time period. There's a small amount of laptop use, and yes, it did increase. Tablet, not as much at all, just about 1%, it rarely went up. When you look at secondary schools, now again, smartphone was very much there, and it was being utilized. There was a slight dip, but that dip was also matched by a slight increase in terms of using a tablet. And at the tertiary level, our students were predominantly using their laptops. There was still some smartphone use at that level. So having a device now, how did the students connect with it? Majority of the students utilized household Wi-Fi. There were students who were also buying data packages to help them with their connectivity, and only tertiary students seemed to get a better hang of free Wi-Fi to be able to find where these locations were. Now that they had the device, they knew how to connect, how was work really being disseminated. There were all different sorts of options that were put forward, and there were some schools that were very inventive. They were distributing packages as well. However, WhatsApp continued to be the preferred way for schools to disseminate their work. And this was seen both at the primary and the secondary level, with at the tertiary level, what they were using were live interactive sessions. So they had their device, they connected, we knew how they were now sending messages back and forth. what were their experiences, what were their challenges. And challenges were almost the same across the board for primary, secondary, and tertiary students. They all had difficulty connecting to the internet. Some had difficulty accessing the platforms. There was a few of them who had some unfamiliarity with the platforms, and we must remember that prior to COVID, we weren't really talking about online learning for primary school students. It's just not in vogue for primary school students to be learning by this method. They had issues with the internet dropping. Some had no hardware, for example, a microphone. There was also the expense for those who were buying mobile packages in terms of having to purchase those, lack of privacy. So remember, if you're at home and you had siblings, or even if you had siblings that weren't in school and everybody was running around, that would be a privacy issue. Students also reported that it was difficult for them to be motivated and for them to engage in their learning experiences. They found it distracting when either teachers were late to their sessions as well as their peers were late to the sessions. And university students noted very much that they did not like online learning. So we went on a little bit further, and we used screening tools to look at psychological well-being. And in terms of those tools, we looked at the GAD-2 and the PHQ-2 for anxiety and depression, respectively, and then we also used the brief resilience coping scales. And what we found in our population is that 1 in every 4 students reported some symptoms of anxiety that met cutoff mark. When it came to depression, 1 in 3 students reported significant symptoms that would meet cutoff mark, and we had much better responses when it came to the resiliency coping scores. We recognized that over 50% of our students were able to cope better. So in summary, we know that on a background of donations, multiple tablets and laptops that occurred in the island at that time, the main device that was being used for schools was a smartphone. We need to remember that this is also on a background of having almost 100% penetrance for cell phone usage in Jamaica. So when you go from one day being face-to-face to the next day having to be online, it would seem definitely it would be the easiest equipment to just transition to. When it comes to access, home Wi-Fi packages seem to have predominated, and we know that other studies done internationally, what they have noted is that reliability is actually better with home Wi-Fi. When it came to dissemination, WhatsApp and text seem to have been the preferred. And if we know our schools here in Jamaica, and we didn't ask this question, but we know that our schools tend to have chat groups for the teachers at every grade level, and you send messages with or without COVID, so it could have been simpler for them from that point of view. Live interactive sessions would have been in place where there was already a learning management system in use, and that would have been at the tertiary level. Though at the primary level and at the secondary, it was referred to as being experimented with, but not really implemented. Challenges were across the board, and these were not only common to Jamaica. The preference remains for that traditional classroom, and when we look at psychological symptoms, we know that we may have more impact to look at further on in years. We now know that mental health is really becoming an epidemic among us, and that even in the current guidelines published for 2022, screening for anxiety and depression is being recommended for children as young as 8 years of age. So thank you to my team, and thank you for listening.
Afternoon. All right, I'm going to jump right in. My name is Jason Tappan, and I'm going to talk a little bit about acute kidney injury, and we're focusing on critically ill COVID patients admitted at the University Hospital of the West Indies. A quick, maybe unnecessary background. A lot of stuff happened in 2019. Brexit, fires, we impeached a US president, but all of that fades into the background to the associated name COVID-19 pandemic. Our first patient arrived on a plane from the UK, March 2020, and not long after we started seeing critically ill patients. And it's now faded, but that definitely dominated society and medicine, and definitely our critical care units after that time. UHWI took care of the largest number of critically ill patients. So what this study sought to do was to look at, although respiratory failure and ventilators got a lot more press and were a lot more visible, not far behind, acute kidney injury was definitely a serious issue and occurred in a number of these patients. What we sought to do was to describe how much this happened, maybe look at risk factors and look at outcomes in critically ill patients. We extracted the data from the hospital information management system. I'll tell you we're missing out about, call it 180. We're missing about 25. That was some difficulty, has since been rectified, but not been able to add those 25 patients. And probably also important is the fact that there are a lot of critically ill patients that we couldn't take. So it only represents the portion that made it into ICU. And there are a lot of critically ill patients that did not get into ICU and would not be reflected. I say 31, so it's now actually down to about 25 patients that are missing. We collected all of their demographic information. We had pretty detailed information on their blood results, respiratory parameters, and so on. And for purposes of our study, mortality is just 30-day mortality, or in hospital. So start by looking at what is the subset of patients, these critically ill patients. Maybe we might expect a slight preponderance of males. Typical age is not that old, 50s. Diabetes, actually pretty common. Hypertension, ischemic heart disease, pretty rare. But a large number of these patients had some chronic illness. When? What time period are we looking at? Why is that important? We had two things, maybe different strains circulating at different times, so different waves which had different complications, maybe affected different people. And then hopefully our ability to respond and deal with this evolved over time. So those are things to consider. And this is just looking at the different waves. You see those missing patients, that's where that missing columns, that's where those 25 people fall. But you can actually see the initial wave, and the big wave is our delta wave, where we had the largest number of patients and the largest number of critically ill patients. Now, what happened? This is just general ICU information. If you made it into ICU, almost 2/3 of patients did not survive. If you made it into ICU, you are going to be there, I'll call it 2 weeks minimum, average. About 2/3 of you are going to get, patients there are going to get acute kidney injury. Almost 80% are going to be ventilated. And the ARDS just suggests how severe, that's acute respiratory distress syndrome, but a large number, almost 50%, are going to have severe lung injury. If you're on that ventilator, you're going to spend over a week, and that's a pretty large spread though, standard deviation of 10. A number of you are going to require vasoactive agents to support blood pressure and cardiac function, and a lot of patients are going to have a bloodstream infection. Looking specifically at acute kidney injury now, which is what our stated goal. Of those with acute kidney injury, comparing the two groups, those who had and those who hadn't, there's a little difference in terms of age. People with acute kidney injury tend to be a little earlier. I'm going to I'm going to come back to diabetes, but diabetes was a major risk factor. Obesity seemed to be associated, the presence of high blood pressure. If you had any chronic illness, and unsurprisingly, this was very strongly associated with mortality. If you had acute kidney injury, and it's actually more strongly associated than the need for ventilation. Who survived, rather than who did not survive. Gender, not that a bigger deal, and a lot of what we would expect. And these are univariate, so age, diabetes, hypertension, if you're obese. Because of time, I didn't include this slide, but we also did some multivariate regression analysis, and by the factor that continued to stand out, control for other factors, is diabetes. So if you were obese, and I controlled for diabetes, obesity was very poorly associated with your outcome. If you're diabetic, that was by far the strongest risk factor in our group of patients. putting it all together, acute kidney injury actually is incredibly common in these patients. 60%, it is more associated with outcome, 30-day mortality than needing respiratory failure and requiring ventilation. Acute kidney injury is not necessarily the direct cause, and it may actually be, to some extent, it's hard to tease it out. It may be that it's just associated with more severe disease rather than acute kidney injury being the direct cause. Chronic illnesses were a major risk factor, but I'm going to zone in again on diabetes mellitus. That definitely had the largest effect on outcome. And I'm going to kind of step back away from our data a little bit and make some suggestions. Hopefully these will fall on the right ears. Just looking at the difficulty with this data and collecting it afterwards, I would actually ask, given that this was definitely a national effort, are there ways we could better collect data? Are there simple ways? I imagine a world maybe not so far away where we could have electronic data updated at least daily. And then some of the limitations we have trying to collect the data after would disappear. Difficult in terms of security and managing it in terms of location, but definitely possible. In the grand scheme of things, our data is not that large, and there are ways. And it would make some of this analysis, this data, collecting and presenting data like this, a snap. Thank you.
Thank you, Dr. Toppin and Dr. Garbott, for two wonderful presentations, quite interesting. And we're going to open the floor now for questions. Any questions in the room? Yes, we have questions. Or you can go ahead.
For your excellent presentations, looking at the last presenter, I wanted to find out the ICU and the 30-day mortality. Is there anything we could do better to have saved the life of those who went in there?
Yes, so there were, in the interest of time, there were some.
Sorry.
There were some factors associated with increased or decreased risk of survival. I hadn't included it, but there was a point at which, in terms of the ventilation, for example, we started doing prone ventilation, and it made a major difference in terms of survival. Medication-wise, it's a little hard to tell because we spoke about the limitations of use of remdesivir. Who got it? Pretty much everybody in ICU, once remdesivir was available, got dexamethasone, remdesivir, and when it became available, a large number got tocilizumab. So that's difficult to tease out. I actually think that the better place to look is before ICU. And to a large extent, because of limitations in ICU space, the people who made it to ICU were very severe. And what we really needed to look for was who to intervene in earlier. And a lot of times you came to ICU, everything. You had multi-organ failure, and our chance of really making a difference was a lot less. And a way to identify who are the very sick people, not quite reaching ICU or not as sick as the other people that we could intervene in earlier. Looking back, there were, if you do ICU, there's severe ARDS. The idea that those patients would be managed anywhere other than on a ventilator is, before COVID, was preposterous. But there are a number of patients that we managed with high flow and extra oxygen that survived. Normally, all of those patients would have been on a ventilator. We were able to manage them off a ventilator, and those patients, a number of them went home and did pretty well.
Thank you.
Hi, excellent presentation to you both, actually. So, two questions. One is, did you find a difference in mortality? And I mean, the numbers are small. Or difference in AKI incidence and mortality in different phases of the pandemic? I know, difficult to assess because the numbers are small. And how many people that died required dialysis? Because that's the really big mortality with acute kidney injury. I guess, as you alluded to, a lot of the critically ill patients are managed on the wards. So it'd be interesting to look at the AKI incidence in people also managed on the wards as well.
Okay, to the first question, did try looking at time periods and different waves. Part of the problem too is that we were missing a certain subset which catches the end of the Delta wave, which for us was in terms of sheer numbers. There does seem not significant, there's significantly more AKI between your first wave and your Delta wave. There's a lot more AKI. In terms of who got dialysis, it's a little difficult because there are some very sick people who we decided couldn't tolerate dialysis, and in another setting would have gotten dialysis. So that's hard to tease out exactly from the data. I will say that there were, if you required mechanical ventilation and got dialysis, maybe 2 people survived. Of the 2 that survived, I went looking in these 2 lucky people. One of them died after 30 days. So if you had renal failure requiring dialysis and severe lung disease, your chance of survival was very low, which, going back to the initial point, that's probably not the time to be intervening. Maybe we've missed the boat a little bit at that point.
That kind of correlates with what they found overseas as well, especially in the periods of the high peaks, was that people who had mechanical ventilation and acute kidney injury requiring dialysis, their mortality was approaching 80 to 90%, which is also what we're kind of seeing. So your point about intervening on people before they are critically ill in multi-organ failure is really important.
Thank you. Question for Dr. Garbott, the one for online learning. Okay, thank you for your excellent presentation. So what I noticed on your slide, so the students don't listen to radio, they don't watch television. That is out of it because I realized nothing was.
There weren't nobody who watched the television recordings. It's just that with this generation that they don't watch television. They watch Netflix and they go online. It's just a different way of learning. We would have probably some of others would have been listening to the radio and have gone to school and you'd have to watch the news report. But kids these days don't do that. You go online and you find whatever you need to look at, and it's very specific. So that's just not the way that they're looking at media right now.
Yes.
All right, do we have one last question from the room?
Yes, good afternoon. Excellent presentations. I have a follow-up question for Dr. Garbott. Just wondering if there were any urban-rural differences in online access as well as the anxiety and the resilience scores.
Can't remember anything separate for them. I know we did collect data by rural and urban, and we actually had to go and deliver questionnaires for rural areas, but I can't remember any differences specifically for rural versus urban.
All right, thank you. We have come to the end of Scientific Session 5. Can we give our presenters a round of applause? Excellent. All right, so we're going to move into lunch now, and then we ask you to join us at 1:45 for feature presentation number 3. Thank you.
We were given a mandate to provide oversight of the redevelopment of the Connaught Regional Hospital. The oversight committee visited the site and inspected the building. And it was a worthwhile building to renovate. To construct a new building would cost 10 times as much of what we are spending to do the renovation.
The hospital is a 450-bed facility. It was pretty much full and has been consistently so. And the options to close would mean having nowhere to put persons. People would literally die if we close the hospital.
This project is approximately $3.5 billion. The first phase was to fix the roof, fix the structural problems. The second phase was to the demolition of the building. That is to remove all the internals, because a lot of them are identified to be mold infested. And then the third phase would have been the rehabilitation of the building.
We have not compromised on one service, one era of service that we are doing before the hospital was closed. We would have removed and built a standalone building to accommodate our CT machines, our X-ray machines, and so on. We would have expanded our accident and emergency unit, constructed intensive care units to be used for COVID, converted living spaces into wards, constructed 3 additional operating theaters, expanded even our dialysis area. When it is completed, we'll have a brand new hospital, a brand new building, brand new facilities, modern facilities, because it is totally being redesigned.
The collapse of the Connaught Regional Hospital posed a challenge to public health that I don't think we have seen post-independence. We engaged in a technical assessment to determine the value of what existed despite the challenges that were there, and it was determined that the building was sound. What we needed to do was to correct the air quality issues at the institution. You had to continue to use the building even with the challenges that you faced and the risks that were involved in that process of air quality issues, while transitioning and creating additional infrastructure around that main building to continue the services that were essential to saving lives. I'm hoping over the next year or so, we will make substantial enough progress to see a gradual return to normality of the main building. Cornwall will one day become the best hospital in the West and probably one of the best in the Caribbean based on the work that is being done now.
This project is approximately $3.5 billion. The first phase was to fix the roof, fix the structural problems. The second phase was to the demolition of the building. That is to remove all the internals, because a lot of them are identified to be mold infested. And then the third phase would have been the rehabilitation of the building.
I'm hoping over the next year or so, we will make substantial enough progress to see a gradual return to normality of the main building. I will be elated, not just for me or for the ministry, but for the people who use the facility. Doctors and the nurses who have put up with all the challenges over time, the patients who use the facility, who have understood the nature of the inconveniences and why this is the case.
What will that moment of seeing that project to completion and walking into a new building feel like for you?
Well, you know, for me, it is likely to be, it will be a very fulfilling moment, without a doubt. I'll be extremely satisfied. It could be an emotional moment because we have seen the lows, we have seen the disappointments, we have seen the frustration, and to see now the success of a fully restored building will create joy and maybe even tears for some people. And for me personally, I will be elated, not just for me or for the ministry, but for the people who use the facility. Doctors and the nurses who have put up with all the challenges over time, the patients who use the facility, who have understood the nature of the inconveniences and why this is the case. You know, I look forward to that day, and I will celebrate on behalf of all who will benefit from the restoration, and indeed take those lessons. In fact, I've asked for a case write-up of the Cornwall experience, because I think the lessons to be learned should be transmitted to all across the public health system to avoid any other institution from having the same fate. So in a sense, Cornwall Regional Hospital should be a teaching moment for us, and that's one of the major objectives that I would have in terms of moving the process forward.
Hello, Jamaica. I'm Chatsmiller. It's unbelievable to me whenever I buck up somebody who is still asking if COVID-19 is real. Because my doctor died of COVID-19. I had COVID recently, and it was a severe case. Most of my lungs were affected. I am so grateful to be alive. Take COVID seriously, guys. Some people won't be affected, that's true, but others may have long-term effects, and some people will die. Let's do all we can to protect ourselves and to protect others.
A message endorsed by the Ministry of Health and Wellness.
Severe pains, shortness of breath, worsening with fever, lack of appetite, extreme weakness, and overall grazing beside death's door. This was my experience with COVID-19. Hi, I'm John, and I'm so thankful that I survived COVID-19. As an asthmatic person who lives alone, I know that COVID could have claimed my life. Listen, don't drop your guard with COVID-19. It only takes a second for you to catch a virus. Initially, I thought I had the flu until things got worse. Don't leave your mask, wash your hands as often as you can, and always keep a physical distance from others. And I want to tell every Jamaican to choose a vaccine before COVID chooses you.
A message endorsed by the Ministry of Health and Wellness.
Cornwall Regional Hospital was built in 1974. It was a gift of the Canadian government. They did all the technical work and provided the resources to build the facility.
Over
the years. Clearly, there was poor maintenance of the building. But also, the building was modified by non-experts. People were constructing offices in the corridor. What that does is to interfere with the airflow and the ventilation. There was water seeping through the roof, it was leaking, but also seeping through the walls, and there were the plumbing fixtures and so on.
As long as you have moisture building up in concrete, in wood, and so on, you're going to have some conditions that are suitable for the growth of mold. To be able to find out the extent of that problem, basically the entire building had to be gutted.
The collapse of the Cornwall Regional Hospital posed a challenge to public health that I don't think we have seen post-independence.
Closing this hospital would not be an option. It would be like closing KPH.
The hospital is a 450-bed facility. It was pretty much full and has been consistently so. The options to close would mean having nowhere to put persons. People would literally die if we close the hospital.
In 2017, when it was deemed that staff were primarily affected by the air quality issues, we realized that we had to relocate on a phase basis and not en bloc.
We are not on the main building, we are all across the campus. We are down the road, we are over West Jamaica Conference, and we are up at Falmouth. Movement on the campus mean you have to serve inpatient, mean you have to move up to Falmouth, you have to move down to Barnet Clinic, you have to move across the campus. And sometimes it is very hot, sometimes it's raining.
We have not compromised on one service, one area of service that we are doing before the hospital was closed. We would have removed and built a standalone building to accommodate our CT machines, our X-ray machines, and so on. We would have expanded our accident and emergency unit, constructed intensive care units to be used for COVID, converted living spaces into wards, we've constructed 3 additional operating theaters, expanded even our dialysis area.
This project is approximately $3.5 billion. The first phase was to fix the roof, fix the structural problems. The second phase was to the demolition of the building. That is to remove all the internals, because a lot of them are identified to be mold infested. And then the third phase would have been the rehabilitation of the building.
It was a worthwhile building to renovate. To construct a new building would cost 10 times as much. And when you're renovating a building, you get many surprises. And that is what has been happening at Cornwall Regional. So you demolish a wall only to find problems which were not planned for.
We understood that there are delays. We knew that persons were disgruntled. Some persons, of course, left. But some of us decided that we're going to have to stick through this and get through it.
When it is completed, we'll have a brand new hospital, a brand new building, brand new facilities, modern facilities, because it is totally being redesigned.
What I can assure members of the public is that we are doing all that is necessary in terms of identifying what are required, be it of resources, be it of management system and so on. And certainly these will be incorporated in our budget and going forward.
We're building the capacity from now. We're looking to get all the expertise we need, that going forward, once the hospital is built, the whole issue of maintenance will not go back to where it was.
Mm-hmm. What will that moment of seeing that project to completion and walking into a new building feel like for you?
I will be elated, not just for me or for the ministry, but for the people who use the facility. Doctors and the nurses who have put up with all the challenges over time, the patients who use the facility, who have understood the nature of the inconveniences and why this is the case. You know, I look forward to that day, and I will celebrate on behalf of all who will benefit from the restoration and indeed take those lessons, because I think the lessons to be learned should be transmitted to all across the public health system to avoid any other institution from having the same fate. So in a sense, Cornwall Regional Hospital should be a teaching moment for us. And that's one of the major objectives that I would have in terms of moving the process forward. Ladies and gentlemen, I wish to congratulate the Rotary Club of Downtown Kingston for hosting this webinar on World Diabetes Day. As we turn the spotlight on diabetes this November, we must acknowledge the scale of the problem of NCDs and redouble our efforts to solve it, drawing on all our resources, including our nurses, who are essential not only as healthcare providers, but also as professionals to whom we can rely for the promotion of self-care management among patients. Our nurses also play a role in helping to safeguard the mental health of their diabetic patients, from identifying emergent psychosocial to making the appropriate interventions to support their patients. This year's theme for World Diabetes Day, Diabetes Nurses Make a Difference, therefore is most appropriate. And in a year designated as the Year of the Nurse, this World Diabetes Day, we encourage stakeholders, from persons living with diabetes to their family and friends and others involved in their care management, to join our nurses in the effort to ensure the best possible health outcomes for persons with diabetes, and to, as far as possible, engage in behaviors to reduce the incidence of diabetes and other NCDs. Those behaviors include increased physical activity, a healthy diet, routine health checks, and strict medication adherence. All the best, and thank you.
Hello, I'm Dr. Shin Young-soo. I'm Regional Director for the Western Pacific World Health Organization. Today, on the World Health Day, I would like to ask you, how safe is your food? Does your country's food safety system protect you and your loved ones? Does it follow international best practice?
Harmful bacteria, viruses, parasites, and chemicals can contaminate food. Every year, millions of people in Asia and the Pacific are affected by diseases that are caused by unsafe food. Unsafe food causes more than 200 diseases, including acute diarrhea, cancer, kidney failure, brain disorders, and chronic malnutrition. Diarrhea is the most common symptom of food and waterborne illnesses, causing some 2 million deaths a year. The risk of unsafe food crossing borders is greater than ever. Trade in food and livestock products in Asia has increased threefold in the past 20 years. Contaminated food can transport disease halfway around the world in a few days. Food safety is a shared responsibility. Countries must work together to prevent foodborne disease outbreaks. Because food safety assurance is only as strong as the weakest link in the food chain. Food safety incidents also have economic consequences. Millions of dollars are lost every year due to food contamination. Consumers lose confidence in the food and stop buying it. Businesses close, people lose their jobs, and exports decline. Food safety must be a priority, from farm to plate. Governments must take responsibility and ensure that all foods comply with minimal food safety and quality requirements. Otherwise, the health and economic consequences may be serious. WHO helps member states build capacity to prevent, detect, and respond to foodborne disease outbreaks. This includes building national core capacities as required under the international health regulations and facilitating rapid exchange of information through the International Food Safety Authorities Network, managed by FAO and WHO. Make safe, healthy food a priority. Take responsibility to ensure food safety. This will help your country maintain good health and achieve economic prosperity.
Hello, I'm Dr. Shin Young-soo, and Regional Director for the Western Pacific World Health Organization. Today, on the World Health Day, I would like to ask you, how safe is your food? Does your country's food safety system protect you and your loved ones? Does it follow international best practice?
Harmful bacteria, viruses, parasites, and chemicals can contaminate food. Every year, millions of people in Asia and the Pacific are affected by diseases that are caused by unsafe food. Unsafe food causes more than 200 diseases, including acute diarrhea, cancer, kidney failure, brain disorders, and chronic malnutrition. Diarrhea is the most common symptom of food and waterborne illnesses, causing some 2 million deaths a year. The risk of unsafe food crossing borders is greater than ever. Trade in food and livestock products in Asia has increased threefold in the past 20 years. Contaminated food can transport disease halfway around the world in a few days. Food safety is a shared responsibility. Countries must work together to prevent foodborne disease outbreaks. Because food safety assurance is only as strong as the weakest link in the food chain. Food safety incidents also have economic consequences. Millions of dollars are lost every year due to food contamination. Consumers lose confidence in the food and stop buying it. Businesses close, people lose their jobs, and exports decline. Food safety must be a priority, from farm to plate. Governments must take responsibility and ensure that all foods comply with minimal food safety and quality requirements. Otherwise, the health and economic consequences may be serious. WHO helps member states build capacity to prevent, detect, and respond to foodborne disease outbreaks. This includes building national core capacities as required under the international health regulations and facilitating rapid exchange of information through the International Food Safety Authorities Network, managed by FAO and WHO. Make safe, healthy food a priority. Take responsibility to ensure food safety. This will help your country maintain good health and achieve economic prosperity.
I was first diagnosed with cervical cancer at age 33. The treatment was not pretty. It was terrible. I couldn't go to work, and I spent the whole 5 years out of work. The pain, the struggle, I removed my womb. I thought, I'm finished with cancer. 2016, cancer come back. There's hope for your daughter. My experience don't have to be her experience. So mothers, give their children the vaccine. It will be good for your sake and for the children's sake.
Don't wait. Vaccinate against cervical cancer. A message from the Ministry of Health.
I want to see a Jamaica that is cervical cancer free. Cervical cancer is one of the leading causes of cancer in women in our nation, and I want this to stop. The HPV vaccine has been proven to be the most effective method to prevent cervical cancer. It is a safe vaccine, and it is best to give the vaccine to young girls before they've even been exposed to the HPV virus. So parents, I want to encourage you to let your daughters get the HPV vaccine. Let us protect our next generation against cervical cancer.
Don't wait. Vaccinate against cervical cancer. A message from the Ministry of Health.
I love my children, and I will do anything to protect them. So that's why, as a mom and as a doctor, I made sure that my daughter got the HPV vaccine to protect her from cervical cancer later in life when she becomes a woman. The HPV vaccine is very safe and effective.
I was afraid of the injection at first, but I got it and it really wasn't that bad after all.
If there was something you could do to protect your child, wouldn't you do it? Protect our next generation. Ensure that your daughter gets the HPV vaccine today.
Don't wait. Vaccinate against cervical cancer. A message from the Ministry of Health.
What happened, Aiden? My mama told me I need to come off the tablet. Yes, you should. We need physical activity. Well, that's what adults say. Adults, I tell you. Seriously though, with physical activity, we will get better grades, better heart health, and improve the bone health. Oh, I heard it will improve memory and overall mood. Yes, it will maintain our weight and lowers the risk for depression. Do you know what will lower your risk of depression? What?
During this time, with online schooling, we are sitting for too long. The problem with sitting for too long is that it leads to soreness, aches, and pains throughout our body.
We're gonna get funky, 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 funky. Everybody clap your hands. Clap, 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 clap your hands. Clap, 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 clap your hands. All right, now, we're gonna do the basic step. To the left, take it back now, y'all. One hop this time. Right foot, let's stomp. Left foot, let's stomp. Cha-cha, real smooth. Turn it out. To the left. Take it back now, y'all. One hop this time. Right foot, let's stomp. Left foot, let's stomp. Cha-cha now, y'all. Now it's time to get funky. To the right now. To the left. Take it back now, y'all. One hop this time. One hop this time. Right foot, 2 stumps. Left foot, 2 stumps. Slide to the left. Slide to the right. Crisscross. Crisscross. Cha-cha, real smooth. Let's go to work. To the left. Take it back now, y'all. 2 hops this time. 2 hops this time. Right foot, 2 stumps. Left foot, 2 stumps. Hands on your knees, hands on your knees. Get funky with it. Oh, yeah. Come on. Cha-cha now, y'all. Turn it out. To the left. Take it back now, y'all. 5 hops this time. Right foot, let's stomp. Left foot, let's stomp. Right foot again.
reduce your risk of viral illnesses like the flu and coronavirus. Wash your hands frequently with soap and water. Cover your nose and mouth when coughing with a tissue and dispose of it. Avoid close contact with anyone with the cold or flu-like symptoms. If you think you've been exposed to COVID-19, stay home. Self-isolate immediately and call 888-1-LOVE. That's 888-663-5683. A message from the Ministry of Health and Wellness.
Provision of services to public patients living with diabetes and hypertension through the engagement of private general practitioners is a welcomed initiative, and the Western Regional Health Authority stands firm in its commitment to healthy families living in healthy communities. This value-added service will increase and improve access to care for persons living with diabetes and hypertension.
We have partnered with the Association of General Practitioners of Jamaica as well as the Ministry of Health and Wellness to engage in a public-private partnership to provide access or to provide care for individuals with diabetes and hypertension in this post-COVID era. What it means is that you can go to a private doctor to have your care and be provided with the same level of care as you would receive if it is that you actually went to a public health center or public health facility.
SARA is the largest of the 4 regional health authorities with responsibility for providing health care to almost half the Jamaican population. And as such, we are endorsing the private-public partnership initiative of the Ministry of Health and Wellness regarding non-communicable diseases.
The Northeast Regional Health Authority fully endorses the public-private partnership between the Ministry of Health and Wellness and private physicians as we address patient care in the health system. all our diabetic and hypertensive patients will have the opportunity to be treated through private physicians as we move to enhance patient care while we go through this COVID-19 pandemic.
The Southern Regional Health Authority endorses the public-private partnership between the Ministry of Health and Wellness and private practitioners. At this time, as we respond to the COVID pandemic, it's important that the health of the region is maintained, and so chronic disease patients continue to attend clinic and to maintain their health. While this is happening, it's important that we appropriately respond to the pandemic at this time. So with this partnership, it will allow us to meet our mandates to ensure that at the end of the pandemic, we would have appropriately responded and our persons are able to maintain and be the best version of themselves.
Come pre this you, don't pre that, let me tell you about the body and some physical facts. Come pre this you, don't pre that, let me tell you about the body and some physical facts. Physical activity defined as bodily movement. You know it beneficial to every student. Chin up, push up, jogging, sit up, feeling lazy, better get up. Physical activity help your mood and memory, make you remember anything, cause it boosts dopamine and serotonin. Target attention, focus, regulate moods. Come learn something, your man listen young youth. Physical activity, healthier weight, go and exercise, students hold the faith. The more you do, the more calorie your body use. Calorie deficit, calorie get reduced. Exercise build your bone and make it more dense. A facts we attack, ladies and gents, physical activity is of the essence, needed like full stop in any sentence. Come free this you, don't free that, let me tell you about the body and some physical facts. Come free this you, don't free that, let me tell you about the body and some physical facts.
During this time, with online schooling, we are sitting for too long. The problem with sitting for too long is that it leads to soreness, aches, and pains throughout our body.
One, two, three, two more. 1, 2. Adults to 30 minutes activity daily. Love your body, treat your body right. Vegetables, make sure you eat plenty. Children do 60 minutes activity daily. Drink some water when you feel thirsty. Cut down dessert and have a smoothie. Jamaicans, love your body, treat your body right. Love your body, treat your body right. Just eat right. Love your body, treat your body right. Love your body, treat your body right. One more time now. Love your body, treat your body right. Love your body, treat your body right. Just eat right. Love your body, treat your body right. Love your body, treat your body right. Listen up. Make sure you know your health status. Go a doctor and get a regular checkup. Chronic disease can slowly creep up. We can lower the risk and live up if we just eat right and get moving. Jumping, running, dancing, or skipping. Change the children, them lazy habit. Make them play out the door and put down the tablet. Jamaicans, love your body, treat your body right. Love your body, treat your body right. Just eat right. Love your body, treat your body right. Love your body, treat your body right. Jamaica get moving. Love your body, treat your body right. Love your body, treat your body right. Just eat right. Love your body, treat your body right. Love your body, treat your body right. After 2, make me hear you say I love me. 1, 2. 1, 2. 1, 2. After 2, make me hear you say I love me. 1, 2. 1, 2. 1, 2. Jamaicans, love your body, treat your body right. Love your body, treat your body right. Just eat right. Love your body, treat your body right. Love your body, treat your body right. One more time now. Love your body, treat your body right. Love your body, treat your body right. Just eat right. Love your body, treat your body right. Love your body, treat your body right. Jamaica get moving. Love your body, treat your body right. Love your body, treat your body right. Just eat right. Love your body, treat your body right. Love your body, treat your body right. One more time now. Love your body, treat your body right. Love your body, treat your body right. Just eat right. Love your body, treat your body right. Love your body, treat your body right. Listen up. Love your body, treat your love your body, treat your
If you are 60 or older, like me, and have underlying health conditions such as high blood pressure and diabetes, you are at a greater risk for severe illness or death from COVID-19.
After more than a year of being under COVID restrictions, it is also time to do what is necessary to get back to life. That's why senior citizens have been prioritized for vaccination.
The vaccine is safe and effective. I have taken it and I'm feeling just fine.
I've also taken the vaccine and I feel so much more at ease.
Get vaccinated and get back to life.
This is an important message from the Ministry of Health and Wellness.
Vaccine 60. Let's go. All approved COVID-19 vaccines are effective against COVID-19 and all known COVID-19 variants. The Johnson & Johnson vaccine requires 1 dose. The Moderna, Pfizer, and AstraZeneca vaccines require 2 doses. You are considered fully vaccinated 14 days after receiving the required number of doses. Don't mix and match 2-dose vaccines. Get the same vaccine for both doses. Vaccines help to prevent hospitalization and death associated with COVID-19. Common vaccine side effects are usually mild and usually resolve in a few days. After getting vaccinated, it's still important to wear a mask, wash hands or sanitize regularly, and maintain physical distance. The quicker we all get vaccinated, the sooner we can all get back to life. Let's strike gold like our Olympians, Jamaica. That was a message from the Ministry of Health and Wellness.
If you know one pop down and fenke, if you burn mosquito and run with dengue, so no make water circle in open container. For them we read up under a danger. Usher them out, run them away. Stop them with the zapper and down them with spray. Use mosquito net and mosquito screen. Protect your household, now make them come in. If you know one pop down and fenke, if you burn mosquito and run with dengue.
A message from the Ministry of Health.
Good ganja sense, learn more your ganja, just be smart with it. Good ganja sense, good ganja sense. We have many uses for the cannabis. Knowledge is power, youths we need that. Ganja smoking and no pitney thing that. Commercial ganja you farm then you reap. Entrepreneurs and scientists see. Good ganja sense, learn more the ganja, just be smart with it.
Brought to you by the National Council on Drug Abuse, an agency of the Ministry of Health and Wellness.
Vaccines are a type of medicine that stimulates a person's immune system to produce immunity against a specific disease, protecting the person from the disease. When vaccinated, your immune system is able to recognize the invading germ, such as a virus or bacteria. It also produces antibodies that fight and destroy the germ before you become unwell. Vaccines continue to be the most successful public health intervention in saving millions of lives every year. That is why it is essential to take the COVID-19 vaccine so that you can limit the risk of being hospitalized or even worse, losing your life to COVID-19. Welcome back to the second dose of the COVID-19 vaccine. It's now time to complete the process to becoming fully vaccinated. When both doses are administered, the vaccine is more than 82% effective at preventing COVID-19 infection. However, you are not fully protected until 10 to 14 days after receiving the second dose of the vaccine. Remember, the injection is given in the muscle of the upper arm. As part of the vaccination process, you will be observed for about 15 minutes, just so a healthcare provider can monitor you for signs of an allergic reaction. Let's talk VaxFacts.
Will I experience side effects from the second dose?
Side effects are more common and may be more pronounced after the second dose of the vaccine. The most common side effects include a sore arm, fatigue, feeling tired, headache, aches, and fever. Severe side effects are rare and treatable.
What are the possible side effects from the COVID-19 vaccine?
Side effects are normal and a sign that your body is building protection against a specific disease. The side effects experienced are usually mild to moderate and may last up to 72 hours. Common side effects may include swelling, tenderness, pain, warmth, itching, or bruising where the injection is given, tiredness or generally feeling unwell, chills or feeling feverish, headache, feeling sick or nauseous, joint pain or muscle ache, vomiting or diarrhea. Less common side effects include sleepiness or feeling dizzy, decreased appetite, enlarged lymph nodes, or excessive sweating, itchy skin, or rash. Seek medical attention immediately if after 72 hours of getting the vaccine, you feel faint or lightheaded, there are changes in your heartbeat, you develop shortness of breath, or you begin to wheeze, there is swelling of your lips, face, or throat, you have hives or rash, there's prolonged vomiting or diarrhea, or if you develop stomach pain.
What do the side effects mean?
If you get side effects, they're a good sign. They indicate that the vaccine is working by triggering the immune system. When you get the first shot, your immune system recognizes something as being foreign. The immune system automatically launches a small-scale attack against it. This process teaches your immune cells to recognize and respond to an invader. That's why you might experience some side effects. When you get the second shot, your immune system launches that attack again. But this time, there are more immune cells ready and waiting to launch a much bigger assault. That's why you may feel more side effects after the second dose, but they will disappear after a day or two. Think of it this way. The body's response to the vaccine is like a training mission for the real fight. Once you're fully vaccinated, if you were infected by the virus causing COVID-19, your immune system would be ready to launch an even larger and more powerful attack to protect you. If you don't experience any side effects from either the first or second dose, that doesn't mean that the vaccine didn't work. In the vaccine clinical trials, more than half of people didn't experience any side effects, but we still know that the vaccine was effective in those people.
Is it possible to get COVID-19 even after the second dose?
The chances of getting sick after vaccination are minimal. Studies show even if you develop COVID-19 after being vaccinated, you are unlikely to get severely ill. Flu vaccines are less effective than the COVID vaccines, but they can protect you from more severe flu illness and hospitalization. The COVID-19 vaccines are even more powerful. The efficacy of the vaccines in the prevention of severe COVID-19 is almost 100%.
After taking the vaccine, it is still important to wear your mask. Always ensure that your mask is covering your nose and mouth. Maintain physical distance. Wash your hands with soap and water frequently. If you're not able to wash your hands, always use a hand sanitizer. For more information about the COVID-19 vaccine, visit www.moh.gov.jm or contact 888-1LOVE. That's 888-663-5683. Follow us on social media at the MOHWGOVJM. Hashtag Get Vaccinated. Hashtag Get Back to Life.
Like you out to mash up some spraying idea,
yeah? Yeah, I go spray them corn there.
So, are the tree wearing the protective gear?
Boy, the sun too hot for suit up here, man.
So you did read the label before you start? Wear protective gears. Your goggles, your respirator, your gloves, and a coverall. At least you did have on a cap. Mix only what you need for the day. Use only on the crops listed, and if some chemical left over, make sure you store it in the original container.
For more information, call the Pesticides Control Authority at 754-9306.
teen hub in Jamaica.
Become the hero on the scene by taking the COVID vaccine. Get vaccinated as soon as you get all the facts. Don't listen to the rumors. This vaccine might just make it possible for teachers to sit face to face with schoolers. This vaccine make it safer for everybody, from the young to the elderly. Don't you want to go back to living normally when things were more orderly? And if you want to live a long good life, then we all have to do what's right. So let's get vaccinated along with the heroes on the front line.
A message from the Ministry of Health and Wellness.
Our loved ones mean so much to us now more than ever, and their safety, especially during this season, should be our top priority. Do all you can to support them mentally, physically, and emotionally. Christmas is not cancelled, but COVID-19 is still here. Enjoy your holidays, shop safe, get vaccinated, wear your mask, keep your distance, and sanitize always. This was an important message from the Ministry of Health and Wellness.
The sun now raising up, and the crowd now waking up. The atmosphere have vibes, and nothing can break it up. The girl never wind non-stop. We had the drinks them in a my cup. We gonna party all night, all night. 24 parties we hit in a row. Tonight at the very last show, before we are out on the road. The girl never release the road. So let me see your hands up, so everybody know, put your hands up, so if you're ready for the road, let your friend them know. We're ready for the road. We're ready for the road. So we're ready, yeah, we're ready, we're ready.
Everyone, and welcome. I am Kamisha Shaw Kelly. Welcome to the feature presentation 3, Childhood Development Reach Up Jamaica. Our guest speaker is Prof. Suzanne Walker. Prof. Suzanne Walker is a professor of nutrition and heads the Child Development Research Group at the Caribbean Institute for Health Research at the University of the West Indies, Jamaica. The group's work on interventions to promote children's cognitive and social emotional development for children under 3 years. Prof. Walker was the lead author in the highly influential Lancet series on child development and a coordinator of the series on maternal and child nutrition. Please help us welcome Prof. Walker.
Thank you, Dr. Shaw Kelly, and thank you to the Ministry for inviting me to talk about the implementation of the Reach Up Early Childhood Parenting Program in Jamaica. So brain development involves interactions of genetic, biological, and psychosocial influences, and is most rapid and vulnerable from conception to 5 years. The early environment and experiences in early childhood are critical, and the figure illustrates the process of rapid synapse formation in early childhood, followed by the equally important process of synapse pruning. Both of these processes are dependent on the experiences of the child. So what we know is that biological and psychosocial risks can lead to deficits in brain structure and function, and in cognitive and social emotional development. Over the last couple of decades, there has been a large increase in the global focus on early childhood development, and Target 4.2 of the Sustainable Development Goals calls for all children to have access to quality early childhood development and care by 2030. Parents are typically the child's primary caregivers and are critically important in early childhood. And for parents to be able to support development requires a supportive environment. I'm not sure if I can point. Does this point? No? No. Never mind. So what is needed are appropriate national policies, access to required services related to health, nutrition, education, and social protection, and these would provide the programs and help to build capacity for parents to provide nurturing care. The Jamaica Home Visiting Intervention was developed in the 1970s and 1980s, and the aim was to build parents' ability to promote development through play. It's delivered by community health aides who visit the home and conduct an interactive play session with mother and child. The intervention has a very strong evidence base that was built over many years, including efficacy trials and evaluation of the feasibility of integration with services. And the intervention was also replicated successfully in several countries. Another important asset of the intervention is that in Jamaica we have long-term follow-up of participants who receive the intervention and have demonstrated important sustained adult benefits, including to education, mental health, and income. In 2014, we developed the Reach Up Early Childhood Parenting Program as a comprehensive training package based on the lessons from the Jamaica Home Visit Program and the curriculum. And our aim was to be able to increase the capacity of implementing agencies, including NGOs and governments, to deliver parenting programs for children in low and middle income countries. The intervention is parent and child focused, and as I've said, involves an interactive play session with the parent and child to build the parent's ability to promote development through playful interactions. And this is done by the community health aide through demonstration and practice with the mother, and eventually the child being able to do the activities on their own. There's a structured curriculum which uses play and everyday activities to introduce concepts and language. The play sessions use homemade toys, songs and games, language activities, and picture books. And there's a strong emphasis on responsiveness of the parent to the child, praise for both mother and child, and an emphasis on making sure that the sessions are fun and enjoyable for both the mother and child. And parents are then encouraged to continue the activities in between the visits and integrate them into their daily routine. Reach Up has now been adapted and implemented in 18 countries. In Jamaica, Reach Up is implemented by the Ministry of Health and Wellness as part of their strategy to build a more holistic approach to child health and their contribution to the National 0 to 3 strategy. The program is led by the Family Health Unit and is called the Early Stimulation Program, and the team at CARE continues to provide technical support. A phased implementation was planned. The first phase would be implemented in one health district per parish, followed by evaluation of effectiveness and any determination of any challenges that occurred which might need to be resolved before national expansion to all health districts in phase 2. So enrollment to phase 1 began in late 2019, and children aged 5 to 24 months at risk of poor development were identified by the health staff using the criteria listed on the slide. 8 children were enrolled per community health aide in each health center within the district, and trained interviewers obtained informed consent and administered a questionnaire to the mothers to collect information on sample characteristics. Following that, randomization was done with 4 children assigned to intervention and 4 assigned to a wait list who would receive the intervention after the evaluation had taken place. The intervention involved home visits by the health center community health aides to the at-risk children in the communities they served. They conducted a 1-hour play session with parent and child every 2 weeks using the Reach Up curriculum, play, and language materials. It was planned for the intervention to continue for 12 months and then conduct the evaluation, which was supported by the ECD Innovation Fund of the Inter-American Development Bank. By March 2020, implementation had started in 6 parishes when it was suspended due to the COVID-19 pandemic. In response to COVID-19 and the need to be able to continue to reach parents with services, we developed a new manual, which was called the Reach Up Parent Manual. The goal was to continue to support families in playful interactions with children 0 to 3 years. And the manual contains selected play and language activities from the Reach Up curriculum, and we focused on those that required few materials or that used materials often available in homes. The manual was designed so that it could be used directly by parents, and it was also planned for the manual to provide content for remote contacts with parents, such as phone calls and text messaging. And some of our partners in other countries also use content from the manual to develop radio programming. In Jamaica, the remote delivery had 3 components. Materials for the family, which included the parent manual and a few play materials. A phone call from the community health aide, which was done every 2 weeks in place of the home visits. And these calls were used to encourage the parents to do the activities in the manual, to explain them more and adjust them as needed, and also to help to continue and develop the good relationships between the community health aide and the family. We also developed a series of text messages which described different play and language activities that caregivers could do with their child and supported the parent manual. And parents received 1 or 2 messages each week. Some additional resources were developed for the health staff, and we also conducted a short half-day orientation for them at the centers on how to deliver the program remotely. So we provided them, the community health aide, with a handbook which included guidelines on how to make the calls, some scripts with some suggested text and format for the calls, and a revised supervisor checklist for the nurses to help them to monitor the quality of the calls. Implementation began in September 2020 in the 6 parishes that had started the intervention, and continuing with the families that had begun home visiting. The duration was 7 to 9 months, and we then evaluated the impact on parent practices. We also conducted interviews with the health staff and parents to understand whether the remote delivery was acceptable and feasible, and to determine any challenges. Parenting practices were measured with a questionnaire administered by telephone, and we attempted to contact all intervention and waitlist families from the 6 parishes. The in-depth interviews were conducted with a subsample of parents, community health aides, and nurses, and these focused on the facilitators and barriers of the remote delivery. We were able to follow up about 85% of the children enrolled, and the mean age of the children on enrollment was about 3 years. At endline was about 3 years. Only 2 sample characteristics differed between the waitlist and intervention group at the evaluation. And these were maternal education, which was slightly higher in the waitlist group, and whether the father lived with the child, which was also somewhat higher in the waitlist group. And we adjusted for these 2 variables in the analysis. The parent outcomes were parent activities, which was a summary of the activities listed on the slide, the number of toys and picture books in the home, the use of interactive language between the mother and child, and the use of praise by the mother. And we focused on praise because praise is so important in promoting positive behavior. So the results for the parent practices, we found that the parents in the intervention group did more play activities with their child than the parents in the waitlist group, with an effect size of 0.34 standard deviations, which compares favorably with some evaluations of face-to-face interventions. They also used more praise, and they used more praise both when their child behaved well and also when their child did something that made them happy. There were, however, no differences in the number of books or toys in the home, and no difference in the use of interactive language. So moving on to the results of the in-depth interviews. Looking at the phone calls, the community health aides said they were convenient as they could do them at home, at times convenient for the parents, and they felt that the parents showed interest. I'll just read a couple. One said, "It sort of let them know that you're still interested. The program still continues, not because of pandemic. The program still continues." And another said, "It's only that because I'm not seeing them face-to-face literally do the activities with the child, but I think they show interest, and I think they are excited about the program." Sorry, I keep doing this. Most parents also stated that they liked receiving the calls and that they helped them feel supported as the community health aides kept in contact and checked up on how they were doing. Parents reported that they enjoyed the interactions with the CHAs and were able to do the activities a few times per week. So I'm just going to read one of them, where the mother said, okay, the phone call, I'm always looking out for them because they help me. Cause little more time, most time I will teach her, but sometimes I don't know what to talk about, so sometimes it motivates me to help me to develop new skills for the baby. The text message was sent to the parents, were felt to be acceptable by the CHAs, and they viewed them as good reminders for the parents. Most of the parents received the text messages and liked them. And one said, it reminds me to play and interact with my child. Some said that they did the activities stated in the text messages without reference to the parent manual, while others looked to the parent manual for more details. Of course, there were challenges with delivering the intervention remotely. There was a lack of interest from some parents who didn't respond, and so there was non-response to the phone calls, and the community health aides did find this frustrating. There were also technical issues which were reported both by the community health aides and by the parents, and these were mainly poor signal in some of the more remote areas, or sometimes the mother did not have a phone of her own. And this led to missed calls. A few of the parents said they did not receive the text messages, and limited literacy was a problem for some parents. Another important challenge was that some CHAs stated that they felt overwhelmed and frustrated with their workload, and this was especially difficult for them with additional pandemic-related duties. An interesting finding was that despite the fact that the CHAs felt that remote delivery was manageable and that it was welcomed by the parents, they almost uniformly said that they preferred home visit delivery to delivering the program by phone. So one said, to be honest, nothing beats home visits. But some of the things that I'm seeing here, I see it when I visit. At times I may call a mother and I hear excitement in the voice. An X can do this, an X can do that. So it's different. Phone call make it different, but nothing beats home visit. Linked to this, about 60% of the health aides spoke to their need to trust what the mothers said. And this then influenced how they felt about remote delivery. So one said, the play activity with the phone is difficult. I would ask the mother, if I actually seen it face to face, I could relate to it some more, but I just have to go by what she says. Overall, the community health aides said that they enjoyed the program and they perceived benefits for the children, and that those benefits motivated them to continue. I think it is a good program. It has benefits for the mother and child, and I think it can be continued. It's nice to see that we can provide education within the health system before the child reach basic school. The parents also were positive about the program and found the program motivating and said it helped with the interaction and bonding with their child. One said, it helps me to bond with my child. When the siblings were doing their schoolwork, then the baby would do the activities. And another said, we have mommy and son moments, and when he learns, it makes me feel proud as a mother. So in summary, the intervention had positive effects on parent activities conducted with their child, and they were 2 times more likely to praise the child for doing positive behaviors. Overall, the remote delivery approach of using phone calls was acceptable to the parents and the community health aides. Most of the barriers to delivery were related to phone issues and also to parents not being available at the time of the call, and also the fact that some of the parents were not in there was a core of parents who really did not cooperate. And the text messages were viewed by the parents as informative and encouraging, and the community health aides as well as the nurses saw them as good reminders. So, despite some challenges, we saw that the nurses, community health aides, and parents valued the program. The results suggest there's an additional training, and in particularly improvement in supervisory support may help to engage the less interested parents. Face-to-face interactions are important for ECD, and this was reflected also in the feedback that we got from staff. And so, together with the two teams, CARE and the Ministry of Health and Wellness, have decided to develop a blended model which may be feasible for scaling. So, implementation is restarting in the same health districts identified in Phase 1. And using the lessons learned, we're using a blended model, using home visits, so there's one home visit per month, phone calls, and then there's one phone call per month, as well as text messages every week. We are also working out how to improve the supervision of the program. The evaluation of this phase of the program will again involve children aged 5 to 24 months, and again focuses on the most at risk, though we have simplified the definition of that. Again, we're enrolling 8 children for each community health aide and randomly assigning to intervention or wait list. And the intervention is planned for 9 months, at the end of which we'll evaluate child development, maternal well-being, and parent practices. And just to say where we are at the moment, refresher training has been completed for all parishes and enrollment is ongoing, and implementation has started in 3 parishes. And we expect implementation to be ongoing in all parishes in which we can work by January or February of 2023. I'd just like to close by giving thanks to the rest of the team at CARE, the Family Health Unit, Dr. Melody Ennis, Dr. Kamisha Shaw-Kelly, and Dr. Julia Rowe-Porter, who, though she's no longer with the Family Health Unit, was integral to the initial implementation of the program. Thanks are also due to the parents, community health aides, and nurses, and to the Inter-American Development Bank for their support. Thanks very much.
Thank you, Prof. Walker, for a very informative presentation. We're now at this point for any questions, any comment. You can go ahead.
Good afternoon. This question here is asking, would video calling have helped the CHAS to feel more effective in delivering the program, or was it not possible due to limited access to internet?
Sorry, I didn't get the first part of the question.
Would video calling have helped the CHA to feel more effective in delivering the program, or was this not possible due to limited access to the internet?
Yes, video calling probably would have helped, and in fact the remote delivery was also evaluated in several countries by some of our partners, and in Brazil, where they have a very strong network, they actually did the calling on WhatsApp and were able to exchange videos. it really wasn't possible for us to use videos, but I think if it was possible, it would be helpful. It would also help the health aides because they might, when they call, they could see a little bit of what was happening and they would feel more comfortable with that.
Okay, thanks.
Can go ahead.
Thank you, Professor Walker, for excellent presentation. It's highly appreciated. I realize that the program is sponsored by another country. Is that true?
No, the program is implemented by the Ministry of Health and Wellness. The evaluation was sponsored by the Inter-American Development Bank.
Do they have documents that you are supposed to follow? Do they give you documents like to say this is what we expect you to use for this implementation or evaluation? Was there a guideline or you were given the freedom as Jamaicans to do what you know best?
No, we have planned the evaluation. The team at CARE is doing the evaluation, and we have planned and developed it. Obviously, we do this we've worked with the team at the IDB for quite some time now, so obviously we interact with them, but we actually have we develop and carry out the evaluation.
Okay, you know what I'm asking? So can you, some of the play, the kind of play they have to play with the children, do they read the Bible to them? Do they sing songs? You understand? Do they have a study like those kind of literature, Christian-based literature as Jamaicans? Would they have that? Because at that early stage of development of a child, bonding with the mother, having that kind of play, is the Christian aspect implemented in this, or we never thought about it?
The intervention follows a curriculum that has been developed and evaluated as being successful over decades now. So, because the curriculum was originally developed in the 1970s and 80s, it does a lot of things. It focuses on concepts, language, on responsiveness between the mother and child, which is very important for secure attachment. And it also, through the methodology, tries to ensure that the mother is expressing love for the child, praising the child. We try and reduce the use of physical punishment. So it's not inspired by any particular faith. It is grounded in the science of child development.
All of us learned Jesus loves the little children, all the children of the world, whether yellow, black, or white, they are precious in His sight. So we all learn that. So playing with the child. So
we
yes,
use lots
that's
of
what I was
songs
asking.
the intervention. Every visit finishes with a song. Some of the songs, probably one of the songs is that very one you've just sung. Other songs are very different.
Okay,
so,
thank you.
That's how it works.
Thank you.
Mm-hmm.
Any other questions or comments? If not, I would like to thank you. Thank you so much, Prof. Walker. Thank you for having us. So next, okay.
So, Prof. Walker, we want to acknowledge our appreciation for your willingness to come to share regarding the Reach Up Jamaica program, and we know that you will continue to support the Ministry of Health programs. We do appreciate it, and this is a small token of our appreciation. Thank you.
Thank you. And I'd just like to say how much the team at CARE has enjoyed working with the Family Health Unit. It's been a pleasure.
And Dr. Shaw Kelly, as moderator of this session, we want to also express our appreciation, and we acknowledge your willingness, and we do appreciate that you are a part of this conference, and we hope that that will be the continued support in going forward. So thanks again.
Thank you.
We were given a mandate to provide oversight of the redevelopment of the Conrad Regional Hospital. The oversight committee visited the site and inspected the building, and we all concluded that it was a worthwhile building to renovate. To construct a new building would cost 10 times as much of what we are spending to do the renovation.
The hospital is a 450-bed facility. It was pretty much full and has been consistently so. And the options to close would mean having nowhere to put persons. People would literally die if we close the hospital.
This project is approximately $3.5 billion. The first phase was to fix the roof, fix the structural problems. The second phase was to the demolition of the building. That is to remove all the internals, because a lot of them are identified to be mold infested. And then the third phase would have been the rehabilitation of the building.
We have not compromised on one service, one era of service that we are doing before the hospital was closed. They have removed and built a standalone building to accommodate our CT machines, our X-ray machines, and so on. We would have expanded our accident and emergency unit, constructed intensive care units to be used for COVID, converted living spaces into wards, constructed 3 additional operating theaters, expanded even our dialysis area. When it is completed, we'll have a brand new hospital, a brand new building, brand new facilities, modern facilities, because it is totally being redesigned.
Welcome to everyone to this scientific session number 6 on public health. We want to say to those in the audience and those persons online, we want to say good afternoon. Our presenters for this session is Dr. Abigail Harrison. We're pleased to have you, and Dr. Michelle Brown. And we just like to say that Dr. Abigail Harrison is a lecturer at the University of the West Indies, UWI, a consultant pediatrician and an adolescent medicine specialist in the Department of Child Health at the University of the West Indies. She is the founder and director of the Teen and Young Families Clinic at UWI. In addition, Dr. Michelle Brown is a doctor of dental surgery and has completed her master's in dentistry. Her area of emphasis is oral epidemiology at the Federal University of Parama in 2016. Currently, she works at the University of the West Indies at the Mona School of Dentistry, where she teaches dental public health and related subjects. Her research interests include oral health and oral health related quality of life. Now put your hands together for our two presenters. We are going to now invite Dr. Abigail Harrison to do her presentation. Thank you.
Afternoon, everybody. Thank you to the organizers for giving me the opportunity to present this afternoon. And I'll be talking on disparity between adolescents' health information needs and the information received in a middle-income country. And I'd pause to acknowledge my co-authors from both the Mona and Cave Hill campuses at the UWI. So adolescents, as you know, filled with many changes, and risk-taking is just a part of their life. They have evolving capacity for decision-making, so weighing of consequences, delayed rewards and gratification, acknowledgement of long-term consequences. And of course, many health-related behavioral concerns are in fact amenable to change through health promotion efforts, prevention, and treatment. So we set out to identify the sources of health information for adolescents and to document the information that they wanted to discuss with their provider and compare it with what was actually discussed. And we use that as a proxy for unmet health needs. We explored factors that influence the disparity, such as age, sex, and their locale. A cross-sectional study design was employed. Participants were selected by convenience sampling at 4 secondary level schools, 2 in the urban region and 2 in the rural. And from each school, we selected 1 class in each grade level, and these were selected randomly, and we invited all students in that class between the ages of 11 and 19. Written consent was obtained from all parents, assent for those who were under 18, and consent for those students who were 18 and above. And they were asked to complete self-administered, interviewer-assisted, paper-based questionnaires. The questions were read out loud to participants in groups of 20 so as to minimize any variations from differing reading skills. Ethical approval, of course, was received from the UWI's Mona Campus Research Ethics Committee and approval received from the Ministry of Education to enter the schools. The items were adapted from the Young Adult Healthcare Survey, which is validated for young people between 12 and 18, and this was used to determine provision of private and confidential care, level of preventive counseling offered to adolescents, their experience of care received. And we collected socio-demographic data such as summative possession score, source of their drinking water, toilet facilities, and a crowding index. And we put those through principal component analyses so as to generate a composite socioeconomic score. Adolescents' level of patient-centered care was assessed using 4 key components: whether their healthcare providers listened carefully to them, explained things in a way that they could understand, showed respect for what they said, and spent enough time with them. And they were able to respond anywhere from always to never. A dichotomous variable was generated for patient-centered care, which was scored as yes if the healthcare provider always or usually performed all 4 of these in the past 12 months. As typical, we used means and standard deviations for continuous variables to describe those, and frequencies and percentages for categorical variables. The t-test and the chi-square tests were used to explore differences across the socio-demographic factors for the characteristics of visits to providers, topics that they wanted to discuss, as well as ones that they actually discussed, and their unmet needs. Multivariable binary logistic regression model was used to examine relationship between the adolescent socio-demographics, unmet needs, and their patient-centered care scores. Statistical significance was set at the 5% level, and the data analysis was done with Stato. So in total, we had 480 high school adolescent participants, with more girls than boys, and the ages ranged from 11 to 19, as we said, with a mean age of 15.1 years. There were more early adolescents, and there were more females and male adolescents within the late adolescent category, and that was a significant difference. There was no significant sex difference, however, by location, school type, or parental union status. Now, about 162, so 80% of the late adolescents were able to visit the doctor or a healthcare provider in the past 12 months, and that was significantly more than any of the other age groups. Now, approximately 15% of these same older adolescents reported that their healthcare provider always discussed confidentiality. But what was concerning was that as many as 40% of the entire sample had never had that conversation, and only 2% of our older adolescents had actually always gotten to have the opportunity to speak privately. Sources of information varied somewhat, with the urban adolescents reporting that they were able to get more data on safety and substance use from TV, radio, and internet than their rural counterparts. The topics most adolescents wanted to discuss were weight management, nutrition, exercise, condom use, emotions they were experiencing, and taking medications without a prescription. Rural students found that they had greater gaps in their ability to discuss school performance and sexual orientation, while urban students had a greater unmet need in terms of discussing STIs. In the logistic regression, the single factor that was critical and was significant was that the older the young person got, was the greater the likelihood of having an unmet health need. So the study provides evidence there is disparity between what they need and what they actually were provided. There was a seriously low proportion of adolescents getting the opportunity to meet privately, with less than 20% even of the older ones, despite having attained the age of medical consent at 16. Confidential discussions, we are aware, increase the likelihood of discussion around sensitive topics and enhances the adolescent's sense of satisfaction with the visit and will positively influence their capacity for decision making. Similar to other studies in the USA, we found that as they got older, the young person had greater unmet needs. However, differently, we found that there were not many differences by location, whether rural or urban. Older adolescents were likely to have unmet needs more so. Female adolescents had greater unmet needs than the male counterparts, and we suspect that this is likely due to their increased desire to have discussion around more sensitive or taboo topics. Now, parents have previously been identified as primary information sources in other studies. However, less than a third of our adolescents reported getting information on sex from their parents. And this actually corroborates some previous findings locally, where Jamaican parents seem to believe that discussions about sex actually represented tacit approval of the adolescent engaging in these activities. So therefore, it's noteworthy that healthcare providers are one of the few credible voices to educate and counsel adolescents around this significant health issue. I pause to acknowledge some limitations. So we know the use of a convenient sample may limit the generalizability of these findings. However, we feel that this was mitigated against quite a bit by having a relatively large sample size with good distribution both by sex and location. We also acknowledge that consistent with studies of this nature, recall bias was also a possible limitation. So what are our recommendations moving forward? We are keen on a minimum of 2 routine preventive healthcare visits for adolescents, with the utilization of a structured format to ensure that there is opportunity for confidential discussion, one-on-one time with the adolescent, as well as age-appropriate participation of parents. We also feel that educating our healthcare providers on the importance of meeting adolescents' needs, the ability to optimize their future health outcomes, and the potential impact each interaction shared with an adolescent may make. Thank you so much for your time.
Good afternoon, everyone. I'm very happy to be here to talk about oral health. A lot of persons don't know that dental caries. Are you hearing me now? Yes? No? Can you help me? All right. As I was saying, a lot of persons don't know that dental caries is a non-communicable disease, and it's non-communicable chronic disease, and it's quite prevalent in all age groups. So I'm happy to be here to talk about oral health and its impact on overall quality of life. The title for this presentation is the validation of the Jamaican language version of the Oral Health Impact Profile for use among adults, the JAM-OHIP study. So health-related quality of life is defined as the extent of which health influences the attainment of a fulfilling life, and it is heavily influenced by certain factors such as culture, values, and biases. So just as how oral health is an integral component of general health, oral health-related quality of life is able to impact on the construct of health-related quality of life. And it is defined as the perception of how oral health impacts an individual's quality of life and their overall well-being. So the Oral Health Impact Profile is an instrument that measures oral health-related quality of life. The OHIP 14 is a shortened version. It consists of 14 questions that are divided into 7 domains, which are functional limitation, physical pain, psychological discomfort, physical, psychological, social disability, and handicap. It has been shown to have good psychometric properties and has been validated in several languages in different countries across the globe. So basically, we wanted to create our own version of the OHIP 14 and then to test it for its validity and reliability for use among Jamaican adults. Before beginning the study, we obtained ethical clearance from the Ethics Committee of UWI. Each participant was also required to give written informed consent before participating in the study. The first thing we did was to develop the JAM-OHIP, and we worked with Jamaican language specialists from the Jamaican language unit. Step 1 was to create an initial version through forward translation. This was followed by backward translation, which was conducted by 2 independent native Jamaicans who were unacquainted with the original English version. The 2 versions were then compared to assess for major differences in their construct to develop the preliminary JAM-OHIP, which was then subjected to a pretest. This pretest was done with 10 individuals who were interviewed using the JAM-OHIP. The results from the pretest were then further evaluated by the translators, and any necessary modifications were made to create a final version of the JAM-OHIP. This study was cross-sectional in nature, and it was conducted at the UWI Dental Polyclinic with patients undergoing treatment between the ages of 18 to 59 years old. Now, to be included in the study, the persons had to be native Jamaicans, and those who had pain which complicated their ease of speaking or had hearing impairments or presented emergency oral conditions were eliminated from the study. And so we had a total sample size of 236 individuals aged on average 35 years old. Clinical data was collected using the Decayed, Missing, and Filled Teeth Index, and this was done by trained and calibrated examiners who had CAPA scores greater than 0.89. A pilot study was conducted to assess the preliminary reliability of the JAM-OHIP, and at this point, Cronbach's alpha value was 0.869, which represents good internal consistency. Each participant completed a structured questionnaire which included sociodemographic data, oral hygiene habits. For the JAM-OHIP, a Jamaican language specialist was recorded reading each item of the JAM-OHIP, and then the video was shown to each participant who responded to each question on a scale of 0 to 4, 0 being never, 1 hardly ever, 2 occasionally, 3 fairly often, and 4 very often. So scores 3 and 4 were considered as having high impact. So to To evaluate the psychometric properties of an instrument does require sophisticated statistics. And so, in addition to descriptive analysis, internal consistency was evaluated using Cronbach's alpha reliability test and item total correlations, the Kaiser-Meyer-Olkin measure of sampling adequacy, and Bartlett's test of sphericity were preliminary tests for the exploratory and confirmatory factor analyses. And then this was followed by checking the overall fit of the model using the chi-square test, the comparative fit index, Tucker-Lewis index, root mean square error of approximation, and the standardized root mean square residual. So for the results. Of the 236 participants, the majority were single-employed females who had tertiary level education. For the caries experience, the mean DMFT score was 8.9, with 3.6 decayed, 3.3 missing, 2.2 filled teeth. 100% of the participants related that they brushed their teeth, with 65% of them using dental floss. And the main reason for visiting the dentist was for checkup or oral prophylaxis, for cleanings. So when oral health-related quality of life was evaluated, we did note a high level of impact, meaning high scores 3 and 4. Our mean oral health-related quality of life was 12.7. The most impacted domains were physical pain and psychological discomfort. The discriminant validity was assessed according to the oral health status of the participants. As you can see here, those who had DMFT scores greater than or equal to 8 did present increased JAM-OHIP scores with statistical significance. When the individual components of the DMFT were associated with the JAM-OHIP scores, for the decayed, missing, and filled teeth, all of them presented increased JAM-OHIP scores with statistical significance. And this demonstrates the tool's ability to discriminate between groups. Cronbach's alpha was 0.82, which is good internal consistency. For the corrected item total correlations, all were greater than 0.3, which is excellent internal consistency. The inclusion of all the items was necessary because deleting a single one at any time produced a score that was lesser than the original Cronbach's alpha. For the KMO MSA, all the values were above the cutoff of 0.6, in addition to the statistical significance given by Bartlett's sphericity, which shows that the data are appropriate to conduct factor analysis. So the preliminary test indicated that the number of factors to be included should be 4, and so the EFA was considered based on these 4 factors: psychosocial, physical, psychological, and social impact. The communalities ranged from 0.435 to 0.789, which are all above 0.4, and the total proportion of variance explained was 64%, which is greater than the general rule of at least 50%. When the goodness of fit of the model was checked, these figures were obtained, which proves that the model that we specified fits the data well. So the OHIP 14 adapted to the Jamaican language was considered to be easily understood by the respondents, easily applied to the population, and did show good validity and reliability, which was comparable with the original English version from which it was derived, and also similar to other validation studies done in different languages in different countries. And the literature shows that the OHIP 14 is able to provide information about the impact of the perception of oral health on quality of life. And this is heavily influenced by culture. And so the findings from this study reinforce the importance of the validation of instruments according to the culture and the language of a determined population. And so in conclusion, the JAM-OHIP instrument was shown to be reliable and valid for the assessment of oral health-related quality of life in the Jamaican adult population, and is able to compare our oral health-related quality of life with other populations on an international level. Thank you for your attention. So the references.
Put your hands together again for Doctors Abigail Harrison and Brown. These are two very insightful and powerful presentations on child health, the findings, and of course, dental health, critical for public health. Now we have a few minutes for questions. Those online as well, you can send your question in the chat. Question, go ahead.
Thank you, Dr. Harrison, for your presentation. Excellent presentation, both of you. And the question I have for the first one, the teenage, the adolescents having the healthcare provider within a space where they have private conversation pertaining to their health. There was limited percentage. Okay, now, the age of, you said age 16, what was age there? That
yes,
is,
age 16.
So
that's the age at which they can access confidential care. Well, care without parental consent.
Here in Jamaica.
That's correct.
Okay, all right. So that brings me to the question where right now in America, I'm asking you as a practitioner, okay? In America, they are saying that from 13, they are allowed to give their parents the consent, whether to be present when they are seeking medical care. And here we have 16. Although we are not saying they must give their parent consent, but you know, that is, they are allowed to. By your observation as a professional, do you think that is the right thing to do?
So, from my perspective, I would say from as early as anywhere between age 10 and 12, all our adolescents should have some one-on-one time with their provider. Okay. So sure, they would come to the doctor with a parent or a guardian of some sort, but I think it's really, it makes such a difference when they get that opportunity to speak with the provider alone, to share their own personal concerns if they have any, but even more importantly, to develop that sense of capacity and autonomy to speak and learn about their own health. Okay. I think that will go a very far way.
Okay, thank you. Because why I ask the question, because it's important to know that what you just said from age 10 is for you to build the child, not to squeal the child away to get certain things that the parents will not approve of.
Right. So I think many persons feel that confidential discussion with the provider is only about sex and drugs and those sort of things, but it is so much more. You can just be talking about schoolwork, you can be talking about their friends, you could talk about emotions that they're not ready to share with anybody else, and you are that sort of safe space for them to have that non-judgmental conversation. And so if we can get all our young people to become comfortable to talk to their healthcare provider in a confidential way, we will be making major progress.
Thank you. And what about the guidance counselor? That is what they are for as well, the guidance counselor.
Oh, for sure. But I think the guardian can be pulled in as a supportive framework, but not as somebody who needs to know every single detail, but to be able to support the young person in the way that the young person can receive it and utilize it.
Okay. And the doctors don't have enough time.
We often don't have enough time, but if we use the small amount of time optimally, then that's really key.
Thank you.
Sure.
Okay, we just have about 70 seconds. Any questions online, anywhere, for any of the other our two presenters? Go ahead, online.
Yes, this question here is asking, were you surprised about the relative high percentage of adolescents who wanted information about weight loss? And what intervention would you recommend for the non-taboo topics that are unmet needs?
Okay, so I was not, thank you for the question. I was not surprised by the amount of young people who want weight loss. We have a big push on not becoming obese and overweight, but we also, from other local research, we realize that we have about 1 in 5 of our adolescents who would be considered at risk of developing an eating disorder, which ranges from a restrictive or a binging type eating disorder. So I'm not surprised. In terms of suggestions for managing taboo topics. I think once we have that space, that confidential space of a non-judgmental conversation, then all things are on the table for discussion and nothing becomes taboo or nothing remains taboo. So that would be my recommendation. I hope that answers.
Okay, we are over and out on the questions. So let us squeeze in one more for
That is for Dr. Brown. Okay? For the Jamaican OHIP, all right? Utilizing it, the language barrier was kind of cracked. Is that what you say? When we modified it to the Jamaican language, or utilizing this particular study guide to know the missing tooth, the feeling tooth, it gave you a better outcome because of language. Is that what you found out?
Essentially, except the JAM OHIP, it asks questions directly related to quality of life. The Decayed Missing Fill Teeth Index was separate. But we actually did a study before using the English version, and the mean score that we got for oral health-related quality of life was substantially less than the score that we got when we used the JAM OHIP. I think because when the instrument was translated into a language that persons understood better, they could relate better to it, they were able to answer more, appropriately. And so it probably reflected the true oral health, the true impact of oral health on quality of life.
Thank you. Which language was that? Was it Patois?
It's Jamaican language, Patois. Yes.
Thank you. Can we clap for her, please?
Okay, so there we have it. There you go. Put your hands, a heavier hand for the presenters. Very good. So use this opportunity now to introduce to you our other two presenters. And we have Mr. Kemar Bundy. He is a public health practitioner who specializes in epidemiology and strategic information. Mr. Bundy has done both field and bench research in non-communicable and infectious diseases and has co-authored research papers in both areas. Mr. Bundy has extensive experience in strategic information and health system strengthening through services to the National HIV Program and now at the Caribbean Training and Education Center for Health, which is a PEPFAR implementing agency. Dr. Kunal Lawane. Kunal is fine. He is a senior resident in the Department of Psychiatry at the University of West Indies Hospital, and he is completing his Doctor of Medicine qualification in psychiatry. He has worked in the field of psychiatry for the past 10 years in the parishes of St. Anne, Kingston and St. Andrew, and has a special interest in substance use disorder. Ladies and gentlemen, put your hands together for our next two presenters.
Good afternoon. I'll be presenting on the assessment of treatment outcome for PLHIV on first-line ART. So the Ministry of Health started the rollout of TLD as the preferred line of ART for persons living with HIV in 2019. Previous to that, the first line of care or treatment was an efavirenz-based regimen. Now, the need to have a potent, tolerable, and a low pill burden drug for first-line ART is on the basis of the limited regimens that are available. First, second, and third, and then that's it. So it's important to prevent failure on first line to prevent persons from progressing to requiring second and third line ART. The ministry used this study to inform their transition of persons on TLE and other first line regimen to TLD, which started in 2021. So the benefits of TLD that inform the decision or make it a better option of treatment for persons living with HIV who are on first line is that comparing to other regimen, it shows to be more potent, suppress viral load more quickly, and has a greater increase and a faster increase in CD4 count. The TLD is more durable. It features a high drug-resistant barrier than NNRT-based regimen and have fewer side effects and greater patient tolerability. So there were previous studies that were done comparing DTG-based regimen to other first-line regimen. The single study was the only one that matched both efavirenz and DTG-based regimen as two different first-line options directly. You had other studies that included other regimen available for treatment of HIV. Now, based on all of that and the importance to have a first-line ART regimen that will prevent transition to the other lines, we started to look at the outcomes of persons living with HIV who were started on TLD between 2018 and 2021. The objectives of the study was to describe the proportion of patients achieving virological suppression, which is less than 1,000 copies per milliliter, on their first viral load test after initiation of TLD compared to other first-line regimen. We also wanted to describe the proportion of patients who experienced treatment failure within a 12-month period after starting ARVs. The method that we used was a retrospective cohort study where persons starting ART between January 2018 and January 2021 was recruited into the study, or data from TSIS, that's the National Treatment Database for persons living with HIV, was the data source for this study. We included persons 15 years and older at ART initiation, were on first-line ART, and had at least one viral load after starting ART in the time period that we are discussing. Now, the sample was decided from a total of 3,176 persons that started ART within that period. After further exclusion, we went down to 2,798 patients who started ART with a viral load result in that period. After further selection, we saw where we ended up with 230 persons being eligible on TLD and 266 persons being eligible on TLE. The data was analyzed using SAS 9.4 and Excel, and chi-square and frequency methods were used. Now, when we look at the data, we saw where we had more males on TLD and also on TLE when compared to females. When we look at the 10-year distribution by age group, we saw where the 25 to 34 age group had the most persons for both regimen, followed by the 45 to 54 age group for both regimens as well. Distribution of health region by regimen, we saw where most persons on TLD were from the Southeast region, and also for TLE, we had 152 persons making up the large amount of persons on TLE. Now, when we disaggregated by first CD4, we saw where we had most persons having a CD4 of greater than 350 for both TLE and TLD. We had, followed by the persons who had results less than 200 for both TLD and TLE. When we look at viral suppression at first viral load results, we recognize that there wasn't any difference between what was indicated in the landmark study. 86.1% of persons on TLD were suppressed, and 81.6% on TLE were suppressed with no significance. When we look at viral suppression in terms of the levels, whether undetectable, low viremia, suppressed or unsuppressed, we saw where most persons on TLD and on TLE were suppressed to undetectable levels. One thing that stood out was that persons on TLD experienced low viremia, and that was significant with a p-value of 0.03. When we look at viral suppression in terms of sex, we saw where for TLD we had, or for males, we had more persons suppressed on TLD than TLE. For viral suppression with age group, we saw where for TLD we had more males within the 45 to 54 age group, which had a p-value of 0.06, which indicate that that was significant. When we look at by regional health authority, there was no significance between TLD and TLE there. When we look at by CD4 count, we saw where persons with CD4 less than 200, meaning they were diagnosed at AIDS, had a achieved suppression at first viral load result on TLD when compared to TLE. The significance there was 0.02. For treatment failure, the results, how we categorize treatment failure was 2 consecutive unsuppressed results within a 12-month period. We had a lot of missing data for those on TLD due to the short time span of the study when the TLD rollout was initiated. However, we saw where we had more treatment failure on TLE than TLD, and the significance there was 0.03. When we look at switching of regimen between TLE and TLD, we saw where more persons on TLE had to switch regimen, 8% switching to second line and 10% switching to another first line, when compared to TLD with 1% each. So in conclusion, viral suppression findings from local population is similar to the landmark studies which indicated non-inferiority or superiority of TLD to TLE. Based on what we saw, we can say that TLE might have greatest impact among males, among adults 40 to 44, patients in the Western region, and patients with a CD4 count of less than 200 at baseline. We also want to note that TLD might be associated with persistent low viremia based on the findings. And that's it. Thank you.
Good afternoon, everyone. Thank you for that introduction, sir. Today, I will actually be doing 2 presentations that will be examining the impact of substance use on driving behavior. My first presentation We're just waiting for it to load. We'll be driving intoxicated, which involves an analysis of alcohol use and driving behaviors amongst the Jamaican population. So just waiting for it to load. Thank you. So for those in the virtual space, I hope you can follow. This topic involves the use of two variables. So to be able to understand the connection of these two variables, that of alcohol use and driving behaviors, it's important to recognize each variable on its own merit and what the statistics show us. So with regards to alcohol use, the most recent World Health Organization report indicated that the alcohol use amongst Jamaicans had increased by double over the preceding 4 years. In fact, a recent paper by one of our panelists at this conference, Mr. Andrew Bourne, highlighted that during COVID pandemic, alcohol use had increased by almost 50%. With regards to the driving variable, I recall reading an article recently where the motor vehicle insurance segment highlighted that there was an increased payout of about 10% during COVID-19 pandemic. And of course, that which our road safety unit has indicated to us that there is an annual increase in the road traffic fatality rate over the past 5 years. When I wrote this presentation approximately 2 weeks ago, the road fatality rate number stood at 384. And in this week, sadly, that number has increased to 401. That tells us that in a span of less than 2 weeks, we have seen an increase of 17 additional road fatalities. And so we look to the international literature to help us understand the association between these two variables. What that suggests to us is that unequivocally, all the studies highlight a similar finding that the use of alcohol impairs driving skills. It does so by impairing the reaction time. It also impairs your attention span, and it also increases your risk of driving fast or speeding. And so if you recognize the impact, you can see that certain sequelae will occur, including 1, increased motor vehicle accidents, 2, increased legal risk, 3, an elevated impact on the insurance segment, 4, an elevated impact on our health resources, and 5, an avoidable burden on family, especially if there's a loss of life. So this really provided the impetus for us to look at this topic. Our objective was to examine alcohol consumption patterns, socio-demographic factors, and the risk of dependence and its impact on our drivers. We conducted a secondary analysis of the Jamaica National Drug Prevalence Survey, which till date remains the largest national survey on drug use patterns in Jamaica. 4,623 participants were selected across the length and breadth of Jamaica through all 14 parishes to participate in a face-to-face interview. And from that data, 1,060 vehicle drivers were identified. That represents almost 25% of the population. And so what did these results show? Well, that 75% of the Jamaican population at some point would have used alcohol at any point in their life. And that 65% of drivers admit to also being an alcohol consumer. Of these drivers, 1 in 5, that's almost 20%, admitted to driving under the influence of alcohol. More alarmingly, however, is that of these drivers that admit to drinking under the influence of alcohol, 55% admitted to being a heavy user. That means they're using 5 or more drinks on one occasion before they even think about making a decision. And perhaps even more staggering is the fact that those who drink under the influence of alcohol, almost 40% also admitted to drinking under the influence of cannabis. Our results suggest that driving under the influence of alcohol is more likely amongst males, amongst the head of the household, those of a non-Christian affiliation, and those individuals who operated machinery as part of their job description. All of our survey participants were asked to complete the audit questionnaire. Now, this is a validated alcohol dependence tool that is used worldwide in many literature. And our findings highlight, expectedly, that those who drive under the influence of alcohol were more likely to develop alcohol addiction than those who did not. But it also interestingly suggests that drivers on a whole were more likely to develop alcohol addiction than non-drivers. And so we put our results to an even more stringent analysis and ran a logistic regression model to identify, elucidate the risk factors and protective factors for driving under the influence of alcohol. And our results suggest that male drivers under the age of 35 who were the head of household were 2 to 3 times more likely to drive under the influence of alcohol. And this was statistically significant. With regards to our protective factors, those who were Christian, those who were married, and those who were earning less than $50,000 per month were less likely to drive under the influence of alcohol. So if you remember nothing else, I want you to remember this, that 1 in 5 drivers admitted to drunk driving, and that of those who admit to drunk driving, 50% admitted to being a binge drinker or heavy alcohol consumer. And more alarmingly, that 40% of those who drive under the influence of alcohol admit to also driving under the influence of cannabis. So a very obvious or observable point from our study was that the most vulnerable group are young men who are the breadwinner of their home. And one of the most important things to realize is that we've seen that persons who are heavy users or use multiple substances, that there's a dose-dependent relationship with the impairment of driving. What that simply means, if you use more, you're going to have more driving impairment. And so what this study, in conclusion, allowed us to realize is that it fills a knowledge gap. This represents perhaps, well, definitely the first study in Jamaica of its kind and in the Caribbean. And studies on driving under the influence are very limited in even international literature. It catalyzes the need for further research. We are aware that the Road Traffic Act is to be determined and decided upon, but these results highlight the fact that there's an urgent need for the amendment to be passed. In certain countries, in China and in the United Arab Emirates, other interventions that have been found to be useful are the use of insurance incentives or even telematic technology. Because in a collaborative effort, it has been found that these factors play a big role in reducing the impact of driving under the influence. Thank you.
Very good, very good. Put your hands together for them again. They spoke to the importance of those treatment regimes in the HIV situation, persons living with AIDS, as well as the 2 variables. Very important study for Jamaica. So at this time, we're going to ask for any questions to our presenters. Go ahead, Doctor.
Good afternoon, everyone. Dr. Alonge from Northern Caribbean University. I have questions for the presenters. Thank you so much for your excellent presentation. I noted here that the TLD is a combined drug which has the ability to reduce viral load. Is that true?
Yes.
Okay. Now, when you compare both, there was no significant difference or there was a significant difference?
Repeat the question.
Was there a significant difference when you compare the
Viral
Yes.
suppression on TLD versus TLE?
Yes.
No, there was no significant difference.
So both of them were effective?
Yes.
And both of them are combined drugs?
Yes.
Which one is readily available in Jamaica?
Both are readily available. Per WHO guideline, the ministry has started transition of eligible clients on first line to TLD because of the limited side effect of TLD.
Okay, thank you. That is important because I wanted to ensure that I catch it and I know what you're saying. Thank you. Then the next person, thank you, Dr. Lawani. Yes. For those under influence, you talked about the fact that, so making the drivers more comfortable, making those who drive, especially I'm thinking right as you were presenting, I was thinking about those I see every day. They smoking the ganja, they drinking the drink, and they driving, all right? Right at the same time. You see them if you take public transport. That's the first thing they do in the morning. So are you suggesting from this study that if they get some level of incentive, that could modify the behavior?
Level of incentive?
Yes.
That can modify the behavior?
Yeah, if they get some level of incentive that could change their behavior. Like you talk about the insurance, you mentioned in other countries. I'm saying if we do that in Jamaica, bringing what we see in other countries based on your presentation, will that also assist in modifying the behavior?
Yeah. Well, that's something that we have to actually determine. The truth of the matter is that things like alcohol and marijuana and substance use, there's a very strong cultural fabric in terms of where these uses would have been inherent in our society. What needs to be evident, though, is that you have to think about what are some of the changes that you can make that will help to mitigate this. I've heard persons talk about personal responsibility, and personal responsibility is an individual characteristic or trait where an individual says, well, I'm going to make better decisions. However, if we were to depend on that, we probably wouldn't see some of the rates that we're currently seeing in terms of the road fatality numbers. So it now begs to us to look at it from a different perspective. Personal responsibility in collaboration with other areas. One of the things I think about is the 3 Ps approach. Personal responsibility, which is the individual characteristic trait. 2, the policy, that the legislation helps to protect or guide when someone decides what their personal responsibility will take them to. And then 3, what some of the private sectors, such as the insurance companies, in terms of providing incentive, can help to de-incentivize persons who will drive under the influence. So I give you an example. You mentioned about someone driving on the road and smoking. I've seen it. Imagine someone leaves a party. Personal responsibility, 5 friends. One says, I am the designated Dan. I am the person who will not drink tonight, and I will drive 4 persons home. They decide to leave the party. They're driving on the highway, and say somewhere along the way, there was a policy where you were stopped. You were subjected to a breathalyzer test for both alcohol and cannabis, and you were found that you were stable. Good, no problem. But what about the other person who's coming the opposite direction, who probably has not taken that same decision, is intoxicated, and lo and behold, there's an accident. So you realize that at some point, had that person been stopped by the legislation or the policy in place, that accident may have been prevented. If you think about it now from a private sector organization, there have been some studies and some insurance incentives where they have said, you know what, we're going to create a database. When a person creates a road traffic violation, in that database, that same database is shared with an insurance company where they can see who the individuals are that may have broken the law. So when now you decide to go and get your insurance premium, there's an adjustment that will either incentivize or de-incentivize your insurance payout or premiums. And so it's almost as a form of an aversion therapy that you know that, hey, guess what? If I'm in that database, it is very likely that my insurance premiums might go up. And so therefore, I might not be able to afford it. Or that if I don't want my insurance premiums to go up, I'm going to think twice about drinking before I drive.
Okay, ladies and gentlemen, this brings us closer to the end and to the end of this session. For all my four wonderful presenters, I want to hear it from them, from you, for them. They have been wonderful. Thank you very much. My name is Everton Baker, and I am out. Thank you. But my friend is saying, hold it. I am holding it to hold on to it.
Mr. Baker, we want to just say thank you. Thank you for supporting our Health Research Conference and your continued support of the activities. This is a token of our appreciation. Thank you.
We were given a mandate to provide
Viking. Just now. Take a chip, take a chip, take a chip, take a chip now. Hey, shake it, shake it, shake it, shake it, wow. We are the sound of 100,000 coming on the road. We are the vibration that you feel when the music loads. We are the mud and the oil and we come the dirty of the clothes. Hey. I made the girl them wine and strike the electric pose. Hey. Take a chip, take a chip, take a chip, take a chip now. Hey. Shake it, shake it, shake it, shake it now. Hey. Take a sip, take a sip, take a sip, take a sip now. Pango dip, pango dip, pango dip, pango dip now. Hey. I swear we are the sound them selectors play every day, making you sway. And when the girl them tell and shadow dingole, I hear the soul talk say, hey.
Amongst us, in our homes and close to the food we eat, live some mysterious, tiny, yet extremely energetic creatures. Much smaller. These are microorganisms, extremely small living beings. There are 3 different types of microorganisms. The good ones help to produce foods and drinks such as cheese and yogurt, fermented meat, and fermented vegetables. Some other microorganisms are annoying. These are the bad ones. They are responsible for the foul smell, bad taste, and repulsive look of rotting food. But they normally don't cause diseases. But it's the other kinds of microorganisms that we really need to be afraid of. They don't cause food to smell bad, and they don't change the way it looks. They are the dangerous ones, and it's necessary to be very careful with them. These are known as pathogenic microorganisms, and they can cause severe illnesses such as stomach pains, vomiting, diarrhea, fever, and even death. They're deceitful, invisible, and dangerous. These tiny beings are very, very prolific. To increase in number, they need food, water, time, and warmth. They can multiply very quickly. Fortunately, no matter how strong and frightening these microorganisms are, they are preventable and vulnerable. It takes as little as 5 simple rules.
Good afternoon. Welcome to the 7th session, the final session for the day. Thank you for all of you for being here, those who are here in the physical space and those of you in the virtual space. I'm Dr. Kevin Goldburn, Director of Mental Health and Substance Abuse Services, the Ministry of Health and Wellness. And having said that, then you know what, I'm very intrigued to lead this session on substance abuse. So our two presenters are as follows. Mrs. Vanessa Williams-Tyndale, she's currently an MPhil candidate at the University of West Indies, Mona. Her research interests focus on identifying and highlighting possible therapeutic approaches for the treatment of chronic illnesses. Mrs. Williams-Tyndale's current research focus is on the hyperglycemic effects of cannabis sativa. She's a researcher who focuses on diabetes research. And as you know, diabetes is very prevalent in Jamaica, so I'm sure this research will give us some insights as further innovation in the control of diabetes. Then we also have heard from Dr. Lalwani, who I must, as we were reintroduced, because he's my younger colleague, and I'm very pleased to say that he is venturing in the field of substance abuse, which is very dear to my heart. So look forward to his presentation. So Ms. Williams-Tyndale will present to us the effects of extracts from various strains of cannabis sativa on blood glucose concentrations in the normal glycemic Sprague-Dawley rats. I've heard of those rats before. And Dr. Lalwani will present on driving high, a secondary analysis of cannabis use and driving in Jamaica. Please make welcome Mrs. Vanessa Williams-Tyndale to do our presentation.
Good afternoon. I would like to thank the Ministry of Health and Wellness for providing me the opportunity to present my research findings today. Now, the title of my research is The Effects of Extracts from Various Strains of Cannabis Sativa on Blood Glucose Concentration in Normoglycemic Sprague-Dawley Rats. My name is Vanessa Williams-Tyndale. Now, diabetes mellitus is commonly referred to as sugar in our Jamaican dialect. It is a chronic disease of the endocrine system, which is characterized by hyperglycemia, resulting from the body's inability to use blood glucose for energy. Complications of the disease include failure of the kidney, heart, and blood vessels, among others. Diabetes can be classified into many categories, of which 3 are my main focus. And those are type 1 diabetes, also known as juvenile onset diabetes, type 2 diabetes, which is the most prevalent and has accounted for 90% of all diabetic cases, and gestational diabetes, which results from a pre-existing undiagnosed type 1 or type 2 diabetes. There are also many tests which can be done used in the diagnosis of diabetes, And the one of focus for this presentation is the fasting blood sugar test. Now, a reading of 126 milligrams per deciliter or above is indicative of a person with diabetes, while a reading of 99 milligrams per deciliter or below is a normal blood sugar reading. Now, over a 30-year time period, the number of individuals who were diagnosed with diabetes has quadrupled. Between the years 2000 and 2016, there was also a 5% increase in premature mortality resulting from diabetes. Diabetes prevalence has also been rising more rapidly in low and middle-income countries, of which Jamaica has seen an 11.6% prevalence of diabetes, totaling over 200,000 cases of diabetes in adults. Now, what then is the solution to our diabetes epidemic? Well, one such solution which can aid in the prevention and treatment of diabetes is herbal folklore. Traditional remedies have been widely used in the diagnosis, prevention, treatment, and management of many illnesses. And the reasons for this include affordability, cultural practices, and fewer side effects, if any. The plant, cannabis sativa, or what we know as ganja, has been traditionally used for its many properties, including its hypoglycemic properties. Now, ganja is an established folk medicine in Jamaica. Common preparations of the plant include soaking the buds or leaves in rum for the relief of a stomach ache, among others. The leaves of the cannabis sativa plant contain what we know as phytocannabinoids, of which 2 are of significant importance. And these are delta-9 tetrahydrocannabinol, also known as THC, and cannabidiol, CBD. Now, THC has been widely known for its psychoactive activities, while cannabidiol has been known for its medical and therapeutic properties. Now, the potency of cannabis is normally evaluated based on its THC concentration. Studies have, however, been done to show that CBD may be capable of antagonizing some of the adverse effects which are related to THC. What then is the justification for this research? Well, chronic diseases and complications are the leading cause of death and disability in the Western Hemisphere. By the year 2045, we are projected to have affected over 700 million people due to diabetes. There is therefore a great need to investigate the use of herbal remedies, which are used in common folklore practices to determine their medicinal properties. Our aim? To investigate the effects of extracts from various strains of cannabis sativa on blood glucose concentrations in normal glycemic rats. Our objectives? To obtain crude hexane, ethyl acetate, and methanol extracts from cannabis sativa strains that's CBD to THC 1:1, 10:1, and a 1:10. From this, we can determine the effects of extracts on blood glucose concentration in normal glycemic Sprague-Dawley rats using the oral glucose tolerance test. We will then be able to compare the effects of these extracts on blood glucose concentration. Our methodology. Now, the stems, leaves, and buds of the dried plant were milled into a finely grounded material. This was then weighed, followed by a sequential extraction using 3 organic solvents, and those are hexane, ethyl acetate, and methanol. These were done for 2 8-hour periods, followed by a 24-hour period. After this, the respective filtrates were pulled together, dried, and concentrated using a rotary evaporator. The procedure was repeated for the various strains. Following this, we did the oral glucose tolerance test. 30 healthy Sprague-Dawley rats were collected from the animal house at UWI. The animals were fasted overnight for a period of 12 hours, after which their fasted blood glucose concentration was monitored. The plant extracts measuring 50 milligram per kilogram body weight were dissolved in dimethyl sulfoxide for IV administration, or 200 milligram per kilogram body weight dissolved in corn oil for oral administration. The blood glucose samples were then taken at 30 and 60 minutes post-extract administration, and following this, a glucose load was administered. The blood glucose concentrations were measured for an additional 2.5 hours at 30-minute intervals, and a graph of blood glucose concentration versus time was plotted. The data was expressed as mean plus or minus standard error of the mean, and statistical analysis was done using the SPSS version 20 software. Variations in the results was analyzed using a ANOVA test, and post hoc analysis was carried out using Tukey and Games-Howell test where appropriate. Now let's take a look at the results. If you turn your attention, this is graph 1, which shows us our E1 strain, and that's CBD to THC in a 1-to-1 ratio. Now let's turn our attention to the orange curve. The orange curve shows us our control, and this shows that what a normal glucose tolerance test should look like. Now, following extract administration, there is a slight increase in the blood glucose concentration. After the administration of our glucose load, there is a sharp increase followed by a decrease at the 120 minutes, and this is due to the action of insulin. Now, the purple graph, which is shown at the bottom of the graph, is our E1 hexane extract. This, in comparison to the control, showed significant hypoglycemic activity at the 120 and 180 minute interval. Graph 2 shows us results from our E2 strain, and that's CBD to THC in a 10-to-1 ratio. Hypoglycemic activity was noted for our hexane extract. However, none of these values were statistically significant. Graph 3 depicts our E3 strain, and that's CBD to THC in a 1-to-10 ratio. There were blood glucose lowering effects noted for our hexane extract, however, no areas of significance. Graph 4 shows us a comparative analysis of all our hexane extracts. Results indicated blood glucose lowering effects for all strains, with E1 showing the most significant activity. Graph 5 is a comparative analysis of our ethyl acetate extracts, indicating hypoglycemic activities for our E1 strain. Graph 6 is also a comparative analysis of our methanol extract, of which none have indicated any blood glucose lowering effects. Graph 7 depicts results showing oral administration of our hexane extract at 200 milligram per kilogram body weight. Results indicated blood glucose lowering effects for all hexane strains, with the most significant being our E1 hexane strain at the 120 minute. What then do these results mean? Well, our crude hexane, ethyl acetate, and methanol extracts were obtained from various cannabis strains, and the effects of their extracts on blood glucose levels, as measured in normal Sprague-Dawley rats, showed both hypoglycemic and hyperglycemic activity. The hexane extract for all cannabis sativa strains indicated lowering of the blood glucose level in comparison to other extracts. Our hexane extracts obtained from our CBD to THC 1-to-1 showed significant hypoglycemic activity both upon oral and IV admin in normal glycemic Sprague-Dawley rats. This indicated that CBD, working in tandem with THC, results in a lowering of the blood glucose level in comparison to when CBD is higher. Our ethyl acetate extract obtained from E1, that's CBD to THC 1-to-1, also demonstrated significant lowering of the blood glucose level. Other ethyl acetate extracts displayed no lowering of the blood glucose level. Our methanolic extract also demonstrated no lowering of the blood glucose level, but instead showed an increase indicating hyperglycemic properties. In conclusion, the plant species Cannabis sativa has significant potential in the treatment of diabetes mellitus. The resultant effects of a CBD to THC 1-to-1 strain, lowering blood glucose levels, indicated that a combination of these phytocannabinoids may have a greater potential of assisting in the treatment of diabetes. Results not only supported the use of natural products as a treatment for diabetes, but also highlights the potential for cannabis sativa as a possible treatment option. Thank you.
Okay, so good afternoon, everyone, again. So now I'll be presenting, sure. Yes, thank you. Okay, everyone, so now I'll be presenting the second presentation this afternoon, and it is entitled Driving High, and involves an analysis of cannabis use and driving behavior in Jamaica. And so similar to the study I did on alcohol, we must treat each of these variables in isolation to understand its impact. A previous study that would have been done in Jamaica would have highlighted that approximately 30% of the population at some point would have indulged in cannabis use. When you think about the impact of decriminalization, recent studies conducted, at least in the United States, where decriminalization of marijuana, legalization of marijuana, or medicinal cannabis laws have been implemented, they have found at least 3 significant findings from their studies. 1, an increased use of cannabis. 2, the increased access to cannabis use. And 3, an increased report of cases of driving under the influence of cannabis. And so, appreciating that, we already recognize that with our driving variable, that which I had reported in the previous presentation, that our road safety unit reports that the number is approximately 401 and is likely to outpace the 487 road fatalities of last year. Also, I want to just highlight that a publication that was done by 2 distinguished professors here in Jamaica, Professors Archibald MacDonald and Newton Duncan, approximately in the early 2000s, highlighted that of all the road traffic accidents that presented to the University of the West Indies emergency room, 50% of victims actually tested positive for cannabis. And so, again, we must look to the literature to understand how the substance use, including cannabis, cause an impairment in driving skills. As I previously mentioned, it impairs the attention, it increases the risk of driving fast, and of course, it also affects the depth perception of the individual in terms of their visual acuity while driving. So, understanding the circumstance of driving impairment, one can see, again, the impact: increased motor vehicle accidents, increased legal risk, an elevated impact on the insurance segment, an increased impact on our health resources, and the avoidable burden, the emotional toll, and the financial toll on the family, especially if there's a loss of life. So again, these were the premises that drove the impetus to conduct this study, in which we examined cannabis consumption patterns, prevalence, socio-demographic factors, and the risk of addiction and its impact on vehicle drivers. And similarly, we utilized a secondary analysis of the Jamaica National Drug Prevalence Survey, and what was highlighted as previously is that 1 in 4 persons, approximately 25% of individuals, identified as a vehicle driver. Now, what did our study show with regards to the cannabis use? Well, that almost 24% of persons who were current users of cannabis who also drive were, well, vehicle drivers. And of those persons who drive, almost 44% admitted to driving under the influence of cannabis. But not just driving under the influence of cannabis, because 90% of these individuals also admitted to being heavy users. That is, persons who use daily or almost daily. And similarly, almost 50% admitted to also driving under the influence of alcohol. Akin to our alcohol study, 9 out of 10 were male, the majority were the head of household, and the majority were young, under the age of 35, and operated machinery as part of their job description. All of these persons were asked to complete a cannabis-dependent survey, a screening tool, and our findings were quite formidable. In fact, 52% of drivers who did not think cannabis was harmful were found to be addicted to cannabis. And 30% of drivers who did think cannabis was harmful were still nonetheless found to be addicted to cannabis. So what is the take-home point? That drivers more than likely have not understood the harm of cannabis use and intoxication, and so will be unlikely to understand its impact on driving behavior. Again, a logistic regression model highlighted similarly that male drivers under the age of 35, who were the main head of household or breadwinner, were the ones that were more likely to drive under the influence.
And those persons who were employed, married, or had at least a tertiary level education were less likely. So listen up. Take home this fact. 2 in 5 drivers who currently smoke cannabis admitted to driving under its influence. Why is that important? 50% of these drivers also admitted to driving under the influence of alcohol. Now listen, cannabis and alcohol co-use is associated with a 5 times increased risk of a vehicle crash, but a 25 times increased risk of a fatal car crash. And in a previous study done here, we have already identified that 1 in 5 persons are a polydrug user. That indicates a higher risk cohort of driver. So what is also important from this particular cannabis study is that persons were also individuals that operated machinery as part of their job description. And there have been numerous studies that highlight the increased risk for injury or accidents in the workplace because of cannabis intoxication. And similar to alcohol use, I cannot emphasize this point more. Heavy use, there's a dose-dependent relationship. More use, more substance equals more driving impairment. So, what do these 2 studies do cumulatively? They fill the knowledge gap. They invite further research because there isn't much. But in particular to cannabis, what it also advocates for is perhaps a change in the legal policy. Perhaps it asks us to consider driving under the influence of cannabis as part of our legislation. It also looks to an intervention that has been implemented in other countries. Do you know the same test that you will use, a breathalyzer for alcohol concentration, they have developed one that allows you to test for THC concentration at the roadside. And if you are found to be above a legal limit, it calls for a repercussion. So, overwhelming point, as I had already indicated in a previous presentation, there's a need for early and comprehensive marijuana intervention program. In this study, what we realized is that drivers don't understand the harm. And if they don't understand the harm of cannabis, then how will they understand the risk of on-driving behavior? Something for us to all think about. Thank you. Before I leave, just 2 things I want to say, my gratitude and acknowledgements. 2, to Professor Wendell Abel and Professor Everard Barton, 2 massive mentors of mine. They've been very supportive, big motivations, and have always given me a reason to conduct research. I thank you. To my friend, Mr. Graylin Fraser, he is an excellent statistician and a colleague who helped me with the data analysis of this report. To my family, both here and abroad, thank you. And never last, my wife, Shalini, I appreciate all that you have done in your support. Thank you, everyone.
Thanks to both Mrs. Williams-Tyndale and Dr. Lalwani for such engaging presentations. So please give a round of applause for them. Are there any questions in the audience? Or yes, Ms. Dawson, Dr. Dawson.
Good afternoon. Thanks very much. Both 2 good, excellent presentations. But a question re the Driving and the Road Traffic Act that's being looked at presently.
Hello?
Yes, I think you mentioned that the Road Traffic Act is being looked at presently.
If it includes cannabis?
No, I'm asking, I think in your first presentation, you mentioned that they were looking at the Road Traffic Act. It's being looked at presently for changes or adjustments? That's what you had said?
I mentioned in the first presentation that the Road Traffic Act was currently under review.
Right, being reviewed.
Right.
So all of what you presented, will it be taken into consideration for the review?
Say that again?
Will the information that you just gave us, will it be taken into consideration for the review?
Road traffic accident, if what you're presenting will be taken into consideration, are you presenting to them?
Oh, well, can I be honest? When I was doing the results for this study and I realized that some of the results were quite alarming, I started to look at some of the literature overseas in countries that had actually done some of these new laws with regards to cannabis use. And so it wasn't intended that I should speak to any particular body, but what I've realized is that there is a message in the literature or in the findings that it is probably something that we need to consider and probably highly consider, because the numbers are suggestive that we should do. But I wasn't really thinking about trying to approach any particular body.
Well, I must add to that being at the policy level, we definitely want to see your research and scrutinize a bit more. Sure. At policy level, we'll want to see what we can do to try to get it involved in the Road Traffic Act.
Of course, sure.
And in addition to that, Doc, thank you for that excellent presentation. That is why we do presentations, okay? Right now you're here at the Ministry of Health Annual Research Conference. So when this research is over, there should be a take-home from here that this ministry, the chair sitting beside you right here, is to be a voice as well that will take it up higher for policy. It is very critical at this time. There are things we know, and I remember the minister will say he's looking for data, he's looking for data. Here is data. Can we put our hands together? This is data, so at the same time they can look at this. They can add to what they're doing right now and begin to do the roadside testing. Let's put our money where our mouth is. Thank you.
Okay, thank you very much. I see two hands there. Dr. Crawford.
Okay, so in response to the question, the Road Traffic Act. The Road Traffic Act does make provision for blood tests to be done. In the case of a DUI, if it is that a person refuses a breathalyzer test or in doubt of the result from a breathalyzer test, then the Road Traffic Act makes provision for a blood test to be carried out. In addition, I wanted to point out that some years ago, a research was done looking at the ketoacidosis in the breath of someone who may be diabetic or not. And so the breathalyzer test is not able to tell the difference. And the person who may not be under the influence of alcohol but happen to be diabetic could be charged for DUI when that is actually, the person was not drinking alcohol because of the ketoacidosis in the breath.
Thank you for that contribution, Dr. Crawford. I have a question for Dr. Williams-Tyndale. What are the next steps, given the findings from this animal study? What are the next steps are you thinking about?
Okay, so based on the methodology that we carried out, we use the stems, leaves, and buds of the cannabis plant. So the next steps would be to separate all three parts of the plant and then to test it on the rats. Also, for the strain that shows the highest level of activity, we would have to do more in-depth study on that to see just what particular compounds were present in the plant to cause lowering of the blood glucose level.
So about a while longer before we can do animal study, human study, right?
Yes, but I will let you know so you can be my first subject.
A quick question as a follow-up. When she was presenting, there was something that came to mind. If it is true, and I agree with what you have done, that it lowers the blood sugar. Is there a possibility that those who use cannabis, that ordinarily they're just taking something that could also lower their blood sugar without them knowing that it is affecting them? Would that also lead to the behavioral modifications that we see among those who use cannabis?
That's a good question. It's something that I can look into. If the usage of cannabis, even though it is smoking, and what we did in this study was unworse. But that's something I can look into.
All right, thank you.
And just to add to that, actually, a lot of cannabis smokers, even though sugar may go down possibly, but they tend to eat more. So probably they won't suffer from hyperglycemia. Are there any questions from virtual space? So there are no more questions, so it leaves me to just really express our gratitude to Dr. Lalwani and Ms. Williams-Tyndale for their very brilliant presentation. And I know that we need to build upon those presentations to get more information so we can have more concrete actions. But thank you both. Please give a round of applause as we show their gratitude.
Before you go, Dr. Golson. Sorry, Dr. Goldburn. We just want to express our thanks. One thing that we know about Dr. Goldburn is that he always supports our conference, and we do appreciate that. And I think that he would be the perfect moderator for this particular presentation that had focused on substance abuse. And so, once again, Dr. Goldburn, we just want to thank you, and we hope that you will continue to support this activity.
Definitely. Thank you very much.
And we have come to the end of a second day of really wonderful presentations. And we want to thank our moderators. We want to thank our presenters for submitting the research to be presented at our Health Research Conference. Before we close, we also want to give a special presentation today because there is one of our judges working assiduously behind the scenes, but she will be working but not in person tomorrow, and we really want to acknowledge, every year we acknowledge our adjudicators who really journey with us in terms of being there and reviewing all of the oral presentations. So it is really a large task, and we do appreciate it. We also have to say that we have a family of judges, and so at this point in time, I want to acknowledge Mrs. Karen Nelson, who not only is in the process of judging our oral presentations, but also played a role in terms of the adjudication of the abstracts that were selected for oral presentation over these 3 days. So we really want to recognize her, and so we are giving her this token of our appreciation.